didn't require any introduction. So I welcome him. Kindly come and use your words.
Good morning, friends. It's immense pleasure to be here again. This is third time the Cardicon is going to happen, and we at Fortis Hospital Department of Cardiology try to make it more interactive, and that how it will be impacting the common man, the general practitioners, as well as having the interesting factors, what is the new development in the cardiology. So we'll try to keep the discussions what is pertinent to your clinics when a cardiac patient comes. Like the topics, if you see that as you already know that the morbidity and mortality is quite high in India for the coronary artery disease as well as the hypertension tops of all of these things. So we have kept the first topic for hypertension, then dyslipidemia and heart failure, which are common things, and few topics for that recent advancement in intervention cardiology. Now as you know that organ donation, and it's immense pride to say that we have been accredited for heart transplant also. So we have kept few topics where we get a knowledge that in what kind of patients, it's not that end of life. If a patient of a heart failure is not supporting, not being taken care by the medicines, then we now have a possibility of up to going for the heart transplant, lung transplant. You have heard about that lung transplant during COVID era, but after that the heart and lung transplant has significantly increased in the numbers in India. But we are lacking in North India particularly for these things. So we have tried to keep the kind of topics which are more pertinent to the cardiology and for the basic care of the patients, and everybody should know basics of all these things. And thank you for giving us the opportunity to discuss all these things. Now I invite Dr. Jha to start the session.
Thank you, Dr. Goel, Dr. Chawla, Dr. Bhatia, Dr. Naveen for the wonderful talk. Now we're starting the scientific session, and for this we have got two young ladies. They will be conducting the scientific session, Dr. Ambika Modi and Dr. Vanna Bhuvna. So I invite Dr. Ambika Modi to start the first session. Thank you.
A very good morning to all of you for the Academy session of Cardicon 2025. The first topic is hypertension from basic to best practice. I would like to invite the chairpersons for the session, Dr. Bimit Jain. Sir is Senior Consultant Cardiologist, Jaipur Golden Hospital. Our next chairperson is Dr. R.M. Chabra, sir. Sir is Founder President, NDPF and Senior Consultant Physician, Max Hospital, Shalimar Bagh. Our next chairperson is Dr. Sapna Jain. She is Senior Ophthalmologist at Narang Eye Clinic and Arhant Eye Clinic. Our next chairperson is Dr. Jagdeep Bansal. Sir is HOD Neurology, Fortis. Okay, Jagdeep Bansal, sir. He is HOD Neurology, Fortis Hospital, Shalimar Bagh. No, there is a chairperson. Now I will ask the chairpersons to kindly invite the speaker for the today and announce the topics and introduce the speakers.
Good morning, everybody. First of all, I must thank Dr. Naresh Goel for giving me an opportunity to interact with all of you. And the slides, please. Excuse me? Please connect it. Yes. Slide change it. नहीं चल नहीं रही सर चल नहीं ये चल नहीं रही थोड़ा सा चेंज करना नहीं पॉइंटर तो है पर चल नहीं रही ना. नेक्स्ट स्लाइड पे. Yes. As you know, hypertension is a silent killer. And we are aware of this thing for the 6th century before Christian era, when Shashrath, father of surgery, he felt that certain patients bled more and certain less under his scalpel blade. So it means there was something inherent. The pressure must have been high in these patients. And it was William Harvey in 1600 who described the cardiac circulation, that's from the left ventricle to aorta and to the veins and to the right ventricle. And this was the first description which is holding true today also. Then first description of the hypertension measurement was done by Stephen Hales in England, when in 1727 he directly measured the pressure of the blood pressure of the horse with the cannulation of the carotid artery. And father of nephrology, Richard Bright, he described that certain of his kidney patients, they used to have hypertrophy of the left ventricle. So it means there was some inherent connection between the kidney disease as well as the heart. And of course, at that point in time in 1800 or so, there was no BP instrument to measure the blood pressure. So, but he came to this conclusion, there is something inherently working between the two organs. And Laennec described the stethoscope in 1820 in France, and the sphygmomanometer was introduced by Rivarossi in Italy in 1896. He engineered it, and his friend Cushing, the one who is famous for Cushing syndrome, he took it to America, and there it became quite popular. And it is Russian medical student at the age of 31 years, Nicholas Korotkov. He described the technique of blood pressure measurement, reported in less than 280 words, which made him immortal in the medical history. And we use his method of measuring blood pressure today also. And surprisingly, in 1931, despite all these innovations, the greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. So this was James Hay, a professor of medicine in Liverpool in England, in the British Medical Association. He was giving a lecture. So this is the state of affair in 1931, and now we know that he was absolutely wrong, and this is 180 degrees. We even try to treat even the slightest degree of hypertension. 3-bit. The Churchill, the English Prime Minister, the Roosevelt, the President of US, and the Stalin, during the Third World War, they met to decide about the war and its post-war conditions. But the physician of Stalin did not allow him to travel far off, and the Roosevelt also was hypertensive, and then they decided to meet in the city of Yalta, beautiful beach city in the north of Ukraine, where all the big three met. And Admiral Rose was taking care of President Roosevelt, and he was mentioning it, but after exactly 1 month of this meeting, President Roosevelt died of cerebral hemorrhage. So there was something wrong with it that they came to know about it, and the Admiral Rose, he did not present his data. He said it has all been lost, whereas the President's friend, Howard Bruin, he gave his own diary to give the blood pressure, and it was found that during this meeting of Yalta, the blood pressure of the President used to be more than 200 millimeter of mercury, and which was not taken care of at that time, and this was the reason for his cerebral hemorrhage. And exactly a couple of years later, Stalin also died of cerebral hemorrhage. He had left cerebral hemorrhage subcortical, and then everybody started taking care of the thing that something is giving way because of this blood pressure. The cerebral arteries give way, and they produce the hemorrhage. Then the research really started in the field of hypertension to control the stage where we are. Thank you. Now we will invite Dr. Saurabh Bagga to give his presentation.
Welcome Dr. Saurabh Bagga. He is the Additional Director in Cardiology in Fortis Hospital, Shalimar Bagh, and he is having more than 10 years of experience and is a graduate from IGM-MC, postgraduate from BJMC Ahmedabad, and super specialty from UN Mehta Institute of Cardiology, and has performed more than 10,000 procedures. I welcome Dr. Bagga.
Screen, please. Screen, please. A very good evening, good morning to our delegates, our faculty, our chairperson, IMA, and Fortis Hospital. So, as sir told about the first diagnosis of the blood pressure, now where we are standing. So, initial the labeling the disease as a hypertension and where we today in hypertension. We'll see today. So, we'll see the accurate measurement, diagnosis of hypertension, and newer guidelines about the blood pressure, which has labeled the blood pressure as a elevated blood pressure and hypertension. So what is the blood pressure? It is a heart which pumps the blood through the arteries, and the pressure exerted by this blood on the walls of the arteries is known as blood pressure. So there is a pathology behind this elevated pressure and blood pressure, that is where different etiology, that is genetic factors, behavior factors, renal mechanism, neural mechanism, vascular, hormonal, environmental, socio-economic, and psychosocial factors. So we all know about it. There is different mechanism behind the development and increase in the blood pressure. What is about the organ, and what is blood pressure if it is elevated? It leads to the damage to the organs of the body, and this blood pressure related damage is called as hypertension mediated organ damage, and it affects the eyes, leading to hypertensive retinopathies. Brain, generally we do a CT scan, we found that there are some white matter lesions, silent microinfarcts, microbleeds, brain atrophy, cognitive impairment, and vascular dementia. This all related to the hypertension. So we should just do not ignore this finding on our imagings. We should check the blood pressure in such patients also. The large and medium arteries leads to the vascular calcification and arterial stiffness. In microcirculation, there is a fibrosis and inflammation. There is an increase in peripheral resistance. If you see the kidney, there is a leading to the glomerulosclerosis, proteinuria, decrease in GFR. If you see the heart, there is the LVH, dilatation of the chamber, AF, obstructive and non-obstructive coronary disease, diastolic and systolic heart failure. So this all is because of the elevated blood pressure. We see some terms in the blood pressure, what we routinely use, that are the systolic BP, and that are systolic BP, that is the onset of the, that is the maximum BP, that is upper one, that is the onset of the, is measured at the onset of first quarter of sound. Different kinds of instruments are available for the measurement of the blood pressures. There is the oscillatometer devices, Android devices, and we can do the intravascular monitoring also for the blood pressure monitoring. The other terms like the diastolic BP is measured the BP during the diastole, that is when there is a complete disappearance of the cortical sound, that is the fifth sound, it is called as a diastolic BP. Or when sometimes it not disappear, the muffling sound is continued, then the fourth sound should be considered for the diastolic BP. Interarm difference we should measure in both the arm, and it should not be more than 10 mmHg. What about the postural and orthostatic hypotension? How we measure the postural and orthostatic hypotension? So you measure the blood pressure at the rest, lying or sitting position, and then after standing in 1 minute and 3 minutes. If the BP falls, systolic BP falls more than 20 and diastolic more than 10, then it is labeled as an orthostatic hypotension. Other term, that is a white coat hypertension, is the BP which is high in the office but it is below the threshold level at the home, is called the white coat hypertension. About the mask hypertension, the BP is low in the office but it is high in the home. This is called the masked hypertension. And what we routine do, that is office BP, that is a clinic, is called the clinic BP, what we measured in the routine in the clinics with the automated machine or with a blood pressure machine routinely. Other term is the home BP measurement. Nowadays, we should tell each and every patient to measure the home BP, and it is called home BP measurement. This is out of office BP at the home, measured by the patient by a device. Ambulatory BP measurement. So now we have a devices which can measure the blood pressure for 24 hours in a patient who has in an interval who has high risk for hypertension and not had a diagnosis, or treatment and management and optimization of the drug. So what is new in our guideline in about the hypertension? So what till now we label blood pressure as a normal pre-hypertension, hypertension. It's now changed to non-elevated BP, elevated BP and hypertension. There is no term which is called normal blood pressure, because there are some differences between the genders and all, and the baseline blood pressure may be 90 in some females and all. So the terms now is labeled as a non-elevated BP, not the normal normal BP. And if you measure this, how we divide this in three groups to the patient. So non-elevated BP, elevated and BP and hypertension, by doing the various measurement of blood pressure at various devices and various times. So we should measure at office BP, home BP, daytime ambulatory BP monitoring, 24 ambulatory BP monitoring, and nighttime ambulatory BP monitoring. So if you see the levels, which was we labeled routinely that your BP is 140 is normal, nothing to worry, it's not like that. So we have to see newer guidelines which have changed these levels, and it is now non-elevated BP is less than 120/70 if the patient visit at the office BP, and if he measured at the home, it should be also below 120/70. What about the ABPM? So in ABPM it should be average less than 115/65, and the night BP should be less than 110/60. So these are the very important readings which we have to remember and monitor our patient and give the treatment. A newer term which is called the elevated BP. This is very important to see and terms and measure the BP, which we routinely measure the BP sometimes little bit higher, but we ignore that. So it's not like that. Now the term elevated BP is there, which has measurement at different times. So if you see, if the BP is 120 systolic to 140, it's come under elevated BP. And it's diastolic between 70 to 90, it's come under the elevated BP. So in home BP, its value is 120 to 135 and 70 to 85 diastolic. If you see the ABPM monitoring, it will be 120 to 135 and 70 to 85, similar to home BP. But the 24 average is less, that is 115/60 by 130/80. So if the average blood pressure should be in this range, then it is called elevated BP. The nighttime BP is low. Every person has a blood pressure low at the night time and should be below 120, 110. If it's between 110 to 120 or 60 to 70 diastolic, then it's come under the elevated BP category. And hypertension is office BP more than 140/90, home BP more than 135/85, daytime BPM 135/85, 24 ambulatory is 130 to 80, and night time is 120 to 70. So this table is very important, because many patients comes and they say that my BP is a home by 130, 140, we ignore them and we don't try to evaluate and treat them. So it's not like that. We should monitor the patients and evaluate it even in elevated blood pressure. So if the patient come with a high blood pressure, when to screen, whom to screen, and how much time and what to do. So if any patient come with a non-elevated BP less than 120 to 70 and it is more than 40 or less than 40, if the less than 40 years, should measure every 3 years his blood pressure. And if more than 140, it should be measured, screening should be measured at least a year. About the new group, that is the elevated BP. If the BP is between 120 to 140 and diastolic between 70 to 90, you should not ignore this group of patient. You should evaluate this patient with seeing the other conditions, CVD is score 2 or OP, which is more than 10% or 5 to 10%, and according to that we have to treat the patient. So if elevated BP is there and there is risk factors, confirm the BP by home BP or ambulatory BP and it's persistently elevated, then you have to treat that. Similarly, hypertension, if the patient comes with the BP 140 to 160, confirm with the home BP or ambulatory BP before starting the treatment to rule out office to rule out the white coat hypertension or mass hypertension before it. And if the home BP is also elevated, you should try to treat that patient. Even in the first time patient come with the 160 to 80, it's not jump to treatment, just first evaluate the patient, confirm that his BP within the, again check within 1 week to 1 month, and if persistently elevated, then you need to treat that patient. If the BP is more than 180, 110, definitely it's urgency, you should start the treatment. So what was new in guideline, I was saying that elevated blood pressure group, which is now very important, because if you start early and treat early, you will prevent the hypertension mediated organ damage. So any patient come to you with BP of 120 to 140 of systolic and diastolic between 70 to 90, you should be evaluated. It's not ignorable that your BP is near range, it's okay, sometimes it's elevated. You should see the patient whether he has the elevated cardiovascular disease, established cardiovascular disease, or CKD, or hypertension mediated organ damage. If it is there, then you should start the lifestyle measurement, and if between 3 months the BP doesn't come down, you need the requirement of the pharmacological therapy, and it should be less than 130 by 80 to be a target, and between 120 to at least nearby 120 by 70. And if the patient is diabetic and less than 60-year-old, again lifestyle measurement and start the therapy if it's not improved within 3 months. What if the patient has just elevated BP and doesn't have any factor? So it's not like that the patient comes to you, you see the BP is 135 or 140 and you go tell him that to go, it's not any problem. You have to mark each and everything in your paper. You should evaluate the risk factors. So what kind of risk factors you should see in such patient?
Dr. Sir, be brief, please.
Yeah. So 10-year predicted CVD risk should be evaluated, and then should be calculated. If there is between 5 to 10%, you should calculate the risk modifier, that is a socioeconomic depression, autoimmune, severe mental illness, HIV is there. If it's not there, you should see the sex-specific risk factor, that is gestational diabetes, gestational hypertension, preeclampsia is there. Even if it's not there, you should evaluate it by the test like calcium scoring, carotid femoral plaque, high sensitivity troponin, antibiotin, and pulse wave fatigue. So if any risk factors is there, you have to label in your sheet, and if there is risk is present, you have to treat this elevated blood pressure. So about the measurement of blood pressure, so it should be, patient should be come to your screen, it should be waited for 5 minutes before taking the blood pressure. You should not talk with the patient and do not move around the patient. It should be properly seated for 5 minutes. Avoid the caffeine, exercise and smoking before 30 minutes. Empty his bladder before making the blood pressure. Nor observer should talk during the rest period or during the measurement. Remove the clothing in which arm you are measuring the vapor. And the BP cuff should be proper 80% of length and 40% of width according to arm circumference. So office BP measurement, yes, patient should be seated for 5 minutes, validated device, and BP cuff should be at the level of the heart. Measure the BP 2 times. That is 1 to 2 minutes apart, and if there is difference more than 10, repeat it again. Measure BP in both the arm in first visit, report for the postural hypertension, measure and write the heart rate at which you had measured the blood pressure, and assess for the orthostatic hypertension. Home BP measurement, yes, again sit it for 5 minutes, obtain 2 readings, obtain reading twice a day, and it is for 3 to 7 days, and record it and show to your clinicians. And if more than 135/85, maybe you need treatment. Ambulatory BP monitoring, yes, it is a device which measures BP every interval 15 to 30 minutes, and its reading should be minimum of 70% usable BP recording should be there, and a diary with the activities, whether the drug is taken, when to sleep, when he is walking or doing exercise should be labeled there, and that should be correlated with her blood pressure monitoring as we seen in the previous chart. So we will not go in detail due to time concern. So there is a disadvantage of ambulatory monitoring, that is expensive and affect the sleep. While home BP monitoring, there can be error during the measurements because of poorly calibrated devices, and nocturnal reading can't be measured. What the routine test should be done along with the blood pressure, if the patient come with the blood pressure, high blood pressure. Yeah.
Summarize.
Yes. So these are the basic tests which should be measured, and it should hypertension, modern organ damage should be labeled by evaluating these different kind of tests. Few words about the resistant hypertension. That if more than 3 drugs are required to control the hypertension, including the diuretic, RAS inhibitor, calcium channel blocker, and the BP is still less than 140 when we are doing exercise, it is called a resistant hypertension. The pseudo-resistance should be ruled out, and if the patient has CKD, diuretic dose should be optimized. If patient is on target dose with the 4 medication, it's called control resistant hypertension, and even in increase with the more than 5 drugs, it's called refractory hypertension. Last few words about the secondary hypertension. It is a blood pressure
Summarize,
caused to
please,
secondary
summarize.
disease. So this is the last slide. So we have to see the secondary hypertension to rule out if the patient comes to your clinic, see the potassium levels, they rule out the primary hypertension by measuring the aldosterone-renin ratio, confirm with the renin and aldosterone ratio at the renal vein sampling. Renovascular hypertension should be done with the imaging. Phenochromosoma, obstructive sleep apnea is very important to rule out, to measure, rule out the hypertension. Renal parenchyma disease, that is a CKD, Cushing syndrome, thyroid disease, hyperthyroidism and coarctation of aorta, and any anti-cancer drugs he is taking should be ruled out to label as a secondary hypertension, particular treatment of that. Thank you.
Thank you, sir. If any questions, we'll take up in the end of the session. I would like to invite Dr. Nitin Agarwal, Director, Interventional Clinical and Critical Cardiology and Electrophysiology, from Sir Balaji Action Medical Institute with 15 years of experience. He's this. So, yeah. Sir will speak on one size doesn't fit all practical drug choices in hypertension.
Good morning.
Stick to the time.
I see. Okay. Good morning, sir. Ladies and gentlemen, I am Dr. Nitin Agarwal from Action Balaji Hospital. Respected chairpersons, and thanks Dr. Naresh Goyal, sir, for inviting me and give the topic, one size doesn't fit all. As we all know, hypertension is one of the most common worldwide disease affecting humans because of the associated morbidity and mortality associated with it. The prevalence of hypertension is increasing rapidly among developing countries, where poor hypertension treatment and control contribute to the growing epidemic. But why to treat hypertension? This is very important. As we all know, it can cause target organ damage starting from eyes, brain, kidney, heart and peripheral arteries. Even asymptomatic patient with hypertension greater than 140 should be treated. Normal blood regulation is controlled by heart, kidneys and blood vessels. By the relation of blood pressure is equal to cardiac output into systemic vascular resistance. These all 4 parameters are regulated by these kidneys, RAS inhibitors, cardiology, heart system and then sympathetic nervous system. So all antihypertensive act via transferring these normal mechanisms. So recommendation for management of hypertension, non-pharmacological measures should be started like DASH diet and exercise. Exercise has a very important role in control of hypertension, like yoga interventions including postures, breath control and meditation have been shown to significantly reduce SBPs and DBP in the pre-hypertension group. Please give, what is this slide? As by non-pharmacological measures, by reducing weight, we can reduce BP by 5 to 20 mm of Hg per 10 kg weight loss. By DASH eating plan by almost 10 mm Hg, dietary sodium restriction by 2 to 8 and increased physical activity by 4 to 9. Reducing alcohol consumption also reduces BP by 5. So these non-pharmacological measures should be taken care of while starting the therapy. Host of drugs are there for controlling the blood pressure. कभी पेशेंट पूछता है कि हमें ब्लड प्रेशर बढ़ाने की कोई दवा है, बढ़ाने की कोई दवा नहीं है, घटाने की हमारे पास दुनिया भर की दवाइयाँ हैं. So we have to take care कि all antihypertensive drugs should be taken care of. And these are some of the newer drugs and the old drugs as well, classic drugs. Calcium channel blockers, these are divided into 3 groups, phenylalkylamines, benzothiazepines and dihydropyridines. We are commonly using DHPs because of the second, third and fourth generation drugs. CCBs are divided into DHPs and non-DHPs. Diltiazem and verapamil, these both drugs usually cause decreased ventricular contraction and heart rate. So they are usually used for arrhythmias and angina, not for hypertension per se. But yes, DHPs are the cornerstone and the mainstay of the therapy with amlodipine and cilnidipine for the hypertension. This slide is very important as all DHPs, first generation, second generation, third generation, fourth generation. Third generation and fourth generation drugs. Amlodipine comes under third generation and cilnidipine comes under the fourth generation. These two drugs are the mainstay which are almost all antihypertensive patients are taking. Look at these things. These both cause less of the tachycardia and edema. Cilnidipine almost cause nil or none edema as compared to amlodipine, while other drugs can cause flushing, headache and tachycardia. These classification is made on slow onset, longer duration, higher vascular selectivity, higher lipophilicity, and less sympathetic excitation. So less tachycardia with these two groups of drugs, third generation and fourth generation groups. Beta blockers, we all know, they are firstly outdated as antihypertensive, but the recent beta-1 selective and beta-2 selective like carvedilol are the mainstay. These are particularly used for asthma, diabetes mellitus and peripheral vascular disease. This is a consensus statement initiated by Dr. J.C. Mohan and group Jamshed Dalal, and in which there is an Indian consensus. They are all experts with a greater than 20 to 25 years of experience with active participation in previous guidelines. Look at this slide. Importance of beta blockers in the management of below mentioned conditions like hypertension. Hypertension with tachycardia. Almost 100% of patients should be given beta blockers. Hypertension with diabetes 70% and MI and AF almost more than 90%. Presence of beta blocker in adults. Nebivolol is now the drug of choice in beta blocker group with 95% tolerance. In patients with hypertension and diabetes angina, almost bisoprolol, nebivolol, greater than 90% patients are using. In COPD, nebivolol, almost 95% patients. RAS inhibitors, as we all know, ACE inhibitors and ARB. हर patient telma जरूर खा रहा होता है, telmisartan, because it has very renoprotective and cardioprotective effect, and it reduces BP by something. So, as mentioned, ARB is in preventing hypertension-mediated organ damage and MACE. All factors like LVH, atherosclerosis, MACE, metabolic disease, diabetes, they all have positive effects of ACE inhibitors and RAS inhibitors. Telmisartan has more than one benefit, like it improves in insulin sensitivity. So diabetic patients should be given ARBs. Because of auditory PPAR, gamma agonistic activity, it improves vascular inflammation, reduces visceral fat, and increases adiponectin. Yeah, this slide is important. Now we use olmesartan and telmisartan. Olmesartan has a slightly better BP control as compared to the telmisartan and losartan group, as shown by the blue and the red diagrams, bar chart. So olmesartan is slightly favorable in comparison to telmisartan in BP control. Diuretics. All diuretics usually potentiate the effect of other antihypertensives. So, अगर कोई amlodipine ले रहा है, if he adds low dose diuretics, it usually potentiates the effect of amlodipine as well. These are the pathway in which all the diuretics add. Thiazide diuretic is the first choice of drug in mild hypertension, like chlorthalidone or hydrochlorothiazide. But loop diuretic should not be used as a first line drug. Lasix कभी भी first line drug use नहीं होता. In uncomplicated cases like CHF, CRF or mild fluid retention. Yes, Lasix should be given in cases of CHF or CRF with fluid retention cases. This is a comparison between CTD and hydrochlorothiazide, which shows almost they have taken more than 13,000 patients. The patient randomized to CTD experienced similar blood pressure control to patients remaining on hydrochlorothiazide at 2 years. So CTD and hydrochlorothiazide don't have major difference between them in case of blood pressure control. Second line drugs like prazosin, terazosin, doxorubicin has been used by reduction in PVR, but they cause marked postural hypertension, so should be used cautiously, and they are not used as the first line agents. Centrally acting agents like methyl-dopa and chlorhydrin are used in resistant cases in which we can't control by first line drugs. Vasodilator, again hydralazine, and they are usually causes reflex tachycardia and salt and water retention. Minoxidil, yes, the minoxidil now mainly used for alopecia, not as antihypertensives. Newer drugs in hypertension management. Can we identify him? He is Lawrence Block. He gives the definition of serendipity. look for something, find something else, and realize that what you have found is much more suited to what you need than what you thought you were looking for. Actually, ये एक serendipity has, SGLT2 has been discovered as an anti-diabetic drug, but now it has been used in failure drugs as an anti-hypertensive drug. The mechanism by it can lower the BP by hemodynamic mechanism, diuresis, nitriuresis, salt sensitivity. So anti-hypertensive, if the patient is borderline diabetic or non-diabetic, we should add SGLT2 inhibitor in a low dose. But I can't substitute, but there is no recent trial to prove this. Similarly, these can cause pre-diabetic and high normal BP. SGLT2 inhibitor has been initiated for reducing the cardiovascular outcome. ARNI has also similar effect, but no trial support. It should be only used for the anti-hypertensive indication, in spite of preserved EF or the low EF. Monotherapy versus combination therapy. We should, why consider for initial combination therapy? As shown by this diagram, when we add a drug for another class, the BP reduction is markedly better as compared to when we increase the dose of the similar drug. So all the groups, when we add another group of drug, the BP reduction is much more as compared to the taking the drug to the maximum tolerated dose. This guideline also emphasizes that starting monotherapy in most patients with two drugs, not one. Monotherapy is usually inadequate therapy for most patients with hypertension. This is the meta-analysis of more than 10,000 patients from 42 trials, which also shows addition of an anti-hypertensive agent from a different class is 5 times more effective than doubling the dose. It is published in American Journal of Medicine. Initial monotherapy and combination therapy has also controlled during the first year also. They have improved cardiovascular outcomes in terms of two drug combination. This can be shown with the pie diagram, but cardiovascular mortality favors combination therapy as compared to the monotherapy. This is the Lancet SPIRIT trial, in which strict control and intensive control and standard control, they have shown a markedly almost greater than 2-digit decrease in the heart attack, stroke, revascularization procedure, 39% decrease from cardiovascular causes and 25% decrease from any cause. They have taken two arms. In the intensive arm, they have reduced the BP by less than 120 and the standard arm by 130. So they have shown this type of benefit. The combination also improved adherence and compliance, as can shown by improving discontinuation of antihypertensive therapy. What is the guideline recommendation? Initial combination therapy is especially useful in the context of lower BP targets. Single pill combination improved to adhere tolerance and to be used in most of the patients. This is the diagram, recent 23 guidelines. We should start with ACE, ARB and calcium channel blocker with thiazide or thiazide light diuretic, followed by, if the 90% control, 2 resistant hypertension. Beta blocker can be added at any stage.
Dr. Nitin, can you summarize, please?
These are the 4 landmark trials, exactly, ma'am. INVEST, all had scope and accomplished. They have shown almost 25 to 50% requirement of 3 drugs.
Time.
So my key takeaway points: hypertension has been long deemed as a silent killer, is a major risk factor of stroke and myocardial infarction. The value of 130/80 should be achieved as much as possible. Lifestyle changes with weight loss and increased activity are cornerstone. Most patients require 2 or 3 drugs for blood control. 50% of patients may require 1, 65% 2, and 75% more than 3 drugs. ACE inhibitor, ARB, beta blockers are the mainstay. Heart failure with hypertension. Always try to first achieve maximum dose of all 4 drugs before adding calcium channel blocker. That is SGLT2, ARNI, MRA and beta blockers. In diabetes, ACE inhibitor with SGLT should be started. Beta blockers, as per the recent guidelines, have essential piece in the management. In CKD patient, ACE, ARB preferred if the potassium permits. Second line drugs are often needed in resistant hypertension. Hypertension should be aggressively treated with multi-pronged approach starting from lifestyle modification. So health is the crown on a healthy person head with good BP and blood pressure control that can only ill person can see. Thank you.
Question will be taken at the end of the session. So once you have the diagnosed case of the hypertension, now comes to the tailoring of the hypertension care, especially in the coronary artery disease or the chronic kidney disease and the stroke patients. Now I invite none other than Dr. N.N. Jha. He will tell us about the tailoring of the hypertension care. He is a principal consultant internal medicine and reporting hospital Shalimar Bagh. He has done the MBBS from the Patna Medical College and Director of the Good Health Clinic, Shastrinagar, and President of the Northern Physician Forum, and Patron of the Bihar, Jharkhand Medical Forum. It is very important, I think. Now, over to you.
Thank you, Dr. Chawda. Such a nice words. And all the chairpersons. Thank you, sir. My topic, before I start, I have two stalwarts, young stalwarts, Dr. Bagga and Dr. Nitin has given lecture. My task has been slightly easier by Dr. Nitin. So, tailoring hypertension care, CAD, CKD and stroke. Why this topic? Because there are three conditions, especially it's called special situations, like kidney, CVA, this thing, in pregnancy, in elderly patients, in diabetes, these are all there, but these three, CVA, CKD and stroke patients, that can be the secondary to the hypertension. So that is very important, but I will talking others is a topic like hypertension special situations. So hypertension has a customary to have some few words about the hypertension. The most important chronic disease risk factor. Estimate burden is about 200 million persons with prevalence of about 22% by data of 2023. Recent studies have shown that hypertension is increasing in India with rapid increase in rural, which was not earlier, and young population. So our younger population is suffering from hypertension at a very early age. Major adverse event hypertension like CAD, CKD or cardiovascular accidents may exist or could be the result of hypertension. But other special situations just contribute to the complications of the hypertension. So as we all know, and it was told by Dr. Bagga, this thing, lifestyle modification is the foundation of BP management. So that is very, I will not go into detail. It will be dietary modifications, weight management, it has come in a big way. With the newer drugs are coming, GLP-1 analogs, injectables, physical activity, stress management is also very, very important. And finally, alcohol and smoking cessation. There are major factors in having the hypertension. So we stop the smoking or the alcohol consumption, things may improve. So what are the lifestyle measures? There is in a cartoon, healthy diet, regular exercise, less salt. Dry salt means about less than 4 grams in 24 hours. This is required sodium chloride. Limit alcohol. Less than 4 grams means you should avoid the table salt. Otherwise, salt, chutney, sausage, these things are very strong. Achar, they have a large amount of salt. So that should be avoided. And the normal you can have in this.
You have to speak louder.
Chale?
Speak louder.
Louder. So salt should be less than 4 grams, which can be used in the pulses or the sabjis, which may not be harmful. So that is lifestyle modification. That is the first cornerstone. Management of hypertension, CAD, CKD and CVA. That is my main topic. It involves personalized treatment plans based on specific health problems, comorbidities, age and lifestyle. While standardized guidelines exist with the AHA, ACC or NICE or SPREE trials, all they have guidelines given, but a customized approach essential for optimal BP control. Optimal BP control and reducing the risk of complications like heart attack, stroke and kidney disease. So it's very important, it has to be tailored. So how do you customize? First we have to see what is your target BP. That has to be established first. Now what are the first line drugs? If it does not control hypertension, the first line drugs, what are the additional agents one can use? And what are the drugs to avoid which can cause complications or maybe other side effects. So that is the criteria of customization of treatment. So hypertension, coronary artery disease, why it is important? Hypertension control, because if there is hypertension, it accelerates atherosclerosis, which may lead to CKD, increases myocardial oxygen demand, may lead to plaque rupture and thrombosis leading to the heart attack. Increased risk of MI and sudden cardiac death if the BP is very, very high. Left ventricular hypertrophy and heart failure are the complications if the blood pressure is very high. So if you lower the BP, the risk of recurrent MI, angina and heart failure decreases as well as improves the survival. So what should be target BP with all the recommendations and guidelines? Target BP should be less than 130 by 80 millimeter of mercury. That should be our target. And first line drugs, we all know, beta blocker is very important for the CAD. It reduces heart attack, that is very beneficial in cases of CAD. Oxygen demand is also reduced and also prevents arrhythmia. As we all know, beta blockers are one of the anti-arrhythmic drugs. ACE inhibitors and ARBs, they are also very useful. They improve atrial dysfunction as well as reduce the cardio modeling, so chances of heart failure is less and heart is not damaged much. Administration agents which can be used are dihydropyridine CCB, as Dr. Bagga said. It is used for the angina also. Thiazide diuretics, if more control is required, it is not controlled with the beta blockers and calcium channel blockers. And avoid excessive BP lowering in stable conditions. If you reduce the blood pressure is very, very low, that may cause the complications, may have some other problems. So that's why CAD management is there. Now the second part is hypertension, cerebrovascular accidents. Why is important? If the hypertension is there or high BP is there, is the strongest modifier risk factor for stroke. So if you control hypertension, stroke incidence will be less. It also promotes small vessel disease and electron infarcts. So blood pressure has to be controlled to avoid this infarcts and small vessel disease. It also causes atherosclerosis, as is the heart of carotid as well as intracranial arteries. And it is a risk of both ischemic and hemorrhagic stroke. So blood pressure can cause hemorrhagic stroke also with the rupture of the vessels, as well as it can cause by clotting in the vessels ischemic. So both can be done maybe more if there is a high blood pressure. So what is the target BP? In primary prevention, somebody who doesn't have any attack or vascular accidents, target is like any other, less than 130 by 80 milligram mercury. And preferred drugs are ACE inhibitors and ARBs. If not controlled, we can add the thiazide diuretic. As Dr. He said, first choice is not loop diuretics. Thyroid diuretic is the first choice in case of any hypertension. And it reduces the first stroke. So that's why it is called primary prevention. So doesn't have any severe incidents earlier. It can be prevented with the control of blood pressure. Of course, other measures like lipid control, diabetes control are also important. But hypertension is one of the major factors for the CVA. In acute stroke, BP rises acutely to maintain cerebral perfusion. So BP is very, very high in these cases, acute stroke, and Dr. Bansal is there, our neurologist and HOD in Fortis. If candidate is for thrombolysis, one has to see whether the patient, if it is infarct, if the candidate is for thrombolysis, then lower BP to less than 185/110 of Mallory before thrombolysis. So it's very, very important. This figure has to be kept in mind. BP less than 185 systolic, 110 diastolic should be there before giving the thrombolysis treatment. If not candidate for thrombolysis, avoid aggressive lowering unless BP is more than 220 systolic and more than 120 diastolic. So very important, if the patient is candidate for the thrombolysis or not, that's very important. And one thing is very, very important, has to always keep in mind that there has to be gradual reduction, that is less than or equal to 50% first 24 hours recommended if very, very high. So that is very important. It should not be sudden restriction like giving nifedipine sublingually or antihypertensive drug. Secondary prevention, that means the person who already had a episode of CVA, of cerebral accident, target BP is for secondary prevention less than 130 by 80 milligram mercury. And some individuals, if somebody individual is elderly or is frail, we can compromise for the higher BP also. So that is not hard and fast rule, but ideally should be less than 130 by 80 milligram mercury. Preferred regimen, ARB and ACE inhibitors are very, very important. They have helped in this thing. Plus, if not controlled, we can use the thiazide diuretics. Calcium channel blockers, if still not controlled, for the additional control, we can use these things. And in severe secondary prevention, lifestyle measure has a key role. Like earlier I told you, salt restriction, weight management, physical exercise, extra has to be there, like stress management, yoga, other things. They also aim to control the blood pressure, leading to secondary prevention. Then the third part was coming the chronic kidney disease. Why hypertension is important in kidney disease? Because hypertension itself contributes to progressive kidney damage. So hypertensive kidney damage is very, very common, and a lot of people, young people, they are getting this CKD because of the high blood pressure. What is the mechanism for having the CKD in the case of hypertension? There is a RAS activation, renin-angiotensin system activation, which leads to glomerular hypertension. Then there's sodium retention, which leads to volume overload, which can also cause the kidney disease. Vascular calcification of the kidney vessels and stiffness. Proteinuria. Proteinuria is very, very important. Is a marker as well as mediator of the progression of CKD. So we can, if there is a proteinuria, we can think of the CKD, or maybe in the kidney disease of different stages can happen. So one has to be very, very careful and would be alert if there is a proteinuria. So what is management? Again, target BP is 130 by 80 milligram of mercury. That is the Kate Daigo 2021. There is a trial, you can say, or we can, the organization which gives the guidelines for the kidney disease. So Kate Daigo 2021, they said should be less than 130 by 80 milligram of mercury. First line drugs are ACE inhibitors, ARBs, very, very important, especially in proteolytic CKD. It reduces albuminuria and it slows progression. It's not halt the progression of nephropathy, or you could add some diuretics. Add-ons are diuretics, thiazides. If GFR is less than more than 30, we can use thiazides. If it is less than 30, loop diuretic is the thing. So CCV is useful. BT blocker, another 1 2 minutes. This is a summary. I will not go into detail. So other special situations in brief: hypertension pregnancy. There is 4 types of hypertension pregnancy: chronic hypertension, gestational or pregnancy-induced hypertension, preeclampsia with chronic hypertension, transhypertension. Safe drugs are methyldopa is the first choice. Labetalol and nipocaline can be used. Contraindicated drugs, ACE inhibitors, ARBs should not be used. It can cause the fatal distress.
Summarize, please.
But just one. Hypertension elderly, orthotic hypertension, you know, ISH is very common elderly. Preferred drugs are thiazides and calcium channel blockers. J-curve phenomena, you all know, increased cardiovascular risk of BGV is too high or too low. Diabetes, I will not go into detail because it's a separate topic. Target is less than 130 by 80. Drug of choice, ACE inhibitors, thiazides and beta blockers, and MRAs. Emergencies, acute pulmonary edema, hypertensive clefopathy, acute aortic dissection, severe eclampsia. This can be managed with immediate intervention with the IV antihypertensive therapy to reduce the BP urgently. Otherwise, things may go wrong. So, what is the take-home message? Management hypertension must be tailored and customized to special situations. Requires a multidisciplinary approach for safe and effective control. Goal is to reduce morbidity, mortality, and improve quality of life. So, final words are: there should be a right drug, right patient, and the right situation for the control. Thank you very much.
Thank you, Dr. Jha. Final comment for the chairperson and 1 or 2 questions from the audience. Only one.
I request the speakers please come on the stage. Dr. Nitin, please
I
come.
just want to add few points in that. One is the tight control of the poor control of blood pressure leading to cognitive decline and dementia has been extensively studied, and it has been found that if the blood pressure is controlled better, then the cognitive decline and the dementia chances are reduced. And with that, sometimes we see the patients are having white matter lesions in the brain, and the patient is asymptomatic. But in those patients, it is found that they are having hypertension, and that's why the target blood pressure should be less than 130/80. And this is very important for the general population to take care of that. And secondly, for the younger people, young strokes and young cardiovascular diseases are prevalent, they are prevalent, and the reasons behind that is not apart from other lifestyle and other things. It has been studied that nighttime blood pressure and the fluctuations in the blood pressure because of lifestyle, because they are working in a place where they are having a lot of stress in the workplace, and they are not getting the blood pressure checked there. And once they are coming to a doctor and getting the blood pressure checked, that is the time where they are relatively relaxed. So the time where they are stressed, that is the surge of blood pressure and leading to the cardiovascular mortality and the stroke also. That is very important to understand. And there was an article in Stroke where it was said the blood pressure is a symptom or a disease. There was a big debate because in one of the initial part it was said to lower the blood pressure is a foolishness. It exactly to some extent this is true, because the acute blood pressure rise is because it is a response of the body to ischemia in the body, any organ of the body which is ischemic. So body prevents that by raising the blood pressure. But if the blood pressure is remaining high, that is damaging the other organs. So the initial part, the blood pressure should not be treated, but later on definitely that should be lowered down to prevent the end organs. But meanwhile, we have to look for the, if we can see, is there any ischemia in any of the organs. And apart from the renal, I think the mesenteric arteries are one which are the area which is most ignored, and the disease of the mesenteric artery or the ischemia of the bowel is maybe the reason for the hypertension where the cause is not known. Thank you.
Sir, just in continuation of the, very well said, sir. And I think the dipping is very important. Nighttime dipping of the blood pressure as well as the heart rate. Because we usually see the early surge in the early morning hours of the CVAs and MIs. Because we need early morning rise dipping of the blood pressure, the dippers and non-dippers. In the case of non-dippers, the incidence of MI and CVA are much more as compared to the dippers. So dipping in the heart rate as well as the BP are very important.
Yeah. Thank you, Dr. Naseer. End of the
I
session,
just want
please.
to say what Dr. Saurabh has already told. See, the guideline has changed that normal blood pressure or non-elevated is 120 by 80. And above 140 by 90 is not being labeled as a stage 1 or stage 2. So all hypertension has been merged. That's what the new guideline of 2025 has come up. So we should treat hypertension above 140 by 90 with multiple drugs, as Dr. Nitin has already discussed about. The combination therapy would be the better. And in the group class they have told that in ARB which sartan would be better, and the calcium channel blocker and diuretic. So it's preferably to give 2 drugs in a combination if BP is above 140 by 90.
Final comment for the Dr. Sapna. Final comment.
Please, sir, wants to some ask.
I would just add, like on a ophthalmologist point of view, when we see cases of nocturnal hypertension, there is an advancement of glaucoma. So we are mostly, we only refer, but if there is any guideline on this also for us.
It's not, basically it's guideline on depending on the hypertension retinopathy rather than on glaucoma. But any drugs preference in the glaucoma is there, but it should be choice of the drug if there is patient is in glaucoma for the treatment of hypertension. That's a mention.
Sir, what is the blood pressure is very, very important because the 24 hours monitoring is done.
Yeah.
And
So that's what the now the recommendation is. It's better to give an ambulatory BP monitoring so that you can avoid the mass hypertension as well as the white coat hypertension.
Yeah, what is the drug which is more suitable for those patients where the BP fluctuation is more in glaucoma patients particularly?
The variability is calcium channel blockers are preferred medications. They decreases the blood pressure variability.
And the frequency of antihypertensive, either it should be OD or BD dose or something else, night dose. Yeah.
It depends on your ambulatory BP monitoring readings. If there is non-dippers are there and there is a high BP in the early morning and such, then the dosage should be changed according to the night time.
Dr. Arora.
What is the drug of choice in a young person, or male or female, in 20s, 25 years, seeing the sexual dysfunction caused by some drugs? What is the drug of choice?
If he or she can be controlled with a single drug, RAS inhibitors, ACE inhibitors or ARB should be the initial treatment. Probably he will not be controlled by the second drug. The second drug should be the CCBs, either in the form of the amlodipine or cilnidipine. And beta blocker should be added when the patient is tachycardic or there is some other comorbidity.
Beta blockers should be avoided. You are taking some sexual dysfunction.
But if anxiety element is there or the tachycardia is there, then the beta blocker could be helpful in this patient.
Say that they are very anxious and palpitation and heart.
So this
Beta blocker will be helpful, but can you other?
As Dr. Jaideep told, it's a cause or effect. If anxiety is the cause of high blood pressure, probably we need to reduce the anxiety. Beta blocker may help in these things. But if it is it's a high blood pressure, as Dr. Nitin has told, the RAS inhibitor and the calcium channel blocker would be a preferred medications.
And what is the ideal time to take the antihypertensive drug? Seeing the early morning, rise, what is the ideal time?
Usually, sir, night time or evening time is preferred as compared to the morning time because we want dipping and avoid the early morning surge of the blood pressure. So night time, or it can be a BD dose in the form of the morning and the evening dose. If the single dose is required, the evening dose should be prescribed.
Thank you.
Thank you. Thank you. Thank you very much. Give the big hand, please.
I will request all the speakers and chairpersons to proceed toward the felicitation area for the felicitation. And I will ask Dr. Abhishek Kumar to felicitate them with Dr. Bhatia sir.
Next.
Okay. Starting with the next session, which is cardiology outreach, I would like to invite the chairpersons, Dr. Sandeep Garg, he is HOD Forensic Medicine, BJRM Hospital, Dr. Manish Garg. Dr. Manish Garg is consultant anesthetist, North Delhi Hospital. Dr. Shakuntala Kumar, ma'am is senior gynecologist at New Life Hospital. The next is Dr. Jagjit Bhatia ma'am. She is consultant ENT specialist at Vinayak Hospital. I will request the chairpersons to invite the speakers and introduce them.
Friends, this is the topic where we are going to discuss about that cardiology in a different subsets of the patients. Like a person who has a heart disease in a pregnant woman, how to deal with this if a person is a known heart patient become pregnant, or during pregnancy if they come to know that what is the heart disease if on echocardiography. Secondly, nowadays we all have seen there is an increased number of the cancer patients, and luckily because of the new medications the survival has increased, but simultaneously it has increased the number of heart patients who are survived after the cancer therapy. So we are going to discuss about second thing, and thirdly we are going to discuss that heart and the cardiology when they are the peripheral artery disease are involved. So in these patients it's basically to outreach the cardiology and the cardiac practice in a different subset of patients. Chairman, please.
So good morning everyone on this bright Sunday morning. I would invite Dr. Adhi Arya, Senior Consultant Pediatric Cardiology at Fortis Hospital, Shalimar Bagh. He has got several accolades to his credit. He has, he's a life member of PCSI, Pediatric Cardiac Society of India, member in Institute Ethics Committee and member ISCR. Dr. Adhi Arya will be speaking on the pregnant heart challenges and choices, and something I would be able to understand because being an obstetrician and gynecologist. Thank you so much,
Definitely.
Dr.
Very good morning to everyone who is present there. I thank Dr. Naresh sir for giving me this opportunity. So I'll be discussing pregnant heart, what are the challenges and choices pertaining to our setup in Indian subcontinent. So there are challenges are many and choices are few. So regarding the challenges which a pregnant woman with heart disease faces is the quantum of problem is there, the changing epidemiology trends are there, we have fewer resources, and there is a lack of Indian data also. We are mostly dependent on Western data when we screen such patients or risk assessment is done for them. And then this is a complex clinical condition where difficult decisions have to be made. And what are the choices for all these problems? When we see the quantum of problem and the changing epidemiology, we should sensitize the scientific community towards the problem and these epidemiological changes. When we have fewer resources, what are the choices? We should build capacity in public and private hospitals, and we should have our own registries. We should not be dependent on Western registries such as Zahara and CARPAC network. And for complex clinical conditions, we should have a cardio-obstetric team caring for such patients. And this should be a team-based approach, and it should not end at the delivery of the patient. It should continue beyond that also, because many complications are seen when the patient has already delivered also. So coming to the challenges, number one, what is the quantum of the problem? We see 1 to 4% of pregnancies which are complicated by cardiovascular diseases. And when we see 1 to 4%, it must sound that it's a very small number, but the absolute numbers are very astounding. More than 19,000 maternal deaths in India are there, and it is a critical public health issue. For our achievement of sustainable development goal of maternal mortality rate of less than 70 by 2030, and currently we are far behind of 97. And hypertensive disorders of the pregnancy are the third leading cause of maternal mortality ratio in the developing world. So this is the chart which shows that there is a disparity also in state-wise also. The southern states do far better than the northern states and eastern and western states. So Kerala leading where the maternal mortality rate is as compared to west with 19. If we compare Delhi, Delhi is also somewhere around 55 per 100,000 live births. So this changing epidemiology is what we want to highlight here, that are we prepared for this changing epidemiology which is in these states where all the health facilities are better. So there is an obstetric transition. The heart disease is complicating pregnancy is expected to contribute to increasing proportion of maternal deaths. Currently, maternal mortality ratio, first leading cause is maternal PPH, and second is infection, and in India third is hypertensive disorders. But we see in many states there is an obstetric transition, because when these causes are addressed, the hypertensive disorders, the people who are being operated in childhood are reaching the age of childbearing age and they are conceiving. And already we see that there is an advanced maternal age at first conception. So already cardiovascular risk factors have already set in these women. So these are 5 stages of obstetric transition. If we compare where in Indian states, most of the Indian states will be in stage 2 and 3. Where direct and indirect causes are increases, cardiac causes are increases, PPH and infections is on a decreasing trend. And if we compare where the maternal mortality rate is less than 50, we'll have Delhi, Maharashtra, Kerala and other developing countries which are also following this trend, such as Sri Lanka. These are small countries, but they're also following this trend where direct causes of maternal mortality will increase. So pregnancy which are complicated by cardiac disease may contribute to as much as 20 to 30% of maternal deaths in developed nations. And ongoing obstetric transition, this trend is also evident in developing nations as well, such as India. So what the third challenge is fewer resources and lack of Indian data. So if we look at the data, 31% of pregnant women with heart disease seek medical attention only during the labor. They are not counseled pre-conception. They are the first time they seek attention during the labor itself, which is already late. And among women with congenital heart disease, only 50% have received preconception counseling regarding contraception, regarding their disease status. And we are highly dependent on Western data for stratification, risk stratification, such as Zahara, Carpet or modified WHO criteria. There is a registry in Chennai, which is Madras Medical College Pregnancy and Cardiac Disease Registry. They are the ones who are maintaining a registry for all their patients who have been treated for cardiac disease during pregnancy. That's the only registry we have in India. So challenge number 4 is, there are complex clinical decisions, and in the absence of dedicated cardio-obstetric teams in most of the institutes, we don't have such facility that cardiology and obstetric teams sync with each other and take shared decisions. So complex decisions will include preconception counseling. Before itself, there should be a counseling on shared decisions. There should be mentioned on the paper of the patient that this has to be done. Contraception. Most of the patient might be on some drugs. So whether these drugs are teratogenic or not, you have to modify those drugs. So drug review has to be done. Then most important thing is what is the current cardiovascular status of the patient. Then how pregnancy affects the cardiovascular disease. Then and how the CVD affects the pregnancy and the fetus. These should be taken into account. Then we should address the heart disease. Then delivery planning, mode of delivery, what mode of anesthesia has to be given, intrapartum, postpartum care, and then again for the second pregnancy you should counsel them for contraception. So this is a whole lot of steps when you see such a patient, and continuum of care doesn't end at the delivery itself, it extends beyond the delivery also, and for next planning, next delivery also, next pregnancy also. So choices are that we should address problems in meetings and professional bodies so that everybody is sensitized towards the problem, that we are seeing a transition in epidemiology, and sooner or later we will see such transition. In many states we are seeing this, and this is bound to happen in every other state. So we should be mentally prepared, and statistically or logistically we should be prepared that this is bound to come to our hospitals, public, private also. Then there should be a lower threshold for echocardiography if any sign or symptoms are present in any pregnant woman. Then it should be a teamwork. I'll just highlight a case because I think I'll have 3 minutes. So this was a patient, Mrs. A, 26 years, primary. She was previously altogether asymptomatic, detected to have murmur on a routine visit to a gynecologist. Gynecologist auscultated and she found a murmur, and she was referred to a cardiologist for echocardiography. On echo, there was a severe AS, aortic stenosis, with a peak gradient of 80 and mean gradient of 54, which I just explained to you. It is a severe condition. And when detailed echo was done, there was a circumferential subaortic membrane. It was subvalvular. Below the wall, this obstruction was there. So she was referred to us for further management at our center. So detected first time at 20 weeks of pregnancy. Major challenges, this is a delayed detection. It should have picked up earlier. It is a missed opportunity for preconception counseling and management of severe AS. So detailed history revealed that at some point in time in childhood she was diagnosed, but this was not revealed due to some social reason that her marriage will be delayed or her in-laws will. So this was the detailed history. Her parents knew it, but the child and her husband was not knowing this thing. So it's a complex case because plan will be based on 4 major questions. What is the current cardiovascular status? By echocardiography, she comes in severe AS, but the patient is asymptomatic. If you ask her, she'll tell, I don't have any complaints. Then disease affecting the pregnancy, because aortic stenosis, severe AS, cardiac output will be hampered, and if we see that these stenotic lesions in general are not tolerated better in pregnancy. Regurgitant lesions are tolerated better, stenotic lesions are not tolerated better. And also maternal and fetal risks are also associated with stenotic lesions. Then how the pregnancy affecting disease process I have already told, and what is the current gestation at which the patient is presenting to us. This is also more important. So to take these shared decision, we should know at what WHO risk stratification this patient comes. So I will not go into detail, but significant 3rd and 4th in this chart, this patient will come in either on 3rd or 4th. Because 3rd, because she is asymptomatic, that's why we are keeping in 3rd. So in this risk, the risk for adverse cardiac event is around 25 to do, it is around 30%, maximum it is around 20 to 30% we can make it. So basic understanding also for taking such decisions is that you should know what pregnancy causes, what are the physiological changes. So cardiac output increases, stroke volume increases, heart rate increases, and systemic vascular resistance decreases. So basic dictum is that all the obstructive lesions will be increased. You will see more increased gradients because cardiac output is increased, stroke volume is increased. And regurgitant lesions, because SVR will decrease, so they will have lower, they will probably improve. You will not say improve, but they will decrease on your assessment. The next choice is you should have a team. So if our patient is coming into category 3 or 4, you should have a congenital heart disease specialist, pharmacist, cardiac anesthesiologist. In this case, we needed surgeon also because it is a surgical disease, because subaortic membrane cannot be addressed by intervention. So I'll just take one more minute that what are the options we gave to this patient. So it was medical termination of the pregnancy because she presented to us earlier at 20 weeks and followed by surgical resection of the SAM, subaortic membrane. Second option we gave that continue pregnancy till viability, that you continue the pregnancy till 28 weeks. If the patient becomes symptomatic, you put her on beta blockers, that will reduce her symptoms. But that there is a risk because another 8 weeks to follow, and such patients have sudden cardiac death risk. So that has to be explained to the parents that sudden cardiac death can occur in such patient despite they being asymptomatic. And surgical correction with fetus in situ with risk to fetus loss explained to the parents. All options are feasible. Based on shared decision, family has to take a decision and you have to communicate these are all the risks. So cardiopulmonary bypass during surgery is safe, irrespective of which trimester you do the surgery, maternal mortality is same. And if you look at the fetal mortality, as you go further, trimester wise, the fetal mortality decreases. This is the data. So you can counsel them regarding that. Thank you. She went for MTP followed by surgical correction of SAM. That's an easy choice for everyone actually. Because following that patient for another 8 weeks, you explain it to them that you have to take a call for sudden cardiac death risk. Nobody takes that risk. But that is a feasible option. We could have done till 26 weeks also, because if your NICU department, your neonatology team is good, you cover them with steroids, and 26 weeks you take up elective cesarean, and after that, along with that, you do the surgery for the mother. So that is also a feasible option, but family did not agree, because keeping a neonate from 26 weeks till at least 32 weeks in NICU also is a costly affair. They'll cost them around 6-8 lakhs. This surgery also will cost them, cardiac surgery will also cost them. So taking all that into consideration, they went for MTP followed by the surgical correction from mother. Later also get this surgery. Because as such MTP when was done, so this gradients also came down a bit. Because when they were 100, peak gradient was 100, when this MTP was done and she came for follow-up, the gradients came down a bit, but they were in the severe category only. Only good thing was that surgery was done after some time because patient was asymptomatic.
Thank you so very much. Actually, the sustainable developmental goal, what we are dreaming of achieving by 2030 has already been achieved in down south in Kerala.
Down south and Delhi.
Now the thing is, what made the whole thing click there was training the trainers. First you train the gynecologists like us, then we go and we teach the ASHA workers and the other. The problem in our clinics is we don't even auscultate the heart.
That is the most important thing.
Yes.
At least we should auscultate.
That is how the delay in diagnosis happened, So if we auscultate and we take a reference from the cardiologist at the earliest, probably we could have avoided this situation. That is number one. And once this kind of a situation is picked up, early reference and probably taking a decision, collective decision by the family and by the gynecologist and the cardiology team, I think that will click. Yeah. Thank you very much. I think we'll take the discussion.
Do you recommend to have an early echocardiography for all the...
We do that. We do that.
Yeah,
the moment we come across any situation like this...
No, see, once the patient is getting pregnant, then it's only coming to you. So do we as a
not in all the cases
should emerge and tell that before pregnancy everybody should go for echocardiogram?
Sir, what happens when we have majority of the times हम लोगों के तो कानों में हमेशा हमें मरमर सुनाई देता है. It's like a pansystolic murmur. We are so confused कि what is this, and the cardiologist has sent it back कि नहीं ये तो anemia है, कुछ नहीं है, आप anemia treat करो और हो जाएगा. How to differentiate this pansystolic murmur from early and other diastolic murmurs? I think some session should be we should have a collective.
I think rather than going to a multiple cardiologist, I think it's better to get an echocardiography for these patients.
Definitely, we do that.
It's difficult for cardiologists also to define this.
We always advise, sir. We always do that.
Thank you.
Yes.
The next speaker is Dr. Rashi Khare. She is Additional Director Cardiology at Fortis Hospital, Shalimar Bagh. She has more than 11 years of experience, and she is a gold medalist in MBBS, MD, and for the best paper presentation at IMCOM. And she will be speaking on the heart in cancer care, protecting while treating.
A very good morning to everybody, and thank you for the organizers for giving me this talk on this prestigious platform. So I'll be talking about rather upcoming topic, cancer and heart disease. Where do both of them intersect? I'll try to keep it short and crisp. So we all know the epidemic of cancer has been increasing, India being a center of that epidemic. And heart disease, we all know, India is the capital, the world capital of diabetes as well as the heart disease. So what we'll discuss? In short, we'll discuss the impact of cancer treatments on the heart. Then how can we optimize the cardiac health in cancer patients? And then a newer approach, a multidisciplinary approach for optimizing the cardiac health in cancer patients. How an oncologist and a cardiologist together can work for the betterment of the patient. I have an oncologist in the hall right now? So we could have some interaction, never mind. So cancer drug development has seen tremendous increase with the chemotherapies, the radios, then the immunotherapy, the new adjuvant treatments. We all know the survivorship has been increasing tremendously in all the cancers, particularly as I talk to my friends, some of the gynae cancer patients after surgeries, they have as normal a life as any normal person, and breast surgery after chemo and it has got perfect prognosis. So the cured cancer patient of today, we are curing the patient of cancer today, but we should be very aware that we are not making a heart failure patient of tomorrow. That is very, very important. So the side effects of chemotherapeutic drugs was first diagnosed way back in 1966-70s when we saw that anthracyclines had a potent potent cardiotoxic effect and led to CHF, decrease in ejection fraction. As soon as you stop the drug, the EF reverts to normal or maybe near normal, and once you restart it, then it can again go down. So there are certain mechanisms, macrophages, inflammatory markers, oxidative cytokines. So what cardiovascular side effects do the modern cancer therapy have? It can lead to arrhythmias. Very commonly it can lead to atrial fibrillation. That can lead to, in the long run, tachycardia, cardiomyopathy. Then there can be cardiac dysfunction. That means the decrease in the ejection fraction of the heart leading to HFrEF. Also, the incidence of HFpEF is more in the patients of CA who are receiving chemotherapeutic drugs. Thromboembolism, the cancer patients are very much prone for DVT in the Wellens criteria. There is an added point for CA patients, and these patients should be prioritized for giving anticoagulation. Then AP and MI, hypercoagulable state, and hypertension very routinely found in these patients. Stress also has some role in that. So cardiovascular events in cancer survivors, the chart shows that the patients who received the chemotherapeutic drugs, they had more events of cardiac diseases, particularly breast radiation, because the area is the same. That actually has a particular effect on the heart because of the fibrotic effect. So there's an important increase in the mortality in the early. Initially, here we can see that the breast cancer patients, in the due course of time, the cause of death because of CVD is more than the cause of death because of breast cancer. So there are certain risk factors that are shared between cancer and cardiac diseases. First, we all know aging is definitely a high risk factor for cardiac disease as well as for cancer. Then tobacco, in certain infections, diet, drugs, alcohol, obesity, physical inactivity, certain environmental factors. In Delhi, we can say about the pollution and the heredity. So these risk factors are overlapping in these patients. So definitely we can say these patients are a bit more prone for cardiac diseases. There's certain interaction between these risk factors and cardiac diseases. The shared risk factors, they are common for them, and the final is risk factors persist during cancer treatment and may lead to decrease in the EF. Now there's a frequent coexistence of cardiac problems in cancer patients, as I already said. Now there are certain cardiac diseases and risk factors in older cancer patients, that is in prostate, breast, lymphoma and colorectal. In these patients there is a higher risk of CHF and CAD. Diabetes as per se is also increased. So the evolution of cancer therapy dates back from 1970s, and the newer drugs are coming along, the proteasome inhibitors, then the new adjuvant therapy, the latest one to come in the line. Now this chart in short, this figure shows which drug causes what. The anthracyclines and the radiation, it leads to decrease in ejection fraction and heart failure, HFrEF. HER2 therapies lead to cardiomyopathy, again decrease in EF. Then basically immunomodulators, I'll just talk about the important ones, lead to thrombosis and vascular events. The immunotherapies that are very commonly used nowadays, they lead to myocarditis even in the younger population. Okay. We have seen myocarditis because of these immunotherapies in young ALL patients as young as 11 years of age. Oh my. Then these PI3K inhibitors, they lead to myocardial arrhythmias and atrial fibrillations. Also 5FU can lead to ischemia and vasospasm. So now we know that chemotherapeutic drugs do cause cardiac events. These patients are prone for cardiac events. There's a decrease in the ejection fraction, and these patients need proper evaluation and treatment. Now, who is responsible for the care of these patients? The oncologist might say that the cardiologist will take care. The cardiologist might say the oncologist will take care, will be held responsible. But no, we have to share this responsibility. And now comes the discussion about having a cardio-onco care, the birth of cardio-oncology. The cardiologists need to take onus of the cardiac health and the oncologists need to take onus of the cancer care, and together in, as a multidisciplinary approach, this has to be done. And it is a rising concept throughout the world because as the cases of cancer are rising, the chemotherapeutic drugs are causing cardiotoxicity, and the subset of these patients is on a high rise. So it is a clinically based discipline focused on the CV health of cancer patients and the survivors. So I'll just talk in short. So the concept is as old as around 21 years. And if we a brief view how these cardio-oncology clinics are working throughout the world, we can see India also has adapted this system. It is a widely dispersed system, and even in India, we are working on that. So what does this clinic offer? It is a rapid access to the cardiologist who has a specific understanding of the systemic and the targeted therapies, the newer drugs that are being invented and being used in the cancer care. The education of the patients and healthcare providers. It includes a cardiologist, an oncologist, a pharmacist, a nurse who is trained in this treatment, and development of a collaborative research environment, because every patient is different, every result is different. So a research work is also to be conducted in this clinic. So we have a hematologist, oncologist, oncology care team, then the cardio-oncology specialist, then we have specialized nurse and the research teams. And in certain hospitals it has been seen then because of the reasons of referral, they could see that they could better assess the rhythm, the CAD and the CHF and the valvular disease and the EF. And it was seen that with the targeted therapies, the outcome in patients with mild or moderate LV dysfunction, it was better when there was when it was diagnosed early, like in mild breast CA, and when it was diagnosed later, the prognosis was poor. Now it has been seen that the impact of this clinic is the patients are better referred, they have a better compliance. That was the patient when they were referred to the cardio-oncology unit, they were taking beta blockers, most of them, but the loop diuretic, the MRAs, they were quite underused, and that was better assessed in these clinics. So it has to be a cardio-oncology partnership. Various forums are working on this, and there's an ABCDE for the steps to prevent heart disease in especially breast cancer survivors. Awareness of the risk of the heart disease, then aspirin should be added, blood pressure should be monitored, then cholesterol, cigarette, tobacco should be stopped, then diet and weight management, the dose of chemo and the radiation should be monitored, diabetes, and then exercise and echo should be done in these patients frequently. The publications are also on the rise. There are multiple clinics in even our hospital. We are trying to set up one. Then the challenges are better understanding how modern cancer therapies impact the CV death. There's early identification, prevention of damage. We can actually strategize, make a strategy for the patient-specific strategy. Then the surveillance and monitoring can be better. And it is a new opportunity for young cardiologists to venture into. So I'll just keep it short that key messages are improvement in cancer therapies has resulted in long-term survivors who may be at a risk of cardiotoxicity, and close collaboration with the cardiologist and oncologist is the need of the hour, and establishing a cardio-oncology clinic with research and education should be promoted. Thank you.
As we age, things keep on coming.
Hello everyone. Hello. Yes, our third speaker is Dr. Achintya Sharma, who is the Senior Consultant Vascular Surgery in Max Hospital, Shalimar Bagh, having the vast experience of 18-20 years. He will tell today about the intervention in PAD, peripheral arterial disease, reducing the MAC and MANE. Welcome, sir.
Well, good morning, everyone. Well, my topic was peripheral vascular disease, but I'll be, elaborating more on certain cases and tell a clear guidelines, what is best for peripheral vascular disease. So the correct choice of treatment at the right time is very important, not only to save the life but the limbs. And as we are working in an Indian setup, the cost plays an important role. Whether to go for a stent, arthrectomy devices, multiple options have been there in the market. But what is best? That is the question. Maybe devices, balloons, now even DCBs. So the choice of endovascular therapy versus surgical bypass in patient with tissue loss, peripheral arterial disease and diabetes is currently a very hot potato, being debated everywhere, all over the world. But there has never been any head-to-head trial in patients with diabetes between the two techniques. In the early 2000s, a trial came, basal, where bypass was compared with endovascular, and it was said that patients with more than 2 year survival, bypass hands down wins. But with this trial, there was a lacuna. 25% of the patients with infrapopliteal disease were not included in it. In the mid 2000s, basal 2 came down, where it showed that endovascular first in below-knee interventions wins. Now, basal 3, interim results are out, where DCB versus plain open balloon angioplasty shows there is no difference at all. Surgical bypass, durable and effective, but morbid. Poor long-term patency in below knee. Surveillance is long-term required, potentially very morbid. Big scars, patients usually refuse. Catheter-based interventions, effective, non-invasive, low morbidity and no mortality, poor long-term patency, but expensive, require repeated interventions. So these lesions have to be classified. There is a very specific guidelines where this has to be done, where this has not to be done. But that has become also a little blurred with vested interest of the companies, newer devices. The line is getting clearly blurred. Ilex A, B, and C catheter, femoropopliteal A and B catheter, tibial catheter as much as possible. Last resort is doing a bypass. So if you talk about the guidelines, short segment lesions, ilex stents, long TARS D lesion, aortoiliac lesions, we would prefer to go for a bypass. Young fit patient, hands down a bypass, not a CRAP or something. Task C, femoral lesions, completely occluded from the origin. Yes, you can come from below tritibial, but do these stents really work? Long segment lesion, because SFA is a flexible vessel which has number of choke points at the adductor hiatus. These stents don't work long time at all. So I'll show you one of my cases. Long segment lesion, did a SFA bypass, doing very well. Here another small TARS D technically, but stented. Patient is doing well. This is a TARS D lesion, aortoiliac lesion. Went with a patient was poorly morbid, 70-year-old, came from the brachials, did a ballerina for him. A diabetic foot, morbid, told for an amputation. This was the status of the foot. Could not reach the pedal plantar loop, but did an plasty of the AT and posterior tibial artery, debrided the wound. This is the status of the wound right now. So vascular surgeon has an advantage of taking care of diabetics both with open and endovascular techniques. Patient here, below knee popliteal lesion, could have been managed. Cost is a very big factor in our setup. We did a bypass for him. This is the status of the wound post procedure. Type D lesion, diabetic foot. This was the status of the foot. Distal reconstructions done. This is another patient, left CI, post CABG, poor conduit, no veins. This was the status. What we would have, we have done just a plain ballooning and came out. So I'll show you one of my few cases. A 56-year-old male, known smoker, known diabetic, underwent a FEMPOP bypass in a center with a FEM distal occlusion. As told that tibial intervention should be done, but it was long segment lesion. No vein, we came with a graft up to the popliteal vein, anastomosed to the vein, the graft, and we came out with doing a PTB. He had a post-procedure very good pulse. 70-year-old male, non-healing ischemic ulcer, 4-foot gangrene, complete ileoc, 70-year-old. So it's not that it cannot be done. Reformed peroneal artery, did a bypass, a jump to the common femoral artery, harvested the great saphenous vein, did a bypass to the peroneal artery. So patient's wound healed. This is another 35-year-old BD smoker, was told amputation in the view of that he is a TAO, went to multiple hospitals. Only posterior tibial artery was reformed, profunda was closed. We did a new intervention for him. I did an anastomosis to the profunda vein, creating an arteriovenous fistula for the patient. Ligated the vein proximally so that we had a jump graft because he did not have any jumping. This is 1 year down the line, we were able to save his limb. We have created an AVF, he has got a venous hypertension, but it works. A 65-year-old patient smoker, diabetic, maybe I came to us first, maybe I did not have a very strong convincing power. Went to another hospital, was stented. Stent went across the inguinal ligament, had recurrent symptoms, went to another hospital, got the stent out, then again was stented. Stent didn't work in 3 months, went to another hospital in Gurgaon. Drug-coated balloon plasty was done, and the stent was again got thrombosed in 2 months. Then again a DCB was attempted. After 2 months, the stent got completely thrombosed. Came to us. This was the status. This is a VR image, but the stent was hanging, dangling below the inguinal ligament. I had to cut down the inguinal ligament completely, take out the stent, do a bypass for him up to the anterior tibial artery. This is the status of the stent which was being taken out. So, as a surgeon, I lost the patient. I'll be very frank. Within down the line 6 months, I lost the patient because of wound infection. So, as a surgeon, one should know his limitations and where to say no. Already spent ₹1 crore just for foot. I could have just amputated and get out with a stump. But that is what is more important. Providing a functional limb in peripheral arterial disease is the way to go. It is not necessary that you every place stent डालें या ballooning करें, even a bypass. So your limitations is very important in diabetic foot patients. So yes, with the rise of newer devices and endovascular interventions have increased, but there is still a role of a vascular surgeon who can give you a rationally where an open surgery is required, where we can go with an endovascular interventions. So if a functional patient with a long segment occlusive disease where you have a good autologous conduit, a bypass is always preferable. In setting of tissue loss and diabetes, prosthetic bypasses are very inferior because below knee we don't prefer any prosthetic graft. A vein bypass hands down is one. Tibial vessels in an immunocompromised or a patient who is very sick, tibial angioplasty is the way to go about it. So balanced view is very important for both for endovascular therapy and open surgery are both important means of revascularization in limb salvage. Choice of intervention should depend upon the degree of ischemia, extent of the disease. Long segment, yes, bypass, but the condition of the patient should be there to handle it. Extent of the wound, if you have an open wound, ischemic wound, and despite doing an angioplasty and amputation would be a better option to go about it. So it also depends upon the expertise of the practitioner. So as this talk was given to me by Rivoxaban, so I have to put in a few words about Rivoxaban. So Rivoxaban is the drug of choice these days in peripheral arterial disease, and it acts at both thrombin and platelets. So out of the newer anticoagulants, the only drug of choice is this Xarelto, which is 2.5 milligram BD. Mirror, Camper, Casper, Dutch Boer, they were the traditional trials, but they were showing that there was excessive bleeding, and Voyager showed that the results are much better. There is a superior reduction of more than by 15%. So dual antiplatelet therapy requires that there is, unplanned revascularization reduces by 12%, unplanned hospitalization by 28%. When to initiate? So patients are initiated with Rivoxaban with aspirin after sexual full revascularization within 10 days. Results suggest that dual pathway initiation should be initiated as soon as procedure. So if you are confident, you should have started immediate as the intervention has been done. So its reduction of rate of amputation is more than 70%. So I would like to conclude this by saying that rivaroxaban is a drug of choice and the only NOAC right now in peripheral arterial disease, not Eliquis. There was a trial by name of Agrippa which has failed. So Xarelto 2.5 milligram BD with ecosprin is a drug of choice these days. Thank you.
Thank you very much, sir. One question, what is the indication of the medication that you spoke about, Dr. Achintya?
Ma'am.
One thing that Xarelto, what we used to use in a pulmonary embolism and the DVT is the dose of much higher than what is there, what you have mentioned in the DPI or this PA, peripheral artery disease. So is there a particular indication that why we are using low dose? Is it because it's a dual and we are giving aspirin also? Or it's alone?
Sir, as we know that rivaroxaban works at both fibrin and platelets. So the low dose of 2.5 milligram BD works at both the pathways. The dose of 10 milligram or 20 milligram OD works only at the fibrin pathway. So venous thrombi is always rich in fibrin and the arterial thrombi is a platelet-rich thrombi. So we require these both things on that.
Can't use alone rivaroxaban in this patient.
Not at all. Not at all.
Thank you.
What is the condition? What are the indications? When should we start the drug?
Ma'am, there is a classical indication for any patient who is a claudicant. Class 3, if he is not able to walk more than 500 meters, proven peripheral arterial disease, then you can put him on best medical management. Best medical management has to be added with graded exercises. 6 weeks. That is, we call it, and then we reevaluate our patient. But in patients with peripheral arterial disease, we usually put them on lifelong anticoagulation with aspirin.
I want to ask Dr. Rashi for the cancer and heart care. Yeah. Please come on.
Sir, cancer and heart care.
So, let me just go through. My question is, once the patient has undergone for the chemo, radio and therapy and detected to have an LV dysfunction, so usually our onco friends tell and to hold the chemotherapy or that required therapy, which is also very important to take care of their malignant disease. So at what certain of the time you should hold the medication or when you can restart those therapies?
So that's a very good question. Most of the chemotherapeutic drugs that cause cardiotoxicity, what we follow protocol is there's one GLS, LV strain imaging that can be done. So we make it a habit that we do strain imaging of these patients at least before every next the chemo dose. So the LV strain can diagnose decrease in myocardial contractility or myocardial functions before it actually appears on 2D echo. So we can, if we find some LV strain GLS is decreasing, then we can definitely discuss with an oncologist and we can decrease the dose or we can stop per se. And if the EF decreases, then at least we should give the patient a brief period of at least 2 weeks and reassess the echo, and it might be patient specific also depending on the disease and aggressive nature of the disease of the patient as well.
While the patient is on chemotherapy, these medications can be continued, suppose the EF is falling?
Yeah ma'am, definitely. Yeah. Once it decreases, we start the chemotherapeutic drug. If it increases, then this again start the drug. The support of the drugs should always be given along with.
And in the, like a chemotherapy which are known to cause cardiotoxicity, is there any preventive role of giving like the heart failure medications? Although we are going to discuss in the next session of heart failure.
It is more of a debate right now, it is not recommended. If the patient is having some symptoms of FF, then we can definitely add.
Thank you.
Thank you very much.
Yeah ma'am. Yeah.
Regarding ECP therapy for peripheral, collaterals and bypass, natural bypass it creates for the...
Ma'am, if you talk about a natural bypass, let's say...
by ECP therapy, like enhanced external counterpulsation.
Ma'am, there has never been any good trial with regard to giving a compression therapy. Arterial arch device has been there. Even stem cell therapy has been tried, but the inline flow, unless you make an inline flow, never these peripheral vascular patients develop. You talk about the collaterals, it is the best medical management which works very well. Arch compression devices multiple devices are there in the market, but is there been any good trial? Question is that.
But there are trials, but
Which,
I think we need to, EECP external, even for diabetic food.
Yes, ma'am. But if you see the pathology of a diabetic patient, these are calcified vessels, not thrombotic vessels. How does in calcified vessel external compression is going to help?
Yeah, but
there is no grade 4 any evidence suggesting. Yeah, it's a grade 1. So if you talk about direct evidence, it is always a grade 4 we consider. Plebiotic treatment has been given, stem cell therapy has been attempted, but the classical guideline for even for stem cell therapy is only for TO patient, not for diabetic calcified patients.
Or anything like for DVT patient or a vascular venous valves, which were initially thought of to the patient who has a varicosity to
Yes,
give the
sir.
venous valves or in these patients.
So if you talk about varicose vein, the guidelines are very clear. Patient should be operated if there is SFJ junction incompetence or GSV is grossly dilated more than 5 mm. That are the only indications.
Any role of percutaneous valves in these patients of venous valves? Are they still under?
Sir, deep venous valve reconstruction is still done, but it has to be done very judiciously because the cause has to be identified. Ascending veno, unless you don't find a deep venous vein, because results it is only done in very few centers, not in all centers, and the procedure is Kirchner's plication, which is done. So deep venous wall reconstruction, we do have to do an ascending venogram to rule out whether the deep venous are involved or not. If deep venous is classically, it can be done. Yes, it can be done. Thank you. Thank you.
Thank you.
I request all the speakers to go for the felicitation at the felicitation desk. It is time for the lucky draw. I request my chairpersons to take out a lucky draw. एक lucky draw. Ma'am, please announce. Dr. R.M. Chabra, sir.
सही पढ़ी हो ना?
हाँ जी,
सही पढ़ी।
बिल्कुल सही. Please, chairperson, proceed towards the felicitation area. एक और है?
एक और निकलना है। एक और। लास्ट सेशन।
डॉक्टर अलका गुप्ता।
डॉक्टर अलका गुप्ता,
आइए प्लीज।
ये साथ साथ ही बैठे हुए हैं. Now I request Dr. Vandana. Now I request Dr. Vandana Bhupna to come in the front.
इधर से मैडम इधर से। अरे मैडम, यही फायदा होता है दुबले होने का। नया बुला दिया चेयरपर्सन।
Thank you, friends. And now this is the session for the heart failure. This is a mega session. We can discuss about the heart failure with the different aspects, with the reduced ejection fraction as well as the preserved ejection fraction. There are many patients, as you know, the epidemic of heart failure is increasing. So we have a very good eminent speakers from the different big institutes like Escorts and All India Institutes that we are going to discuss all the queries regarding to the heart failure, when we have to do and what are the indication or a contraindication when we can start the medication and what cautions we have to take. It's a very good panel with the 2 nephrologists, cardiologists as well as the cardiac surgeons. Please start.
So, as sir has mentioned, Dr. Achint, are you there? Is there? So, as sir has mentioned, heart failure actually affects the quality of life and increases the mortality and morbidity. So, for this session, I'd like to call upon the chairpersons, Dr. Piyush Jain. He is the Director Non-Invasive Cardiology and Head Department of Preventive Cardiology at Fortis Cots. Dr. H.C. Gupta is a Senior Physician. Dr. N.K. Handa, again a Senior Physician in North Delhi. And Dr. Nausheen Ansari. She is a GP at General Practitioner at Ansari Polyclinic. And I'll request the chairpersons to start the sessions. Please introduce the speakers. This is a 90-minute session and we'll be discussing the heart failure.
Hello. Hello. So, thank you very much. Yeah, I know that there has been some change.
First me,
yeah.
Second myself.
Right.
Third me.
Sure. So, good morning everybody. So we are going to have a 90-minute session on practically all aspects of heart failure management in day-to-day practice. And we have several speakers, and there has been a little change in the sequence of the talks because of some administrative reasons. And I suggest to start straight away with an overview of heart failure basics and foundations of heart failure care by Dr. Bimit Kumar Jain. Everybody knows Dr. Bimit Kumar Jain. He is an interventional cardiologist with more than 38 years of experience. He is a DM in cardiology, and he is working at Agrasen International Hospital, Rohini. And I had the opportunity of working with him at Gangaram Hospital way back in 1988-89. So, thank you.
Thank you, sir, and good morning once again. And I would like to thank Dr. Naresh Goel for giving me an opportunity to interact with all of you and to meet my old friend Dr. Piyush Jain, with whom I have really worked. For next couple of minutes, I'll be taking you through the basics and the foundations in heart failure care. Valley of Queens, where the Queens of Egypt were buried, and it was the Schiaparelli Ernesto, who was the Egyptian pathologist. He was basically a Spanish person who was doing all these discoveries of the mummies, and found that mummies buried 3,500 years ago had the evidence of congestive cardiac failure. But then what was the treatment given to them was not really known. And William Withering, he came to know about Mother Hutton, who used to give herbal medicines to the heart failure patients, and there was a collection of about 30 herbs, and she was giving. And from the knowledge of his botany, William Withering could make out that this was the foxglove which was giving them the beneficial effects. And then he published his data, and he really fought with Darwin to achieve his superiority in the treatment of congestive heart failure with the foxglove, and he has virtually become immortal in the history of heart failure treatment. Now, 1919, when General Dyer was killing thousands of Indian people in Jallianwala Bagh, a medical student in Vienna, the beautiful capital of Austria, in 1909, he found out that the mercurials which are used for the treatment of syphilis were producing the diuretic effects. And same thing was known with the antibacterial sulfonamides, and that started the history of sulfonamides from the thiazide diuretics from the sulfonamide group. We have four models of treatment of congestive cardiac failure. The cardiorenal model, which lasted for about 180 years, from 1680 to 1960, and then came the cardiocirculatory model 1960 to 1980, and then neurohormonal model, which is even working today from 1980 onwards, and the biomechanical models where we are using the certain devices for the treatment of congestive cardiac failure. Now, cardiorenal model is disease is with the heart, treatment is through the kidneys. That is the diuretics. It gives good effect, and it is the foundation of the treatment of congestive heart failure even today, though the beneficial effects in terms of longevity of life is not there, but without diuretics the treatment of heart failure really doesn't really start. Then the cardiocirculatory model, that the cardiac inotropes are being used, and the digitalysis is one of the important things which are being used, and then the vasodilator, both the arterial vasodilator as well as the venous vasodilator, they are still being used, though the mortality benefit is less, but hydrazine and the venous is the isosorbide dinitrate is still being used in this model. And then neurohormonal model, which we came to know about in 1980s, that once the heart failure sets in, it it produces the neurohormonal system to get activated to help the heart and the body, and the sympathetic system gets activated, and then the renal angiotensin system also gets activated, and the aldosterone, and we inhibit all these things because excess of everything is bad. So once these treatments, the compensatory mechanism increase, the harmful effect really set in, and that's what really we treat these days. John Wayne, who won the Nobel Prize for the elucidation of the mechanism of action of aspirin through cyclooxygenase pathway, his student Sergio Ferreira from Brazil, he was very knowledgeable about the pit viper. This is known as the mother-in-law snake, because it bites you without any provocation. And then he knew that this was producing hypertensive effect, and he suggested to John Wayne that why not use this antihypertensive as an antihypertensive agent, but since it was having all the peptides, so this was not orally effective, so they contacted their friend, the Ondetti, who synthesized captopril, and this is virtually the oral version of the snake venom, which has opened new chapters of angiotensin converting enzyme inhibitors in the treatment of pharmacology. And soon we came to know about the angiotensin, which is a murder molecule with the serious adverse effects on the heart, brain, and the kidney. And this was really used, and as we will see in the due course. Now, after the Second World War, DuPont company, which was manufacturing the gunpowder, there was a recession because in the peaceful time. So they diversified in the pharmaceutical industry, and then they synthesized angiotensin receptor in an attempt to have more scientific approach rather than the ACE inhibitor that directly block the angiotensin receptors, and that's how they came out with the synthesis of losartan. Now, Mark Favre, he was working with the spontaneously hypertensive rats, and the ACE inhibitors have come, so he could show that the ACE inhibitors work in these kind of animals also. Now his wife was doing experiments on the mouse by ligating the LAD and giving them the ACE inhibitor. She found with the help of her husband that the infarct size with these kind of animals was less once they were given ACE inhibitors, and then the function of the heart was also better once these animals were given ACE inhibitors after this myocardial infarction. Now James Black, which synthesized propranolol and cimetidine. Propranolol because it came after 180 years of foxglove intervention, that there was no molecule in between those 180 years. Now this was basically, he was a pharmacologist and veterinary surgeon who did not work well with the John Wales. So he resigned from his company and did his own research and came out with a very scientific molecule to inhibit the angiotensin system. The propranolol came in 1960, and he is the one who synthesized cimetidine also and won Nobel Prize, and cimetidine became the blockbuster medicine. That's $100 million, that's $1 billion, was the income in 1986, and SmithKline French company became the biggest and the richest company with just one molecule. Now, Waxstein, in 1970, he was working in Salgansa University, and he had the knowledge of beta blockers, and in a patient of congestive heart failure, he started giving beta blockers. But the very next morning, he was given warning not to give this kind of thing because this was not the drug which was really recommended. And on the second, his opportunity to treat such patients, he was banned from entering the CCU. So he was put in the medical wards, where his senior, Lars Verco, he really helped him. And this is one person who made the beta blockers immortal for the treatment of congestive heart failure. And the obesity of the beta blocker for the treatment has also been written for the treatment of hypertension. Now, in 1950, there was discovery of aldosterone from the adrenal cortex. And the very next year, the Swiss Polish chemist also synthesized the antagonist to distinguish the aldosterone antagonist spironolactone. And it was used as potassium sparing diuretic, very weak diuretic as we are aware, but then it is the physicians who used it for potassium sparing in the RALS trial, but surprisingly found out that this was a wonderful medicine, producing about 35% risk reduction in the mortality of these patients of heart failure. Now, spironolactone looks very weak diuretic, but surprisingly this is still being used today in more than 14 diseases like heart failure, edematous nephrotic syndrome, ascites, liver disease, essential hypertension, secondary aldosteronism, primary aldosteronism, potassium-sparing diuretic, Bartter syndrome, anti-androgenic activity, dermatological conditions, seborrhea, hirsutism, and pattern loss. So 14 diseases are still being used, the aldosterone, spironolactone. Now, the discovery of SGLT2 inhibitor has also become very accidental. The fluorogen, which was seen from the apple tree bark, was used for the treatment of diabetes in producing the renal hypoglycosuria. So this was the drug which was really aware of, and may I have water, please? In the renal glycosuria. And now we know this is SGLT2 inhibitor, both acts proximally convoluted tubule as well as the distal convoluted tubule. And in 2008, the restrictions were there that any new cardiac medicine has to be given a cardiovascular outcome trial, and there came the discovery that the drug, which is the empagliflozin, producing beneficial effects in the patient of congestive heart failure. And now we know that all the drugs used in the heart failure, they are the stolen drugs from other fields, like beta blockers from the treatment of blood pressure, ACE inhibitor from hypertension, MRAs from diuretic, SGLT2 inhibitors from the treatment of diabetes. And now we know the various types of other drugs are also being used. This Arni, which has been there in the market, and it was introduced in 2016. It became the drug which was appreciated by American College of Cardiology to be recommended to replace the ACE inhibitors for the treatment of congestive cardiac failure. And we have other drug also which has come, the Vestiguat, which is from the very scientific knowledge of heart failure, that the nitric compound, nitric oxide, works very well, and that comes less in the congestive cardiac failure, and this is the drug which increases the nitric oxide and increases its mechanism of action by different pathways. Natriuretic acts through the membrane-bound cyclic pathway of the GMP production, and it is the nitric oxide which works on the soluble fraction, is helped by the Vestiguat, and Vestiguat itself also acts on the other component of the soluble guanylyl cyclase and really works well to give the beneficial effects. So these are the basic things which we know that they have formed the basis starting from the history for a long time, over 200 years or so. Thank you.
Thank you, Dr. Mimit. We will take the questions at the end.
Okay, for the next topic, we have the 4 pillars of heart failure therapy by Dr. Ajay Agarwal. He is a DM cardiologist, presently at Delhi Heart and Lung Hospital. He is well experienced in field of non-invasive and invasive cardiology, and he is also practicing at his private clinic known as Dr. Ajay Agarwal Heart and Child Clinic in Ashok Vihar.
He is still in names, Dr. He is still in names or names?
Start, Dr. Agarwal.
Yeah. Good morning, everyone. Thank you, Dr. Naresh Goyal sir and team DNZ for giving me an opportunity to speak on this topic of 4 pillars in heart failure. As we all know, there has been a paradigm shift in management of heart failure over past 10 years. And from symptomatic relief to now disease-modifying therapies, we have now 4 pillars of heart failure. There are ARNIs, beta blockers, MRAs, and SGLT2 inhibitors. And all these drugs have shown not only to decrease hospitalization, but also to decrease mortality in heart failure. Hence, these are being called the foundational pillars and the 4 important pillars of heart failure. And current guidelines divide heart failure into 3 categories. The first one is the heart failure with reduced ejection fraction, that is EF less than 40%. In between is the heart failure with mid-range ejection fraction, that is heart failure, that is ejection fraction between 41 to 49%, along with evidence of elevated LV filling pressures, which can be determined by elevated natriuretic peptides or echo evidence of LV diastolic dysfunction. And heart failure with preserved ejection fraction, which is defined as ejection fraction of more than 50%, along with evidence of increased LV filling pressures. And these fantastic 4, or if we go to the benefit of these fantastic 4 pillars in heart failure, we will see that most of the benefits with these drugs are in those patients who have ejection fraction towards the lower range of normal, that is less than 50% or below. SGLT2 inhibitors are the only drugs which have shown benefit across all spectrums of ejection fractions, irrespective of ejection fraction, that is they are beneficial even in patients with normal or more than normal ejection fraction. So SGLT2 inhibitors are shown to be beneficial even in patients with ejection fraction of more than 40%, and the results have been replicated both with empagliflozin and dapagliflozin. And the main benefit of these foundational pillars, the 4 pillars, have been in patients with ejection fraction of less than 40%. But trials have shown that the benefit goes on to patients with ejection fraction between 41 to 49%. That is, these can be used even in patients with ejection fraction between 41 to 49%. But whether the benefits extend to patients with heart failure with preserved ejection fraction, that is more than 50%, is an area of ongoing debate. Coming to the first drug, that is ACE inhibitor, the ARB, ARNIs, I'll touch them upon very briefly, because Dr. Piyush sir is going to elaborate on this. The results, the first were with consensus trial, which showed a beneficial effect with enalapril. The 20 milligram dose, it was found to reduce mortality by 40% in patients with ejection with NYHA class 4 symptoms. In SOLVE treatment also trial, the patients with EF of less than 35%, there was a reduction in mortality and hospitalization. With ARBs like candesartan in CHARM trial, the candesartan reduced the risk of cardiovascular death and heart failure hospitalization in EF less than 40%. And again, the paradigm heart failure, which was a landmark trial which changed the treatment of heart failure, the ARNI, the sacubitril valsartan as compared to enalapril, reduced the risk of cardiovascular death or heart failure hospitalization by 20% when compared with enalapril. Coming to the evidence of these drugs in mid-range ejection fraction and preserved ejection fraction, the perindopril elderly heart failure trial PEP-CHF, there was no significant difference in primary composite outcome of mortality or heart failure hospitalization after a median follow-up of 2.1 years. CHARM preserved trial, again a non-significant reduction of 11% in primary outcome with candesartan. And again in CHARM trial program, there was a risk of composite outcome of cardiovascular death and heart failure optimization, but that was seen only in patients with ejection fraction up to 50%. Again, in irbesartan in patients with ejection fraction more than 50%, there was no reduction in primary outcome of mortality or hospitalization. Again, Paragon heart failure, which was a trial of ARNIs in preserved ejection fraction, there was a beneficial effect, but it was driven by non-significant reduction in number of heart failure hospitalizations. But there was no difference in rate of cardiovascular deaths. Again, the combined analysis of Paradigm and Paragon heart failure showed that there was an attenuation of benefit above 55%, but the relationship was seen to extend to a higher LVF in women. The next pillar is beta blockers, and the US carvedilol heart failure study showed that in patients with EF of less than 35%, there was reduction in death by 65%. In Copernicus trial, again in EF of less than 25%, there was reduction in mortality by 35%. In CIBIS-2 trial, bisoprolol was used in patients with EF of less than 35%. there was 34% reduction in mortality and 44% reduction in risk of sudden death. In metoprolol also, with metoprolol in EF of less than 40%, there was 34% reduction in mortality. Seniors trial, nebivolol in elderly patients was compared in EF of less than 35%. Death from any cause was reduced by 12%, but this did not reach statistical significance. Again, in mid-range ejection fraction and preserved ejection fraction, mortality benefits of beta blockers appear to extend to those patients with an EF of 40 to 49%, that is with mid-range ejection fraction, but not those with ejection fraction more than 50%, that is preserved ejection fraction. And beta blockers were also found to reduce mortality mainly in patients with sinus rhythm, but not in patients with atrial fibrillation. And more research is needed regarding role of beta blockers in patients with heart failure and ejection fraction more than 40%. Coming to mineralocorticoid receptor, that is aldactone and eplerenone, Rails trial found beneficial effect of spironolactone in patients with EF of less than 35%. There was a reduction of 30% in both in risk of mortality. With emphasis heart failure and ephesis heart failure in post-myocardial infarction patients, eplerenone was also shown to have a beneficial effect on mortality and heart failure hospitalizations. Again, in mid-range ejection fraction and preserved ejection fraction TopCat trial, there was no significant difference in cardiovascular death, those randomized to spironolactone or placebo. However, there was a nominally significant 17% reduction in hospitalization for heart failure favoring spironolactone. There was greater benefit in patients with LVF at lower range of ejection fractions. Coming to SGLT2 inhibitors, these have been again a wonderful drugs in heart failure, and the beneficial effects are because of their modest diuretic effects and increased glucagon and increased ketone bodies production. And these ketone bodies are preferably helpful for failing myocardium, as the failing myocardium is better able to utilize these drugs for energy conservation. And the DAPA heart failure and Emperor reduced trial both reported benefits of SGLT2 inhibitors in reducing the risk of cardiovascular death or worsening heart failure. Again, the Emperor preserved trial was a landmark moment, because for the first time in patients with ejection fraction of more than 40%, a treatment was shown to reduce the primary composites of cardiovascular death or heart failure hospitalization. Again, DELIVER trial, benefit of dapagliflozin was seen in patients with EF of more than 40%. And in DELIVER and DAPA heart failure trials, the benefits were seen to be consistent across the full spectrum of LVF with no evidence of any heterogeneity of treatment effect. So there has been a consistent benefit of these SGLT2 inhibitors across the range of LVF, reinforcing that SGLT2 inhibitors can be considered a treatment of all patients with heart failure, irrespective of their ejection fractions. And both the European and American College of Cardiac Society guidelines firmly established that 4 pillars of ARNI are the foundational treatment, and they have been given class 1 recommendations in heart failure with reduced ejection fraction. There is no longer the exact sequence of initiation or uptitration is dictated, but it is emphasized that the benefit is of establishing all pillars on 4 pillars and optimizing therapeutic doses thereafter. In other words, guidelines provide the final goal of therapy but allow individual approaches to get to the goal. And there is also a recommendation of urgency to get to the goal quickly and recognize an heart failure hospitalization episode as an opportunity to optimize therapy before discharge and overcome therapeutic inertia. In heart failure with reduced ejection fraction, there is class 1 recommendation of all these 4 pillars. In mid-range ejection fraction, there is class 2B recommendation with ARNIs, beta blockers and mineralocorticoid receptor antagonists. SGLT2 inhibitors are given class 2A recommendation. In preserved ejection fraction, the ARNIs and MRAs are given class 2B recommendation, and SGLT2 inhibitors are given class 2A recommendation. And especially the benefits with all these 4 ARNIs and MRAs more in those with LVF on the lower range, that is closer to 50%. Still, there are some evidence gaps, like there are large evidence gaps regarding pathophysiology and therapeutic targets in patients with higher LVF, and attention is being paid to cardiac amyloidosis and hypertrophic obstructive cardiomyopathy in heart failure patients, and there are new drugs like tafamidis and mavacamten to treat them. And there is the initiation and titration may require consideration on individual patient. For example, ARNI is often better tolerated when patient is still congested, that is wet, whereas beta blockers are better tolerated when patient is less congested, that is dry. Beta blockers should not be newly initiated in patient with decompensated signs or symptoms, but can be continued with decompensated heart failure. So there is no exact guidelines on how to initiate and sequence the therapies. There are various sequences available, but given the benefits, it is only recommended that all the patients should be started onto these drugs as quickly as possible and up-titrated to the maximum effect, maximum doses. And with this, I will just like to mention the 4 takeaway points that quadruple therapy has been established as first-line therapy in patients with heart failure. There is increasing evidence that many patients, more than 40%, may benefit from these medications. SGLT2 have been shown to be beneficial in heart failure regardless of ejection fraction and regardless of sequencing. The goal is to initiate as early as possible these medications and up-titrate them to their maximum doses as quickly as possible. And there are evidence gaps in those with higher LVF. And with quadruple therapy, there is a 62% reduction in overall cardiovascular death and heart failure hospitalization and cardiovascular death. So with this, I will end the presentation here. And I think with proper tools, we can give our patients longer years, and not just longer years, but better years. Thank you very much. Thank you.
The next speaker is Dr. Sandeep Seth. I have pleasure in introducing Dr. Sandeep. He is a graduate, postgraduate, and DM cardiology, all from AIIMS. Currently, he is in the AIIMS faculty since 1998. He is professor of cardiology in AIIMS since 2011, president of Indian Society for Heart and Lung Transplantation, fellow National Academy of Medical Sciences, fellow European Society of Cardiology, founder, editor-in-chief, Journal of Practice of Cardiovascular Sciences. Dr. Sandeep will speak on worsening heart failure. Welcome, Dr. Sandeep.
Thank you, sir. So my job actually is very simple now. After Dr. Jain and Dr. Ajay have covered most of what I had to speak, I'll just finish what is left over. So heart failure, especially acute heart failure, is a major problem in India. Patients who have been admitted for heart failure actually have a median survival of 3 years unless we actually aggressively treat them. We have already covered most of what I'm going to speak. The management of heart failure starts with a good evaluation, which actually starts with a good history and examination, not forgetting simple things like ECGs, chest X-rays, a good blood test, biochemistry, biomarkers, examination which, as was said, including things like GLS, more advanced tests, including family histories, genetics. The treatment has advanced from a time when there was actually no treatment available, just bed rest or applying blood-sucking leeches, to the discovery of digitalis, the initial toxic diuretics, to the concept of using vasodilators. Initial vasodilators were relatively simpler, to the concept of RAS inhibition. Then came the concept of using various kinds of interventions like devices, the transplants assist devices. We moved on to trying to use regenerative therapy, so cell therapy came in, gene therapy was attempted. And then when we thought that nothing else could be done, nothing new was going to come up, then we again started discovering newer and newer drugs. So drugs like ARNI, Ivabradin came in. We started doing newer forms of non-surgical interventions like the mitral clip, intra-atrial shunt devices, percutaneous valves. Now we are basically being able to replace all valves. You can replace practically all the 4 valves non-surgically. And now newer and newer drugs are coming in. Specific precision drugs which can treat HCM, which can treat amyloid, and newer drugs like Vericiguat are coming. So the advancement of treatment of heart failure is going in unimaginable directions. I'm not going to go into detail. These are the drugs which will be covered in more detail still. So paradigm shift, the various trials in dapagliflozin. We actually are in an era where we can actually think of trying to reverse various kinds of heart failure, trying to see if there's inflammation in the heart and trying to reverse it. If nothing else can be done, initially what was thought to be imaginary, now in all parts of India we have options of putting assist devices and transplants. We already covered the concept of 4 pillars of therapy. And beyond the 4 pillars, you have other second line drugs like ivabradine. You have the concept of giving iron therapy, combinations like hydrolazine nitrate. So there are multiple forms of therapy so that all patients can be treated. What is more important, what I'm going to emphasize today is that the treatment of heart failure starts much earlier, not when a patient has already developed heart failure, is an advanced heart failure. You have a stage when the patient has only risk of heart failure. He is diabetic, he is obese, he has hyperlipidemia, he has hypothyroid. That's a stage when there is a risk of heart failure. From that, the patient develops heart failure. Patient improves. So those are phases where you have to be aggressive in treating. Today I'm going to focus on what is called worsening heart failure. Then a patient of heart failure who has stabilized then again starts decompensating for the first time. That is a period of worsening heart failure, which I'm going to emphasize. And then once he's had his first episode of decompensation, these episodes will keep recurring. And that's where we have come up with this consensus statement, which has been there all over the world. What is worsening heart failure? A patient with heart failure previously diagnosed who has now come back to you with another episode of decompensation where you have to increase his therapy in some form, and usually this would mean that you increase his diuretic dose. Not necessarily an intravenous dose, not necessarily requiring an admission, even just an increase in the oral diuretic is a worsening heart failure. Why do we need this kind of definition? Because this patient will ultimately have a poorer outcome as compared to a stable patient unless you are very aggressive in treating this patient. That is why we have defined this kind of category separately, because this patient needs to be treated very aggressively. So basically this patient has to be treated very aggressively simultaneously with all possible drugs, all the 4 pillars of therapy, including a new molecule which has now come, vericiguat. This basically attacks a new pathway called the cyclic GMP pathway, basically which increases the nitric oxide content in the body, as Ajay also said and Dr. Jain also said, and this improves the remodeling in the body. This is the pathway. It reduces the inflammation in the heart, improves the vasodilation in the blood vessels, and reduces the fibrosis in the kidney. I won't spend too much time going to the details of this. Basically, the benefit of vericiguat has been shown in the sickest of patients. That means the Victoria trial took patients who were very sick, patients who had been excluded from most of the other trials, patients who had been recently hospitalized, had the highest possible BNP levels, and which had been excluded from the other trials. And in this subgroup, it showed a benefit and reduced hospitalization. So this was a subgroup. Patients recently hospitalized in the past 6 months had a high BNP. So they had to have a high BNP. If the BNP had normalized, they had not been hospitalized, these patients were not included in this trial, and hospitalization was reduced by this. BNP levels were also reduced, and there were no major side effects with this. Based on this was included in the guidelines that in patients with worsening heart failure, vericiguat should be considered as a drug of choice. Now, just to see how do I consider using this drug in a patient. Now, what you have to understand is that if you have a patient who's sick, which are the drugs you would start initially? You would always give a diuretic, you would always give a vasodilator, you would always give a drug like SGLT2 inhibitors, because these drugs act very fast. Vericiguat also acts very fast. Beta blockers take some time to bring in the benefit. So beta blockers you would bring in a bit later because they will take a few weeks to give the benefit. You can be a bit slow with the beta blockers. This is the strong HF trial. Ajay was saying there are various kinds of protocols we can use, but the strong HF says that when you have a patient who's sick, you should start all drugs simultaneously. Within a month, try to get all drugs in the patient, and within 1 or 2 months, get as high a dose as possible in all the patients. And this has shown benefit that a high intensity regime brings benefit very fast in all the patients. So just to give you an example with the patient, how do you apply all this knowledge in a patient? So this is a patient who's come to us. He's a 30-year-old, very sick patient, multiple hospital admissions. He was at that time when he came on a diuretic, was on an antiarrhythmic, he's on digoxin, and he's had multiple decompensations. Now what do? He was not on a vasodilator, so we added a ramipril, not on SGLT2, we added SGLT2, added a very low dose of a beta blocker, not a very high dose, and we added a starting dose of vericiguat, and we gave some iron also. So we've given something. As you can see, his hemoglobin is also somewhat down. We've given the starting doses. We had made sure that he's on all 4 pillars of therapy, not on the full doses, but the starting doses. He comes back. His admissions are still occurring. His admissions have not stopped. Blood pressure is still reasonable. eGFR is still reasonable. So we switched from ramipril. We switched to Arni. And as you will note, the Arni he's getting is 50 milligrams 3 times a day. You don't have to so strictly follow a twice daily regime. You can easily go to 3 times, 4 times a dose, because that way the blood pressure fluctuations become less and you can go to higher doses. Patient can tolerate higher doses. Vericiguat has now gone up to 5 milligrams. Dapagliflozin from day 1 was 10 milligrams, which is the full dose. So dapagliflozin you can give full doses from day 1. It does not cause any blood pressure problems. You have to only tell the patient to be a bit more careful about the hygiene in the genital areas. Next admission, patient comes, BP has started falling. So there's a problem with the blood pressure. So Arni doses have to come down, but you also note that his diuretic requirements are going much higher and higher, and at this point we advise him to be listed for a heart transplant. By this time we also gone up on the vericiguat. So vericiguat is going up every 2-3 weeks from 2.5 to 5 to 10 milligrams. Vericiguat has to be increased very slowly over every 2 weeks. So 2.5, 5 and 10. It doesn't cause a fall in the blood pressure too much, but the increment is every 2 weeks. So now once he's on these levels of doses, his symptoms stabilize to some extent. He's not stabilized totally, but at this point he's on Arni of 25 milligrams once a day. He's not tolerating more than that. Dapagliflozin of 10 milligrams, vericiguat of 10, and a very high dose of torsemide. He remains stable, ultimately gets transplanted. So it's not that you avoided a transplant, but you've stabilized the patient sufficiently to let him get to a transplant. So you cannot always change the course of a disease, but you can stabilize the patient so that he can go on to the next stage of a disease. Just to very quickly show you some pictures, there are Indian initiatives that we've done. We've trained heart failure nurses. You can train your paramedics to also work with you in heart failure. You can use various kinds of checklists which we have been developing, which you can use in your OPDs, various kinds of very simple checklists. This is called the ABCD checklist. A is for your ACE inhibitors, Arnis, B is the beta blockers, D is the diuretic, C is everything else. So supposing you find your nurse or your paramedic has filled this form and B is missing, that means the beta blocker is missing. You can check why is the patient not taking a beta blocker, very simple thing. This is something we call the Hriday card, again contains a checklist inside and a pictogram to explain to the patient what medicines to take. So to summarize, in today's era, all patients of heart failure can be treated with quintuple therapy. Beyond the 4 pillars, vericiguat is very useful in your sick patients. You should use all the drugs early. Don't go for sequential therapy. Use everything from day 1. You can start with very low doses, build up on all the doses, start with vasodilators, start with ACE or ARB, switch to Arni very fast, start with very low doses of beta blockers, increase the beta blockers slowly, add your SGLT2 inhibitors on full doses, add vericiguat in patients with worsening heart failure, and then go up on the doses. Thank you very much.
Thank you, Dr. Seth. I think we will have the questions at the end.
Our next speaker will be Dr. Deepak Kalra. Dr. Deepak Kalra is a well-known nephrologist associated with the Fortis Hospital, Shalimar Bagh. He has 25 years of experience in nephrology and has worked as an expert in different cities in India. Dr. Deepak Kalra has contributed to handling numerous complex medical cases in several hospitals. He is known for his attention to accurate diagnosis and treating patients emphatically. The specialty interests of Dr. Deepak are hematology, kidney transplant physician, clinical nephrology, and diabetic hypertension. He is also an active member of the Delhi Medical Council. Dr. Kalra had his MD in medicine from King George Medical University, Lucknow in 2002. He has also completed his DM in nephrology from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow in 2008, and he has participated in research work and various workshops under the nephrology department and published many papers. He is MBBS, MD and DM in nephrology, and he has got great work experience as a consultant nephrologist in various hospitals like Bhagwati Hospital, Delhi, and Jaipur Golden Hospital, Delhi, and many more. Thank you. Dr. Kalra.
Thank you, Honda sir. So, today I am going to talk about one of the established 4 pillars of management of heart failure, the role of mineral corticoid receptor antagonist in heart failure and diabetic kidney disease. Heart failure and CKD remain a major cause of morbidity and mortality globally. Neurohormonal activation plays a key role in chronic kidney disease and heart failure progression. Mineral corticoid receptor overactivation causes inflammation and fibrosis, brings about hemodynamic changes like elevated blood pressure and intraglomerular pressure, poor glycemic control, all ultimately leading to glomerular injury, fibrosis, and leading to kidney failure, and in the heart causing fibrosis, cardiac remodeling, and heart failure. Mineral corticoid receptor overactivation is a potential treatment target to reverse heart failure and slow down chronic kidney disease progression. Spironolactone was the first MRA which was introduced in year 1960. It was initially thought to be only a potassium sparing diuretic, but the 1990 landmark RAISE trial proved mortality benefit in heart failure with reduced ejection fraction. In the year 2000 came eplerenone, a more selective steroidal MRA, and now we have non-steroidal MRAs, Finrenon, which have been developed in the later years. Spironolactone was introduced in 1960. The problem was it was a non-selective binding mineral corticoid receptor antagonist, lot of endocrine side effects, gynecomastia, impotence, menstrual irregularities. But with the RAISE trial, it became cornerstone in heart failure treatment after RAISE trial. So the RAISE trial, the study population included patients of severe heart failure, reduced ejection fraction less than 35%, and severely symptomatic NYHA class 3 and 4 patients. Spironolactone was compared to a placebo, and it showed 30% reduction in all-cause mortality, 35% reduction in hospitalization for worsening heart failure, and thus MRAs had established role in treatment of heart failure with reduced ejection fraction. The major concerns were hyperkalemia, and after this trial, a lot of spironolactone was being used clinically, but soon we realized that hyperkalemia was a big challenge in clinical management of these patients, especially those who had renal dysfunction, diabetes, or there was concomitant use of ACE inhibitor ARBs. In fact, some of the trials showed that in advanced chronic kidney disease, with the addition of spironolactone on ACE inhibitor ARBs, hyperkalemia incidence was as high as 40 to 60%. The other side effects, gynecomastia, impotence, menstrual irregularities, all necessitated search for more selective MRAs. And thus came eplerenone. Eplerenone was developed mainly to minimize the hormonal side effect. It had greater selectivity for mineral corticoid receptors versus the androgen and progesterone receptors. The first major trial with this molecule was published in 2003, FSS trial. The study population included patients with recent acute MI with LV ejection fraction less than 40% and clinical heart failure. The result showed significant reduction in all-cause mortality and cardiovascular hospitalization, and this cemented the role of eplerenone in guidelines for heart failure after MI. The second trial, which was published in the year 2011, emphasis heart failure trial. The study population included patients with heart failure with reduced ejection fraction less than 35%, but with milder symptoms, NYHA class 2. These patients were already on beta blockers and or ACE inhibitor ARBs. The trial had to be stopped early due to significant reduction in risk of death and hospitalization. The trial extended the MRA benefit to patients with less severe symptoms, NYHA class 2, and LV ejection fraction 35%, less than 35%. The safety profile of eplerenone was much better. It had lower endocrine side effects, but hyperkalemia still persisted, though it was significantly lower as compared to spironolactone. Eplerenone is contraindicated in patients with less than 30 ml GFR, and when you use it in patients with CKD with GFR between 30 to 50 ml, use it only at a dose of 25 milligram, not at the recommended dose of 50 milligram, which is usually used in heart failure patients. The third and the new kid on the block is Finrenone, a non-steroidal MRA. So Finrenone and steroidal MRAs have distinct chemical structures and mode of binding, leading to different downstream effects. If we compare it in terms of potency, it is as potent as spironolactone, but it is much more selective than spironolactone and eplerenone. Due to high selectivity, Finrenone shows lesser risk of breast-related side effects. Also, the half-life is lowest, and there are no active metabolites of this molecule Finrenone. Short half-life and no metabolites lower the risk of hyperkalemia. Also to mention, it is not a potent antihypertensive. Spironolactone and eplerenone have been used in resistant hypertension, but you can't use this molecule as an antihypertensive drug. Very low reduction of blood pressure it causes. Major trials with Finrenone in heart failure. One of the most important trial is FinArts heart failure trial. It is a phase 3 randomized double-blind placebo-controlled trial, included 6,000 patients. Finrenone was studied against a placebo. Duration of mean follow-up was 32 months. The major inclusion criteria included patients with more than 40 years, diagnosis of heart failure with preserved ejection fraction, LV ejection fraction 40% or more, elevated NT-proBNP, structural heart disease, stable background therapy for heart failure. All patients with less than 40% ejection fraction were excluded. eGFR 25 ml or less was excluded. Serum potassium greater than 5 at the screening. Patients more than 5 serum potassium were again excluded. CABG, stroke, TIA within last 90 days, PCI in last 30 days were included. So were excluded were SBP greater than 160 millimeter Hg. So these 6,000 patients were randomized into two groups, a placebo and the other group receiving Finrenone 10, 20 or 40 milligram based on the eGFR. The primary endpoint that was studied was number of cardiovascular death and total heart failure events. Secondary endpoints were total heart failure events, NYHA class improvement and renal composite endpoints, all-cause mortality. Finrenone demonstrated a clinically meaningful 16% relative risk reduction in the composite of cardiovascular death and heart failure events, p-value 0.007. Different in treatment effect on composite cardiovascular outcomes were observed very early and remained consistent throughout the study period. The statistically significant reduction in the composite cardiovascular outcome was driven mainly by the reduction in heart failure events. So if you compare the cardiovascular death, there was not much difference between the placebo and Finrenone treatment arm, but the heart failure events were very significantly reduced in patients treated with Finrenone compared to placebo. The effect of Finrenone on the primary outcome were consistent regardless of LV ejection fraction and background therapy at baseline, including SGLT2 inhibitors. So whether the ejection fraction was preserved or it was slightly reduced, Finrenone scored better than placebo in terms of reduction of hospitalization for heart failure, and whether SGLT2 inhibitors were being used or not, Finrenone was better than placebo again. Finrenone increased the risk of manageable hyperkalemia, and the incidence of hypokalemia was numerically lower compared to placebo. So if we look at the figures, Finrenone again causes increase in potassium. The investigator reported hyperkalemia was 9.7%, 4.2% in the placebo group. However, serious adverse event leading to death or hospitalization were almost equal in the two arms. Serum potassium more than 6 millimoles was 3% in the Finrenone and 1.4% in the placebo group. Hypokalemia, that is serum potassium less than 3.5 millimoles, incidence was numerically lower for Finrenone compared to placebo. Coming to Finrenone trials in chronic kidney disease population, there are two major trials, Fidelio trial and Figaro trial. Together they comprise composed more than 13,000 patients were studied in these trials. So this is one of the largest trials in the CKD population. Till now, the largest trial was EMPA kidney disease, which had 6,000 patients. But Fidelio and Figaro together. So Finrenon has been very well studied in CKD population, diabetic kidney disease population too. So in this trial, Fidelity trial is a pooled analysis of Fidelio and Figaro trial. 13,000 patients of stage 1 to type 4 CKD diabetic patients were included. There was a run-in period of 4 to 16 weeks where patients were put on maximal tolerated dose of ACE inhibitors and ARBs. Then they were randomized in 2 arms, placebo and Finrenon 10 milligram or 20 milligram. The study included patients with advanced chronic kidney disease. Around 7% patients had a GFR below 29 ml. The lowest GFR that was studied was 25 ml. There were early kidney disease patients to the tune of 40% having GFR more than 60 ml but having moderate to severely increased proteinuria. Other important factors were RAS inhibitors was being used in 99% patients, SGLT2 receptors in 6.7% patients. There was 14% relative risk reduction in composite cardiovascular endpoints. Hospitalization for heart failure was reduced by 22%, composite endpoint reduction, kidney endpoint reduction in 23% patients, 20% relative reduction in dialysis. So because of this overwhelming data, European Society of Cardiology recommends Finrenon in patients with CKD and type 2 diabetes mellitus to reduce the risk of heart failure as a class 1A indication. Finrenon has been recently studied in confidence trial where they have used a combination of Finrenon and empagliflozin, and they have shown that the combination reduces UACR significantly more than any other agent alone. Overall adverse effect profile of this combination of empagliflozin and Finrenon was equal in both to either being used again. So we have now 4 pillars of pharmacological intervention to prevent progression of diabetic kidney disease: RAS inhibitors, SGLT2 inhibitors, non-steroidal MRAs, and GLP-1 receptor agonist. If we use all these RAS inhibitors, SGLT2 inhibitors and Finrenon and compare it alone to the usage of RAS inhibitors, the combination can increase the decrease the hospitalization for heart failure by 3.1 years. It can delay the dialysis of the patient by 4.9 years, and it can delay the death by 2 years. So Finrenon has presently been approved by US FDA for use in type 2 diabetes mellitus patients with CKD to reduce the risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI infarction, and hospitalization for heart failure. Finrenon has recently been approved by US FDA for use in adults with heart failure with mildly reduced or preserved ejection fraction. So we can say now there are 5 pillars for management of heart failure: ARNI, ACE inhibitors, beta blockers, steroidal MRAs for heart failure with reduced ejection fraction, SGLT2 inhibitors, and non-steroidal MRA Finrenon for heart failure with preserved ejection fraction or slightly reduced ejection fraction. So coming to the end of my talk, MRAs are an important pillar in management of heart failure and diabetic kidney disease. Hyperkalemia and androgenic side effects are a challenge with steroidal MRAs. Finrenon, the newer MRA, has renoprotective benefits in diabetic kidney disease. It has been recommended to be used in diabetic kidney disease patients to reduce renal disease progression and reduce cardiovascular events. Finrenon has been approved by US FDA for treatment in adults with heart failure with mildly reduced or preserved ejection fraction. Finrenon has no androgenic side effects, and incidence of hyperkalemia is lower than spironolactone and probably less or equal to eplerenone. Hyperkalemia and initial fall in GFR are the main caution points when you use Finrenon. Thank you.
Thank you, Dr. Kalra. So now we have a set of 3 talks focusing on ARNI, and I will be one of the speakers, and then there are going to be 2 speakers who are going to talk about the role of ARNI in the setting of surgical or medical, interventional revascularization, and the role of ARNI in patients with CKD. So I will start with the first talk, and I think thank you very much.
Okay, so for this symposium, we have Dr. Piyush Jain, sir. He's a Director Cardiology and Head, Department of Preventive Cardiology, Fortis Escort Heart Institute, Okhla Road. He's a guest faculty at national and international conferences in India and abroad. He is also a former editor-in-chief, The Heart of the Matter, bi-monthly journal of heart and diabetes care, author of 16 books of medicine and health in English and Hindi. Some books also have been translated in regional languages as well as in Indonesian Bhasha.
Thank you very much. So, as my topic suggests, I will be talking about the ERNI in Indian context. We have very limited data on that, but I would like to focus on what is known and what is not known regarding the magnitude of heart failure in this country, how has been the prognosis in real life settings, and then of course the efficacy of ERNI in the Indian patients, and some challenges like underdosing and underuse. So this is going to be a very general kind of talk, and this is my disclosure. And as I said, what are the concerns with heart failure patients in India? So the magnitude of the problem is huge, and the estimates have varied very widely from 1.3 million to 23 million, and that reflects the lack of proper screening on a wide basis in the community. So whatever data we have is mostly based on the hospital data, which actually is not representative of the true picture. So difficult to say, but all I can say is that there are millions of people, and the number of cardiologists who are practicing heart failure management are very few, but that does not mean that we should not treat heart failure. All of us, every physician, every clinician, even a good MBBS doctor can actually treat heart failure in, at least in the community. And maybe one could exclude patients who require hospitalization in tertiary care centers, but heart failure is a very common condition, and the treatment is very simple actually. If we recognize heart failure in early stages, and that is not difficult provided we think about it. And I remember one quote from Harrison's Principles of Internal Medicine: left ventricular failure is something which is the most missed diagnosis in the community. And that is true actually. So what happens when the patient develops heart failure? So whatever may be the reasons, and I'm not going into the reasons, but a large proportion of patients who have heart failure, they not only get admitted, but they keep on getting readmitted. And in fact, 1 out of 3 patients who get admitted as the index event, they get readmitted, and almost 1/3 of them will die within 1 year during their productive life years. So that means the prognosis of heart failure in our country is really dismal. So one needs to improve that. So let's just compare as to how do we do as compared to some of our neighboring countries and some emerging economies like Southeast Asia, Middle East regions, South America, China, and I'm not comparing this with the Western populations, but I'm also going to make some comparison with the sub-Saharan African countries. And if you look at the mortality at 1 year in patients with heart failure, there are various causes of heart failure, various causes of mortality in heart failure. Not every patient with heart failure will die of heart failure. But look at the proportion of people dying of cardiovascular causes of death. This seems to be the highest amongst Africa, Southeast Asia, Middle East region, South America and China. So though it is not a direct measure of the death from heart failure, it seems that the cardiovascular death in patients who have heart failure, they die very often from cardiovascular deaths, and most likely these are probably because of worsening of heart failure. And not surprisingly, the adjusted survival curves, if you look at it by these regions, you find, except for Africa, our survival rates are actually the least amongst all these countries like China, South America, Middle East, Southeast Asia. And it is not only to blame the treatment strategies or follow-ups or compliance, it may also be because of biological reasons. We actually have not gone into all that. Sorry. So, heart failure readmissions occur very often. Readmissions occur very often, and with each readmission, the prognosis becomes worse and worse. But there is no difference between men and women. It is irrespective of the ejection fraction at the baseline, and you find the risk of readmission at 1 year is 30% in heart failure with reduced ejection fraction as well as with preserved ejection fraction. So it is not correct to say that patients who have got low EF are at the higher risk of readmissions. And about 5 to 6% patients, they get readmitted again and again. So the problem is really huge. And this is responsible for higher mortality in the Indian heart failure patients. And this mortality keeps on increasing with repeated readmissions, as I said, and this graph clearly shows that 1 year mortality is significantly higher in patients who have more than or equal to 1 hospital readmission. And this is not something that stabilizes. Like in coronary artery disease, you have acute coronary syndrome. For the first month or so, or first 3 months or so, or first 1 year, the risk of recurrence of an acute coronary event is high. But as the patient stabilizes, the risk of getting an acute coronary event over next few years is something like maybe anywhere between 1.5 to 2.5%, but not heart failure. The heart failure mortality keeps on increasing with time, and the cumulative 3-year mortality is still close to 50%. It may have reduced as a result of the treatments that are available, but if you ask me whether heart failure mortality in our country has, or elsewhere also, tremendously reduced and now it is much, much less than what it was before, I will actually not say that. But of course, the morbidity and heart failure readmissions, they are reduced substantially, provided we are able to institute the guideline directed medical therapy and the patient is adherent to the treatment. So lack of guideline directed medical therapy is associated with higher risk of mortality in Indian heart failure patients, as was observed in the Trivandrum heart failure registry. So the question that could be asked is, what has been the impact of ERNI on the heart failure management in India? So the Indian consensus is that sacubitril valsartan should be initiated early in the patient with heart failure and reduced ejection fraction regardless of the previous therapy being given. Secondly, switch from ARBs and ACE inhibitors to early ERNI intervention in all patients with heart failure with reduced ejection fraction is highly desirable. Thirdly, ERNI can be safely initiated in de novo heart failure patients who are ACE naive. So there is no need to start with ACE and then go on to ERNI thinking that the patient is not responding symptomatically or getting readmitted. That's not the right time. The right time for a newly discovered heart failure patients for institution of ERNI therapy is the time when you diagnose it. And lastly, ERNI should be started in all patients with acute decompensated heart failure before discharge once they are off all 4 parenteral inotropes and the vasodilators, provided the patient is right, in the presence of AKI or unstable serum creatinine, hyperkalemia or symptomatic hypotension. That is not the place where you will start hernia. So I will not repeat this in the interest of time, and I already said that the ACC 2024 consensus documents, they also recommend a de novo hernia approach, which means don't start with ACE inhibitor or ARB first and then go on to hernia, and start with hernia directly in a patient with heart failure with reduced ejection fraction. So ESC guidelines, they also recommend sacubitril valsartan as a first-line cornerstone therapy for all heart failure with reduced ejection fraction patients. So the main trial, or the first trial on hernia, that changed the face of heart failure treatment, and we started switching over from ACE inhibitors to ARB, hernia, which is a combination of sacubitril and valsartan, which is an ARB, was the Paradigm HF trial, and this was the new evidence which appeared in 2016. And as you can see, nearly all the endpoints, including cardiovascular death and heart failure hospitalization, and a composite of the two, there was reduced by about 20%, and it was not a placebo controlled trial. It was a trial where hernia was compared with enalapril, which was the standard of care of treatment at that time, and this is something which led to a significant decrease in the rate of hospitalizations as well as rehospitalizations. So the last question that you may ask me is whether sacubitril valsartan shows similar survival benefits among Indian patients as compared to the overall Paradigm HF, population. You find that first heart failure hospitalization in limited studies have shown that there is once again about 22% reduction in the first heart failure hospitalization, and also about 12% reduction in the all-cause death, and about 13% reduction in the cardiovascular death as compared to enalapril. So looking at this particular diagram, you can say that whether you are talking about the primary composite outcome or cardiovascular death, heart failure hospitalization, or all-cause death, comparing the Indian data, whatever we have available with us, compared with the global data, the benefits are directionally the same, and the magnitude of the benefit is also almost the same, around 20%. So I think I will finish here, and this was a continuing dialogue, and can I request my chairperson to introduce the next?
Call the Dr. Udgamgir and Dr. Manish Jain over the dais, please. Dr. Udgamgir is a cardiac surgeon, and Dr. Manish is a nephrologist. So they will make a presentation. All the panelists will come here and have a discussion of
okay.
Do they have slides?
It's okay. Let them use the slides if they want. So, Dr. Dheer, would you like to use the slides, or you will just have an open discussion? Okay, fine.
You have the slides? You have the slides? Please, Dr. Deepak, also join us.
Chairs coming up.
Hello.
Dr. Bimit, उधर आइए सर वहाँ पे
चेयर कैन बी टेकन सर चेयर कैन बी टेकन सर एक ही बात
Mike. So we have a good number of discussions, and thank you all the eminent speakers. Dr. Sandeep Seth has to left for that some important work, but now as we have a nephrologist and CTV surgeon also. So I would like to ask sir, you Dr. Udgamgir, that in post bypass patients and the patients like who has an LV dysfunction and then they go for surgery. So do we need to treat them once the ischemia is corrected, and we need to give this anti-heart failure therapy for a longer duration, or is once it's being corrected and then we don't need this kind of therapies?
It's a very beautiful question it was asked. See, I think I am the only surgeon in this whole, and I belong to a family of physicians. Me and my brother, we are only 2 surgeons. And sorry, I'll just take 10 seconds. And my father used to say, that you only know how to use the knife, you don't know about anything about medicine. That is a general perception among the physicians. But no, we also have been taught by our cardiology colleagues and all that. Very apt question he asked, that post-revascularization. See, post-revascularization, this was a dissertation topic of one of the DNB students of nuclear medicine, because I was getting a PET scan and we were getting all post-PTCA and severe LV dysfunction patients who had viable myocardium, and we had to go for intervention, maybe bypass surgery or mitral valve repair, or a stenotic heart, aortic stenosis who has gone into LV dysfunction and all that. So mechanical problem has to be dealt mechanically, but we need some time to tide over that failure post-op. So post-op we had drugs like dobutamine, levosimendan and all that, but after that what? So oral previously, as cardiology taught us, was the ACE inhibitors and ARBs. But Ernie changed it was a paradigm shift, and with new drugs, I would say with vertigo at times, post-op, patients who are not tolerating Ernie. We started with 25 milligram once a day even. And their anti-pro-BNPs, that is my usual this thing, because it was a part of dissertation topic also, drastically dropped. So post-op, even with post-CABG, who have severe LV dysfunction, who have moderate mitral regurgitation, whom we are not treating, they are not the candidates for mitral valve replacement or repair. This Ernie is a very good subset in treating those patients who have ejection fraction between 35 to 45 years. Previously, we were starting only in patients with severe LV dysfunction less than 35, but patients who have ejection fractions of 40 with moderate MR, partly a component of ischemic MR, post-revascularization, their MR doesn't resolve so easily because there is a tethering at the posterior leaflet and because of inferior wall damage. This Ernie has reduced their anti-pro-BNP, and I have data whose anti-pro-BNPs are less than 175. I'm talking of patients who are less than 65 years of age. And it is documented data in all Indian patient data. So I would say post this Ernie, it's very helpful for surgeons also, because those patients, they don't come to us for. And second thing, what you were saying, sir, once a patient of heart failure, that's a cardiology teaching. Once a patient of heart failure is always a patient of heart failure. So you have to monitor it, you have to continuously give those drugs. It is not about, we have dealt with the mechanical problem, but once they come out, their ejection fraction improves. Still these medications, they cause reverse remodeling, and these patients, they fare much better as compared to the guys who are not on any drugs. Thank you.
As Dr. Piyush has already recommended and told that to continue the medication of heart failure. So my question to both of you is, once that correctable lesion has been corrected, like severe AS with LV dysfunction, can we stop these medications once the heart failure has improved, and when you have mechanical obstruction has been removed, or patient who has an ischemic cardiomyopathy, the ischemia has been revascularized and the patient has improved LV function. Do we still continue this heart failure therapy for a longer duration or the lifelong?
So the point is that once the patient has got LV dysfunction, it never becomes normal. So the definition of improvement is rather arbitrary. The definition is that the patient should have a post-treatment LVEF of more than 40% and an absolute increase in the LVEF of 10% or more. That is one. The second point is that most of these patients will still continue to have at least mildly reduced ejection fraction. And the remodeling that has taken place over a number of years maybe does not become normal always, not even once, So the recommendations, and I agree with those recommendations, that you have to continue treating the patient with the guideline directed.
So that's what therapy. My question was to, first of all, my apology, Dr. Ajay Agarwal, please join here over the stage.
So I'll comment.
Yeah.
Very apt question, sir, you have asked, that post aortic stenosis, where the mechanical problem and LV dysfunction, and once his ejection fraction comes above 45 and 50, what to do? So sir, there are around, that also means I can say with data because I have all that. So 40% of the patients, they are diabetic and hypertensive too. And now the combination of antihypertensive drug, so Arni has valsartan. So valsartan is, as compared to all the ARBs, that is, so that's why. Yes, there is a patient whom we recovered above 50%. We have changed to ramipril. But yes, means changing from ramipril or telmisartan to valsartan, that would be your personal choice. But as far as for coronary artery disease, see, coronary artery disease, what we are dealing, whether we are doing stenting or whether we are doing surgery, we are dealing with the macroangiopathy. We are still not dealing with the microangiopathy. What my subset of patients, 70% of the patients are diabetic, have a borderline CKD, hypertensive, smokers, and all these. So these drugs in any way, these patients will be persistent on heart failure. So continuing on their drug with lifestyle modification would be,
Sir, actually, if you see from the patient perspective, once he has undergone a surgery or a procedure, he expects कि now दवाइयाँ बंद हो जाएंगी, and the heart failure, when we tell them कि oh, you have a HFrEF patient, your ejection fraction is low, so you need to take medicine, then he comes back कि अब operation भी कर दिया, heart failure normally भी हो गया, ejection fraction, still I have to take this bunch of the medicines.
So what I say, I can just tell you in the open. मैं कहता हूँ गाड़ी में बार बार पेट्रोल बढ़वाना पड़ता है, तभी गाड़ी चलती है.
Thank you, sir.
पेट्रोल बढ़वाने के लिए ये दवाइयाँ लेनी पड़ेगी.
So we have an eminent nephrologist also with us, Dr. Manish Jain. So we all, Dr. Udgam also discuss about the CKD and heart failure, and that's what we are discussing. And when we treat a heart failure patient, definitely the renal function is a very key factor when you want to give an MRA, when you want to give an ARNI. So renal function has to vary. So what are the choices of therapy in Indian patients who has heart failure with CKD? Because if you give an ARNI, then creatine rise and then creates a problem for the कि ये tablet ली इसलिए बढ़ गया. If you start an SGLT2, तो creatine बढ़ गया, then again they have a question. If you give an MRA, then they have an hyperkalemia. So how to differentiate and what would be the better choice and how to monitor these patients?
Sir, already this has been discussed, and actually the heart failure treatment has been a revolution for the physicians in last few years, and there are so many drugs. Previously we used to have only ACE or ARBs, but if you see last 10 years in our armamentarium, SGLT2 inhibitors, ARNIs are there, then non-steroidal mineral receptor antagonists are there. So these all are there, and once already Dr. Ajay Agarwal was saying and Dr. Jain was also saying, like we generally suggest that we should go in a sequential way. So initially we can start with the SGLT2 inhibitors, watch it for a week and watch for the creatinine rise. If it's not too much, then you can introduce the ARNIs. So
but Dr. Piyush was recommending to give all the 4 medications.
All the 4, but then the GFR definitely goes down. If it deteriorates, then we don't know which one is causing the much more deterioration. So that approach is also good, but sequential way if we are adding. So in that way you can easily come to know which drug is causing much more damage, and then you can withdraw it or you can stop it, accordingly you can reintroduce it. So my practice is I'll give SGLT2 inhibitors first. Once they tolerate it, wait for a week or 2 weeks, again repeat the KFT, then you add the ARNIs. And
so in DKD or in kidney disease, you don't have heart failure with reduced ejection fraction all the time. Very often you have heart failure with preserved ejection fraction. So unless there is any other indication for beta blocker, they should not be given. That is number 1. But otherwise the medical management is the same. SGLT2 inhibitors, norepinephrine, and maybe even ARNI in stable patients where hyperkalemia is not a great concern. That is briefly speaking like that.
Very true, sir. That's very important, and just our patients, they are taking very potassium rich diet because it generally it goes in a thing. आप कमजोर हो नारियल पानी पी लो या ये fruits खा लो नींबू वगैरह जो वैसे general population, these are very good, but we should tell them have a good dietary counseling that they should have a potassium restricted diet, because ARNIs will also cause hyperkalemia, phenylenediol will also cause hyperkalemia, so these cares have to be taken. With SGLT2 inhibitors, you need to take a genital care, foot care, and for fungal infections.
Thank you. Any question from the audience? Otherwise, I
would like to. So, see, it was that the post-surgery, there is a very, this thing that ARNI will drop the blood pressure. That is the most common thing, and the creatinine will rise. So how I am not saying there are August, because this has been taught by my colleagues and my seniors who are nephrologists, who are cardiologists and all that. So they advise me. So what I did was, I start post-surgery, day 3. Once the patient is out of ICU mobilized, I start with a low dose of Arni, not 50 milligram twice daily, 25 milligram twice daily. Regularly monitor their blood pressures. Get their potassium levels done every 3rd and 5th day. And get their creatinine levels. Those who are CKD, who have creatinine above 5 or eGFR less than 70 also. And if their creatinine doesn't rise more than 25%. So how I explain, that has been also taught to me by nephrology colleagues, right? We have a long association for more than, I would say, 18 years and all that, and we have worked at multiple hospitals together. So we tell them that don't go by the creatinine level. If the heart is functioning properly, your kidneys are going to get benefit. So the point is, the potassium has to be monitored, most important, the dietary restriction. I have a patient admitted right now, what he was saying, Nariyal Pani. He had 7 Nariyal Pani in a day, and he came with a potassium of 7.2. We had to get a dialysis done just because of Nariyal Pani. Doctor Sahab, juice se और Nariyal Pani se शरीर में ताकत आती है, and post-op we face it a lot. Everyone who comes there, post-op, नहीं ये कमजोर लग रहा है. They will not realize कि अभी सर्जरी हुई है, हीमोग्लोबिन भी कम है, नहीं कमजोरी लग रही है डॉक्टर साहब, खून चढ़ा दो या नारियल पानी दे दो. That is the most important thing. So I would. नहीं सर आप बोलो.
मौसमी भी दे दो सर, मौसमी का जूस भी दे दो नारियल के साथ साथ.
बिल्कुल सर.
ऑडियो पोटेशियम बढ़ जाएगा. My very simple question. Can we use the RD in the acute setting, like patient with the acute MI?
No, sir. Sir,
so how many,
post MI, we don't give, yes, okay, guidelines I think cardiologists are setting, but still post MI, and if we have operated an acute MI patient and he requires surgery, we usually don't start anything before 6 weeks.
Sir, to you, one question.
2 points regarding, sorry, can I speak? Yes. This problem of hypotension with ARNI or with ACE inhibitors, it is compounded by a very wrong kind of advice to the patients, particularly by paramedics. Don't have more than 1 liter of water. So hypovolemia is a major contributor to hypotension, particularly in patients who are recovering from acute illness. And of course, we have to see whether the patient is getting any vasodilators, and not in the usual sense, but something like alpha blockers. Many patients have prostate, and they are getting alpha blockers. So if you remove these things, then one could actually manage with a decent dose of ARNI. The second point is regarding hyperkalemia. We always think of juicy fruit juices, coconut water, a banana, but we tend to forget that even tomatoes and nuts, they also have very high potassium. The last point is regarding indigenous salts. I have been asking this thing prospectively from my patients when they have hyperkalemia. Are they using some indigenous salt, pink salt, sendha namak? And 90% of the times they are taking sendha namak. And none of us actually knows what is there in sendha namak. So, and many a times, not always, but many a times, if they stop sendha namak, their potassium tends to come down very significantly.
As well as the Lona salt also that comes.
Lona,
low sodium salt also is a richer source of potassium.
Yeah, Lona, yes, very correct. But sendha namak getting very popular for some reason.
So I would agree with all the 3 points, sir.
Yes.
When you use ARNI, especially in patients who have hypovolemia,
yeah,
the blood pressure is going to fall, and there is incidence of AKI also increases.
Yeah.
So especially cut down the dose of diuretics when you start ARNI, and especially when already patient is on SGLT2 inhibitors. The combination of SGLT2 inhibitors and ARNI especially causes lot of hypovolemia and hypotension. So cut down the dose of diuretics at that point.
And keep the fluid intake decent.
Decent. Second point, the third point, this Lona salt, salt substitutes are very commonly, these are the causes of hyperkalemia definitely. It has 3 times more potassium than the normal salt. In fact, normal salt, sodium chloride, is sodium chloride. Lona salt has around 3 times potassium.
Yeah. 36%,
and magnesium.
36%.
Yes.
So as Dr. Udgam told about blood pressure, that at low blood pressure we should start. One is that can we start with the 25 milligram which is not available? Just last question. And secondly is what blood pressure should we give as a cutoff to the patient at home? Okay, this is the cutoff that if it is going beyond or going less than this blood pressure, we should be worried about it.
Actually, it is symptomatic hypotension is
So,
something.
but we need to give some stats because the patients are very curious about when the blood pressure comes less than 100. Then they used to ask it, what's the blood pressure come aa raha hai? And then you ask the symptoms. Sometimes they are there, sometimes they are very mixed symptoms. So you are not able to define whether they are postural symptoms or not.
The rule of thumb is that as long as the patient is asymptomatic and the systolic blood pressure is 90 or 90 plus, it's okay. When it starts going down less than 90, then it should ring a bell in the minds of the doctor as well as the patient. So,
Sir, the use of
but symptoms are more important.
To what extent it improves the left ventricular ejection fraction, LVF?
What's the question?
To what extent it improves?
Sir, I can just tell you one thing. I have a list of transplant patients of 22. Out of that, 15 are right now removed from the heart transplant list because their ejection fraction from 20-25 has improved to above 35-37.
But that is not only because of ERNI.
Not because of ERNI, it's multiple.
The mechanistic studies have shown that with the ERNI, the increase in EF is something like 5 to 8%. But when you combine everything like SGLT2, beta blocker, in the long run, the improvement may be marked. Or there may be no improvement, but the patient has got a reduction in the risk of rehospitalization for worsening of heart failure. And that is what we want, not actually the increase in LVEF.
Thank you, sir. Thank you to all the eminent speakers and the chairpersons.
Talk about 4 on 5 pillars. What about digoxin, which I used to use?
So I think.
No, sir. This is has been relegated to past. Digoxin is still a wonderful medicine because the type of patient we come across, those who do not respond to all the 4 pillars or the 4 pillars cannot be instituted in those kind of patients. Digoxin is still useful medicine. Class 2B indication is still there with the European Society of Cardiology, and the consultant opinion is still there. Though everybody really puts it behind the status to use digoxin, but we use it. And second is the group with the atrial fibrillation also, it is helpful. So both the reasons when the drugs are not effective or cannot be instituted, and 2 is the atrial fibrillation. So 50% cardiovascular mortality, not 50%, but 50% of the patient will really respond to this kind of medicine, and 25% mortality benefit is also there for only from the cardiovascular point of view. All-cause mortality is not there, but cardiovascular mortality definitely comes down with the help of digoxin.
Thank you, sir. Thank you all the eminent speakers and the chairpersons.
Thank you.
And it was a wonderful discussion about the heart failure, that we have discussed about the previous and basic medication, how it started, and what are the current medications, what we are presently having. Thank you, sir. And we can have later on discussion later on. But now, in the interest of time, I think I request Dr. Vandana to start the next session. And friends, next session is now we have discussed a lot about the medications, and being a cardiology sections, we have some new recent development in the cardiology where that intervention can help us, and that's what we have very eminent speakers from the different institutes to guide us where we can help all these new things.
I'll request all the eminent speakers and chairpersons to move forward to the photo booth for the mementos and the photographs over there. Thank you so much. And we will have we had a lucky draw, and the winner is Dr. Sushil Kumar Gupta. Dr. Sushil Kumar Gupta, congratulations, sir. You can collect your prize. And for the next session, which is the interventional cardiology, I request the chairperson to come on stage. Dr. Sanjay Modi, who is a senior pediatrician at Modi Clinic, Ashok Vihar. Dr. Manisha Sinha, she is practicing in Wazirabad. Dr. Satish Tyagi, he needs no introduction, is a past president of DNZ and president-elect currently. He is also the past general secretary of DMA and a senior, very senior surgeon at Tyagi Hospital and Max Shalimar Bagh. Dr. Kuldeep Kumar, who is medical officer at Ministry of Health and Family Welfare. I'll request all the chairpersons to come on stage, please. I request the chairpersons to introduce the first speaker and start the sessions, please.
Hello, good afternoon. The first speaker is Dr. Atul Mathur. Dr. Atul is the chairman of Interventional Cardiology and chief of Cath Lab at Fortis Escort Heart Institute, New Delhi, and also the president of Indian Council for Carotid Therapeutics, India. So please, good afternoon, sir.
Which one? This. Okay, thank you. Good afternoon, friends, and I thank the organizers for inviting me for this very interesting meeting. It's very happy to see all of you. It's been a long time. I had visited this site. So today we have an interesting topic. We are going to talk about resistant hypertension. So we have a lot of discussions on hypertension, but today we'll just focus on resistant hypertension, and some new therapies have emerged. So we know hypertension is a leading risk factor for several problems. 140 by 90 office blood pressure is an average of 2 readings is considered as a cutoff line. And most of the cardiovascular deaths, 35% of cardiovascular deaths, strokes, deaths, they're all linked to hypertension. So definitely there's an important thing that we have to treat hypertension. And a few important things which we forget is how to check the blood pressure. So I just made one slide for drawing your attention. So often we forget when the patient walks into our OPD, we are not observing these precautions. It has to be a quiet room, comfortable temperature. Patient should not have had coffee or exercise for the last 30 minutes. His urinary bladder should be empty. Let him relax for 2-3 minutes. Take at least 3 measurements at 1-minute intervals, and then use the average of last 2 measurements. The cuff size should be correct, and other etc. etc. So I just wanted to draw your attention. Now we know that nearly 10% of the patients have, of the hypertensive patients will have resistant hypertension, of which half are pseudo resistance, and only the remaining half are true resistance. Now what is resistant hypertension? When the seated office blood pressure remains above 140 by 90 in a patient who has been treated with 3 or more antihypertensive medications, of which 1 has to be a diuretic. So these are the definition for resistant hypertension, and we often see a lot of such patients in our OPDs, and are we paying enough attention to them? Of course, before you go to identify the true resistant hypertensions, we need to understand some very important causes of, secondary causes of resistant hypertension, because those have to be excluded when we are treating, because they have specific treatments. And the commonest cause of resistant hypertension is obstructive sleep apnea. And we very often do not diagnose this. A very simple sleep study can be done to diagnose these patients and treat that, and you'll find how well their blood pressure will respond. Other causes would include primary aldosteronism, renal artery stenosis, renal parenchymal disease, and also some drugs or heavy intake of alcohol will cause resistant hypertension. So what are the drugs? You have to remember, when your patient's blood pressure is not responding, you have to see whether he's on a non-narcotic analgesic like non-steroidal NSAIDs, whether he's taking any sympathomimetic agents like decongestant pills, diet pills, etc. Is he a regular user of alcohol, oral contraceptive pills, etc., etc. 2 words about renal artery stenosis before we move forward to our subject. So renal artery stenosis, commonest causes, 90% of the cases are either due to atherosclerosis or fibromuscular dysplasia. Fibromuscular dysplasia will be responsible for less than 10% of these, and it is usually seen in young, more common in female, and it's usually in the middle of the renal artery, whereas atherosclerotic stenosis of the renal artery is mostly after age of 50, located at the ostium of the renal artery, and more commonly seen in men. And this is a very common finding. At least in 20% of the cases who have resistant hypertension, you'll find renal artery stenosis. So you should always look for a renal Doppler when your patient blood pressure is not responding. Now, when do you treat renal artery stenosis by renal artery stenting? Because that's the treatment of choice which all interventional cardiologists can offer to your patient. And this is when either renal artery stenosis exists with accelerated, resistant or malignant hypertension, and you find renal artery stenosis of more than 70%. That's a class 2A indication. Another indication is when you have a unilateral small kidney with resistant hypertension, again that becomes an indication. And thirdly, renal artery stenosis and hypertension where the medication is not tolerable, and you find a renal artery stenosis, then you can treat those. So these are 2A indications. There are several other indications for renal artery stenting, but I am focusing on hypertension. Renal parenchymal disease, CKD, again, you have significant number of patients who will have hypertension, and the use of diuretics has a very important role in these patients. Now, when you are looking at true resistant hypertension, when you have ruled out pseudo-resistance in the form of obesity correction, sleep apnea, sedentary habits, excessive salt intake, usage of drugs which cause high blood pressure, alcohol abuse, and you have also ruled out those secondary causes which I mentioned, then what next? And your patient is not responding. There we start looking at the renal and the central sympathetic nervous system. That's a new development which is happening in this field. We have known for a long period of time that an overactive sympathetic nervous system is an important driver of hypertension. In the 1950s, surgical sympathetic denervation was being done to patients where they had malignant hypertension. So we have a new mechanism of ablating the renal sympathetic nerves to treat resistant hypertension, and this is called renal denervation therapy. It is a minimally invasive percutaneous procedure like an angioplasty, which utilizes three mechanisms. One, commonest use is radiofrequency energy, ultrasound energy, or delivery of alcohol around the renal artery. So how does it work? Kidneys, usually in response to ischemia, send afferent sympathetic signals to the brain, and the nucleus tractus solitarius in the brainstem is where the sympathetic nervous system is driven. So the nucleus tractus solitarius will now give instructions through the efferent sympathetic nervous system to increase the heart rate, to increase Should we run out? Fire safety? All right, thank you. So now renal denervation therapy has been evaluated in the last nearly 2 decades using the radiofrequency, the ultrasound based, and the ethanol injection in the periadventitial space. So several interesting catheters have been developed. The radiofrequency catheter, that is the Simplicity and the spiral catheters. So this is the unipolar radiofrequency catheter. This is the multipolar, spiral is the multipolar catheter. And then we have some catheters which are developed by the Boston Scientific and St. Jude's. Then plus after that you have some ultrasound-based catheters by Teremo, and finally you have an ethanol injection which is available. So here we look at various trials which have been done for RDN. When we started in 2013, there were Simplicity studies, there were other various studies which were performed. Initial studies showed a very large blood pressure reduction in uncontrolled settings, and ambulatory blood pressure monitoring did not show much. So these trials were dubious, but they established the proof of concept. Of late, the new catheters which is used by the Simplicity spiral mechanism have shown significant reduction of blood pressure in those people who had resistant hypertension, both when they were on drugs and when they were off drugs. So this is what one of the comparisons, significant, statistically significant reduction with both the radio frequency techniques which have been used in significant number of patients. So these trials have now made the resurgence of renal denervation therapy, which is now being practiced effectively in our country also. And just to show you how this catheter looks like. So here you have what you do is enter like an angioplasty technique with a 6 French catheter. Inside this you go with a 4 French spiral catheter. This has a helical shape. There are 4 electrodes. At the same time you will give radio frequency energy. This radio frequency energy will, these are the sympathetic nerves around the renal artery. This radio frequency energy will break these sympathetic nerves, damage these sympathetic nerves, so that the afferent mechanism of carrying nervous stimuli back to the brain is blocked. This is how it works. So this is the second generation system, and you have to have a renal artery of at least 3 to 8 millimeters, which is a very normal size, and it is a very simple to use catheter where you don't spend too much time. 15-20 minutes you can be done with this procedure. Now, who is an ideal patient who will benefit by renal denervation therapy? So these patients will be those who have uncontrolled hypertension, that is resistant hypertension beyond 140/90 despite good triple drug therapy. And the other thing is that you have to give priority to patients who have got risk factors for cardiovascular disease. If they are diabetics, if they have a strong family history of heart disease, and they have uncontrolled high blood pressure, they are very good candidates. Only thing is, you have to remember, untreated secondary hypertension should not be included in these treatment groups. Single functioning kidney has not yet been established to be safe, whether we should use it in those patients or not. And severely impaired kidney function, those are the cases where you do not use renal denervation therapy. Transplanted kidneys also, we have not yet evaluated whether renal denervation therapy will work or not. So there are certain anatomical considerations. We know that sympathetic nerves are closer to the renal artery when you go away from the aorta. So this is the point when you go away from the renal artery origin, that's where your delivery of your renal denervation radiofrequency ablation should be done. Now, this renal denervation is also showing benefits in other treatments also, not only resistant hypertension. The sympathetic nervous system also affects atrial fibrillation, heart failure treatment, ventricular tachycardia, obstructive sleep apnea, metabolic syndromes, and in chronic kidney disease. So that is the future. We need a lot of study into this, but it is a mechanism where you denervate the sympathetic system. Anywhere in the body where the sympathetic nervous system is going to work is going to give you benefit. So in short, I'm just going to conclude now. True resistant hypertension affects only 10% of the hypertensive individuals. Pseudo-resistance and secondary causes of hypertension should be first looked for. Appropriate drug combinations should be used, and good lifestyle management is important, of course. Arterial ambulatory blood pressure measurement and home blood pressure management is also very important in monitoring your patients with resistant hypertension. Renal denervation therapy has been proven to be safe and effective therapeutic strategy in lowering blood pressure in patients who have uncontrolled hypertension. The multipolar electrodes, which have been now recently used and shown to be very effective in trials, is what is the way going forward for renal denervation therapy. Anatomic considerations, evaluation of your patients properly with a good renal artery Doppler is very important. And the potential clinical benefits of RDN may go for other therapies like I mentioned in sleep apnea, atrial fibrillation, ventricular tachycardia, heart failure. So that has yet to be seen. Thank you very much.
Thank you, Dr. Atul. The next speaker in the series is Dr. Arvind Seth. Dr. Arvind Sethi is Director Cardiology at Fortis Shalimar Bagh. With 20 years of experience, he is a graduate and postgraduate from Maulana Azad Medical College, has been trained in Lady Hardinge Medical College and RML Hospital, and he will be speaking on the next cracking the calcium. Dr. Arvind Seth, please.
Thank you, sir. Good afternoon, everybody. I'll be speaking on newer advancement in intervention. That's the angioplasty technique. Sorry. It's cracking the calcium. As we are well aware, CAD, coronary artery disease, is a widely prevalent disease, and the options available for treatment are medical management, intervention by angioplasty, and surgery. Routine angioplasty requires guide wire, balloon, and stent placement in most of the cases, but then and the successful outcome is less than 20% residual stenosis. That is, in case we are able to achieve more than 80% luminal area, that's considered a successful outcome. And not all vessels and lesions are the same. Because up to 35% of the lesions are quite calcific, and more the calcium, it increases the risk of poor clinical outcomes. And not all calcium is the same. It could vary from circumferential, superficial calcium to deep calcium and eccentric calcium and nodular calciums. These are the imaging modalities, IVS and OCT, that are commonly used in complex angioplasties. And for additional tools which are required, which are used these days, are scoring and cutting balloon, rotablation, intravascular lithotripsy, and the recent advance of orbital atherectomy. We calculate, we decide which tool would be of utility in particular case, depending on the amount of calcium. In case the calcium is mild, then maybe non-atherectomy strategies by scoring balloon or cutting balloon can be utilized. And in case calcium is much higher, then depending on, in case it is engulfing the whole 360 degree around the vessel wall, or less than 270 degrees, we can, depending on the amount of calcium that is visualized by angiographic means, it can be decided that whether to go by scoring balloon or by atherectomy means. As far as atherectomy is concerned, various modalities. This is a scoring balloon. It is inexpensive, has been used for long, and familiarity of experience makes it relatively safe. But then, because of the calcium, many times, because of the bulky nature of the balloon, crossability becomes an issue. Rotablation, another modality which has been used for long, but then it generally creates passage along the calcific path in a defined path, in a single plane. And large amount of particulate matter is generated that can clog the arteries distally, leading on to no flow and complications like that. As compared to this, intravascular lithotripsy, commonly known as IVL, this is utilized nowadays for mainly the deep-seated calcium, and it helps by modifying the vascular compliance. This is the newer modality, orbital atherectomy, that is an advancement over the mechanism which was observed, which has been used for over 3 decades now, rotablation. This has a very minimal kind of setup and can be set up in a short while. And it acts by eccentrically mounted diamond coated core that reduces the coronary plaque and calcium burden. And crown rotates in single plane and also in the orbital fashion to sandify or make particulate matters of the calcium, which can be easily drained away. And it's effective in a wide range of coronary vessel diameters because the mechanism, single size can be utilized in different size vessels. This has a unique bidirectional action, that is forward mechanism also can help, and in fact in the retrograde fashion also it can give rise to reduction of calcium burden. And it is utilized by routine 6F guiding catheters, and various size 2.5 to 4 millimeter vessels can be tackled by the same burr. and it's a bidirectional standing capability, and it improves vessel compliance also by increasing the luminal gain. This is comparative between rotablation and orbital atherectomy. Rotablation generally acts in one plane only. It might give rise to, yes, it can increase the passage, but then depending on the requirement, we have to at times increase the burr size to increase the passage to be able to pass on further hardware. Orbital atherectomy acts in this fashion, in a single plane and also in different planes. IVL, similar picture. IVL gives rise to, it improves the vascular compliance, does not really do much in the calcium reduction process. So with this background, I'd like to show some cases that we performed with this technique. The first one is 54 years old male, moderate LV dysfunction. Presentation was NST-MI, hypertensive, diabetic. These are the angiographic pictures. This is the left side and this is the right side. This picture shows the passage of orbital atherectomy burr, which is moves in a dual planar fashion. And this is once we have created the passage, then for further pre-dilating the vessel to increase it to the lumen diameter. And this is the stent placement. This is the ease by which the stent can be crossed through the calcific lesions. And this is the final outcome, which can be seen here in the next image by the imaging technique of a well opposed and well expanded stent. Moving on to the next case, a similar case, 65 years, he had triple vessel disease, refused for surgery. LAD and OM were tackled in the first setting. RCA was heavily calcified vessel, which was required to be taken up in the next setting because it would not give away, it was not allowing the balloon, even the smallest balloon, to be passed through the coronary artery. This is over the wire orbital atherectomy catheter has been, by glide assist mode, it was easily crossed where the balloon would not cross even the smallest size. This is the pre-dilation after the crossing of the, and this is the stent placement. I'll show you the final results. This is the artery, which was well opposed, well opened stent and Timothy flow. Another case who had presented with ACS, again diabetic with severe LV dysfunction. Here the LAD shows significant calcium critical disease and a long segment disease. This patient also refused for surgery and was to be taken up for angioplasty for treating. This shows the glide assist mode by which the orbital catheter was advanced into the LAD. This is pre-dilation, after creating the passage and reducing the, after modifying the calcium load. This is stenting going on. It required bifurcation stenting of LAD and diagonal. After post-dilation, this is the final result of LAD, which showed very well opposed stent. And so in summary, to conclude, orbital atherectomy is a safe option nowadays in carefully selected patients, and advantage is that even large caliber vessels can be tackled with a single burr. In single crown, there is no requirement to upgrade the size of the burr, and well prepared lesions obviously facilitate adequate luminal gain, and obviously they are good for good stent apposition and good long-term outcome results. I'll end with a short video of this. This shows the burr that is working in 2 dimensions, not just going in one plane. It orbits around within the vessel to debulk the calcium load. It's a dual action. By grinding away the calcium, and also the pulsatile forces modify the deep calcium. Another significant advantage as compared to rotablation is because of the movement in different planes, it facilitates blood flow along with the orbital atherectomy process. I think that's it. Thank you.
I am requesting to Dr. Gurbeer Singh, Associate Professor and Head of the Department, Heart Research Center, Christian Medical College and Hospital, Ludhiana.
Thank you, Dr. Goel sir, for inviting me for this wonderful conference. It's good to hear a lot of people talking on medications, but once the medications don't give an answer and patients keep on deteriorating, then probably we need help of interventional cardiologists or surgeons. So this question actually, it's very difficult to answer in 10 minutes, but I will try to go as fast as possible. So, depending on the risk of procedure being performed, I'm talking of the surgical risk. It is imperative to know that we classify these patients as inoperable or very high risk, intermediate or low risk. So in which kind of patients interventions are going to be useful, and in which kind of patients I think surgery still holds true. That is what we are going to answer in the next 10 minutes. So I think in 1965, when Professor Davies performed the first valve implantation in a dog, that actually started the era of evolution in valvular heart disease therapies. So 2002, Dr. Alan Kribbier, he performed the first transcatheter aortic valve, and then all through these 23 years, we have evolved a lot, and we keep on learning with each day, with each case, how we improve in our technique and the device therapy. So this is that landmark photograph from the first case, but when the patient is referred to us by physicians, by colleagues from other allied specialties, we study these patients in a great detail and depth before taking them up for any sort of intervention. So aortic stenosis, you all have seen this slide. It says when somebody has symptoms, so it needs to be treated. There is no, I would say, established drug therapy as of now which can reverse or which can improve a patient with aortic stenosis until unless you take care of the obstruction. So in this famous graph, the survival is just 2, 3 and 5 years if somebody has heart failure syncope or angina as symptoms. And we had this famous trial, the landmark trial. If patients have high risk for surgery and they are denied surgery, so almost 80% of them are going to die in the next 3 years. So that was the time when we felt that there's an unmet need for a safer alternative, and that gave birth to transcatheter aortic valve replacement. So before that, I think it is imperative that we differentiate a true severe AS versus a pseudo-severe aortic stenosis by doing a dobutamine stress echo wherever we feel the cardiac reserve probably is hidden or low. So our surgery colleagues have been doing this for the last 3 to 4 decades, and what we are doing is just an evolution of that form of therapy. We are doing it with a lesser invasive technique. Otherwise, the principles remains the same, that we are replacing the stenotic valve. But when the patient is referred to us with all the comorbidities and all the high risk, it appears like this. We have to plan a lot of things and we have to study the patient in detail. This graph from Europe actually, it tells us the success of transcatheter therapies over last, I would say, 2 decades. And it is surprising to see that transcatheter therapies have actually overtaken surgical form of therapies, and people want more and more of a lesser invasive form of therapy rather than getting operated. So the flow hemodynamics, we don't remove the valve leaflets. The leaflets remain there as such, which gives rise to a favorable hemodynamic profile as compared to when a surgeon will dissect out the leaflets and replace it, suture it with a new valve. I think the management of any such valvular heart disease patient, it starts right from the time once the patient is actually diagnosed by a primary physician. And from that time itself, it should be kept in mind that what is going to be the history of this patient in terms of symptoms, longevity, and morbidity and mortality. So valvular heart disease therapies gave rise to this term called as heart team approach, and it involves various specialities apart from cardiology, cardiac anesthesia, and cardiac surgeon. They are part of team, but apart from that, each patient is seen by the allied health specialities as well as the paramedical specialities, which gives rise to more confidence in the operating team, and it actually turns out that it gives better long-term outcome. So as I mentioned, we divide these patients as per the risk. So there are various risk scores available which are online, and we use it for all our high-risk patients, whether coronary or structural heart disease patients. One question which always comes to our mind is, does age actually mean high risk? I would say no, because all these trials have taken population where the mean age was more than 80, but they were low risk trials. So there are other factors like frailty, the comorbidities, the renal function, the lung function, which we need to consider. So we learn a lot of radiology once we do our structural fellowships, and we need to be, I think, 10% radiologist in order to perform structural heart disease intervention, because unless you study the detail of anatomy in great depth, I think the success can be challenged. So I'll just touch upon 2 valves which formed the basis of these revolutionary therapy. First was by Edwards, and we have come a long way. Now we have the 5th generation valve, which is X4. The good thing about this bioprosthetic valve is that it has longer durability. The second valve is core valve, and now again we have the 6th generation valve which was launched last week in India, and same, the longevity of this valve again is claimed to be better than the previous versions. We always feel proud to have 2 Indian valves actually. One is from Merrill, India, that is my valve, and you will be surprised to know that this Indian valve is being implanted all around the world, and we have more than 50,000 implants around the world, and in some countries it's even more than India. So it's competing with multinational companies, and it comes with a very cost-effective solution for such patients who can't afford a costlier device therapy. We use these sizing charts to actually select our valve sizes, and there are various valves available in the market, but we as interventional cardiologists, we try to master 1 or 2 valves which are either balloon expandable or self-expanding, or one of each, rather than moving to multiple valves at the same time. So all this is supported by a lot of clinical data, and success is defined by good clinical outcomes with this device therapy, and it is available for both balloon expandable as well as self-expanding valves. So I'll just show you a case. He's an 88 years old male and bicuspid aortic valve. We in India come across a lot of bicuspid valves. Almost 50% of our patients are bicuspid. And this patient actually has moderate MR, TR, moderate PH, and mild LV dysfunction. So the risk score for him, actually it falls in high risk, I would say, because the risk of mortality is around 12%. So we discuss with the cardiac surgeon and anesthetist, we always keep them involved and they are always in our cath labs while we operate. So this is how we do. We take an angiogram, basic angiogram shot to just localize the valve. We cross the valve, we predilate with the balloon and then we implant the valve. So this is how it is done, and this can be done actually under conscious sedation now. We do most of our cases under conscious sedation, and the patient probably is ambulatory in less than 8 hours. So the risk of complications always we have to keep in mind. One is stroke, second is the leak around the valve, which is paravalvular leak, the risk of pacemaker implantation because we are going to impinge on the conduction tissue around the aortic annulus. One question which always we need to answer before we offer this therapy is the longevity of valve. All the bioprosthetic valves have a longevity less than 15 years till date, but we need an ideal lifelong valve. So we have this Dura AVR, Dura aortic valve replacement valve, which has been tested in humans, and the company claims it is sutureless, without human touch manufactured valve, and this valve is going to stay forever till the patient survives. And they have tested it in vitro, and the life of the valve is said to be more than 20 years. There's another valve in pipeline, Trial LP, and which is also manufactured with a robo. There is no human touch involved, and the chances of structural degeneration are very low. So when we offer this therapy, we also think of what is going to happen after 10 years or 12 years once the patient has a structural valve degeneration of the valve. So we make our choices based on that, because this is not going to be the end therapy for the patient. They will come back to you after 12 years, 13 years, 14 years. So you have to think about that at the index admission itself. The surgical colleagues, we always discuss the least invasive possible surgical options, and there is great amount of progress in that field also. We have the sutureless valves which can be implanted with a micro incision on the sternum, and there is no sternotomy needed. So the current evidence of TAVI in inoperable, high risk and intermediate, I would say it is 1A, and day before yesterday European Society of Cardiology has given guidelines, and it says all more than 75 years aged aortic stenosis patients can undergo TAVR. So coming to mitral valve, I'll just touch upon that. It is more complex than aortic valve because there are a lot of structures involved. It's not just the valve leaflets. It involves the functioning of left ventricular cavity, papillary muscles, chordae, leaflet, as well as the atrial function. So what we see actually is just the tip of iceberg, and there are various device therapies available which we have been using, like BMV, for decades now, and we as Indian interventional cardiologists are very experienced in doing such type of interventions. The reason why we lagged behind TAVI for mitral valve interventions, I already mentioned. So one entity which is functional MR, when we are treating heart failure patients, despite optimized medical therapy, they will continue to have a functional MR, and there are ways to treat it. But before that, just I want to focus on this slide. It's not always necessary that functional MR is just due to LV dilatation. It can be due to the atrial dysfunction which is induced by long-standing atrial fibrillation. So for such patients, we have a device therapy, and recently the Merrill company has launched a device called MyClip. It's a sort of clip which we use to bring both the leaflets together. This is one patient, 78 years old male, 3 years follow-up, NYHA class 4, he was unable to even lie down. So this is the device therapy, very cost effective. It's called MyClip tiered system, transcatheter edge-to-edge repair system. And we have good data on initial 50 patients for this device, and it is very promising. So this is how it looks like on the cath lab fluoroscopy screen. It's just like a cloth clip what we use, but it demands a lot of patience and evaluation before we do this case. And if you can see pre-clip and post-clip, I have just put this video to compare. You can very well visualize how significant the MR is on the left side, this jet, and just deploying the clip, it almost disappears. So this is again one form of therapy, doing a valve-in-valve, where already the patients have a bioprosthetic valve or a ring. We can always put a valve-in-valve in such patients. And tricuspid valve, just 2 slides. It's more challenging because tricuspid valve is large. It has 3 leaflets, and in case you have tricuspid stenosis, you can always do a balloon tricuspid valvotomy. But in case of regurgitation, it is actually very challenging to bring these leaflets together. But we have been doing it successfully. And these are all the therapies which are available. So you should always involve surgeons before you attempt such patients. I'll show you one case where we have done
Dr.
valve.
Can we wind up, please?
Yeah, just last slide, sir. So this is valve in valve I performed in Cairo, Egypt last month. So the patient already had a bioprosthetic valve, so we just implanted a valve in valve, and the patient was able to walk. So this is one more device called TRIC. It's a bicable device, costly, but it gives good results. So I'll conclude by saying that undoubtedly it's a major breakthrough in cardiovascular sciences, but heart team approach and good planning, that is very crucial for the success. All more than 80 years are not high risk patients. We need more data for low risk populations, and please involve the patient. What does he want as a part of his treatment? And valve for life, it is not far from reality. Thank you.
Dr. Naresh Goel, can we defer this question answer session, or?
We'll just take some small questions.
Please, because we are already late by 1 hour.
No, we'll just take one question only, so that because these are the new therapies. Actually, the purpose was keeping this session was to have an interaction and to understand that physiology of these things. So Dr. Atul Mathur has to leave for because he has some personal work on this thing. But the good thing is that we have a Dr. Amitabh who has personal experience about doing cases of renal denervation. Please. Dr. Amitabh. So can you tell us, like a person who has a very severe hypertension has not been controlled? Please give him a mic to Dr. Amitabh. So what is your experience of this new process of renal denervation? Because what we want, nobody wants to take, it's a silent killer, you know, number 1 cause of morbidity and mortality presently as per the WHO guidelines, and still it is very much under control, and nobody wants to take tablets for a long duration. Apart from lifestyle modification and taking a tablet or 2 if the blood pressure is not controlled, so what is the real role in Indian population, or what exactly we can do? You have done a good number of cases in India.
Yeah, so our experience started way back in 2012 when we started it using our own catheters, and with the recent spiral we have also done a few cases. So I'll just tell you the cases that we did, and you can understand.
So please can join
you can understand the scenarios where it is. First case that we did recently with the spiral catheter was of a female. She was 70 years old. She lived with her divorced son. The son used to go to his work, and she was alone at home, and she was taking almost 6-7 types of medicines. She had CAD also, so she was on coronary artery disease medicines also, plus 5-6 types of antihypertensive medicine. The only problem with her is she just could not remember the medicines. So beyond certain time, you have to give medicines that are probably thrice a day, or maybe twice a day, sometimes in the morning, sometimes in the evening. Diuretics have to be given in the morning. So she was just fed up. She just said that, because when she was admitted twice or thrice in our hospital for uncontrolled hypertension. When we gave her the medication, she got controlled. Once she goes back home, again she forgets. So I think that's a very common problem for especially elderlies, where you have so many medicines and it is impossible to track them. So this patient we did, and she had very good results. Another patient was, he was uncontrolled despite 8 types of medications, sometimes supraphysiological doses, because when there is nothing else, what can you do? Again, this was a priest. He came with severe weakness, transient ischemic attack kind of a situation, where fortunately the CT scan or MRI was normal. So in this patient, we again performed renal denervation, and then his blood pressure requirement decreased. Another patient, a young female, 35 years old, she had renal artery stenosis. We had done the angioplasty of the renal artery. Her ejection fraction was 15% before the renal angioplasty. After renal angioplasty, ejection fraction improved, but her blood pressure still remained uncontrolled. Again, she was on multiple medications, not getting controlled. In this patient, post-renal stenting also, we did the renal denervation. The next day, the blood pressure became 100/70. We had to stop all the antihypertensive medications. And she was discharged only on 20 milligram telmisartan and 12.5 milligrams metoprolol. So these patients do benefit. So patients who are unable to take medications because of either they are not able to tolerate, they are not able to remember, or patients who are taking medications but still they have what is called as true resistant hypertension. All these patients, I think renal denervation is a option that we can always choose. Sir, we have done, in our initial trial, we had done around 10 patients, and now we have done 4 patients with the spiral. All of them are doing well, and the studies have shown even in thousands of patients, the chances of complication is less than 0.04.
So that's what I wanted to communicate. Thank you, Dr. Amitabh. That the blood pressure can be beyond medication. We can control nowadays while doing things. You remember the sympathectomy was done a long way back, but the surgery and the complications were there, so we couldn't do it further. But now we have this quite a simple procedure which can be performed within an hour, and we have our own experience in Delhi to doing these things. So if the blood pressure is not adequately controlled, I think we should try these interventions. Thank you. I think for the time I will change.
Now I will request all the speakers and the chairpersons to proceed towards the felicitation area for the felicitation, and it is time for our lucky dip. So I will request the chairperson.
Mr. Maipal.
Chalo, request them to take out. Please sir, proceed towards the felicitation area.
अंदर से निकालो.
Next session is recent advances in intervention. Dr. Rajiv Dhawan.
Lucky dip.
Dr. Rajiv Divan sir. He is a consultant internal medicine at Rose Hospital. Next is Dr. V.K. Arora sir. Sir is general physician practicing in Nehru Bihar. Next is Dr. Sunil Khetarpal sir. Sir is senior consultant physician, past director Rajiv Gandhi and vice president of IMA DNZ. Next is Dr. Girish Tiwari sir. He is general physician. He is the senior vice president of IMA DNZ and chairman of Junior Doctors Network. I will request the chairpersons to kindly invite our speakers and introduce them.
So these are the topics again I would request, and I will try to tell the audience that it's recent advancement and that so that we are not going into the detail about these things, as in the previous speakers has told already about the valve surgery. Nowadays the surgery is not mandatory if it's an aortic valve and elderly patient. Same way the surgery is not mandatory in the severe mitral regurgitation patients. And as previous speaker Dr. Arvind Sethi told about, nowadays you can avoid the bypass surgery also if these are the calcified vessel, and angioplasty can be done. And previously as an RDN has already been explained, and further these things what we are going to discuss about that pacemaker, because we have seen there is a pocket device pacemaker, and there is a eminent speaker to discuss about the pacemaker. Secondly, we have a topic where the stents, because everybody is feared whether whenever there is a blockage we have to put a stent, so how we can deal these patients who in whom we, without putting stents, how can we open up the artery and keep them opened up. And thirdly, we have a speaker for these things, where nowadays very complex patients who has a DVT comes, and we just have a Novax to give them or Clexane to give them, but nowadays we have the procedure to remove those clots, not from the deep veins as well as the pulmonary embolism. So I request the speakers, chairpersons to please call the speakers.
The first topic is on pacing the heart. When the heart rate dips, to speak on this topic is Dr. Devendra Kumar Agarwal. Please, sir. He is Additional Director Cardiology at Fortis Shalimar. More than 50 years of experience. He has done his MBBS from SMS, MCH from Jaipur, MD Medicine, AIMS, and DM Cardiology, GB Pant Hospital. Please, sir.
Yeah. Thank you, all the organizers, for this conference. My topic is about the leadless pacemakers. And So in last almost 5 decades, the pacing has evolved from the external pacemaker to small devices. But in the last 2 decades, there is a work on the these implantable pacemaker inside the heart itself. These are leadless pacemaker, they are without the leads. So what is the need of these leadless pacemaker beyond these conventional pacemaker? So this is conventional pacemaker which has the pulse generator which is placed near the shoulder in a subcutaneous pocket, and the 1 or 2 wires depending on the single chamber or dual chamber, the leads are connected to the pulse generator, and they are implanted in the RA appendage, and the right ventricular lead is implanted in the RV apex or in the septum. So if you see the conventional pacemaker, the important weakest part of the pacing system is the lead, because the lead has the conduction system and there is insulation. So there are issues about the insulation break or the fracture of the conduction material, or there is a issue about the venous access. The initially new implanted lead can dislodge from their site, so there is an issue of lead dislodgement that acutely happens in the few of the cases, and when these acute dislodgement, they can be problematic and even have the reimplantation procedure, or even adds to few mortality in these patients. Infection in the subcutaneous pocket or the lead are issues, and in the prospective study of around 6,000 patients, and these device implantation has risk of infections. There is an implantation related pneumothorax, and that happens in around 1% of the patient. Lead dislodgement also again in around 1% of the patient. So although the target of the device implantation in conventional pacemaker to keep these complication rate near zero, but these are definitely in the range of around 1% that these complications do happen. This is about the study showing the rates of pneumothorax over the years. This is about the lead fracture one can develop over the years. So lead fractures, subcutaneous hematomas, pocket hematomas, infections, all these are the complication. All the rates are in the range of 1 to 2%, but how can we minimize and what are the solution? So this is the leadless pacemaker, and one is from the Medtronic Micra and one is Avir from the Abbott. There was earlier NanoStim from the St. Jude Medical. The same has been upgraded, and now it is Avir. So these leadless pacemakers, which is around 90% is smaller than the transvenous pacemaker, and it itself has the pulse generator, battery itself, and anode and cathode, and it is implanted in the RV apex. So there are studies in last 1 decade which have shown that they are quite easily implanted, and the acute and chronic complication rates are acceptable, and this was published in the NEJM, where the initial complication rate was less than 5%. So what is the recommendation about the leadless pacemaker? So these leadless pacemakers should be considered as an alternative to transvenous pacemaker when there is no upper extremity venous access, because the conventional pacemaker needs subclavian venous access to implant the leads, or when the risk of device pocket infection is particularly high, like the patient who has experienced the previous infection, or the patient who are on hemodialysis, they are at considered high risk of these infections. They can also be considered in alternative to standard single lead ventricular pacing, taking into consideration of life expectancy and using shared decision making with the patient. So these leadless pacemaker are without the pocket, they reduce the infection risk, they are minimally invasive. The two devices, like from the Avir from Abbott and Micra, they are comparable. The Medtronic is available in the market since last almost 1 decade, and this Avir in last 2 years in Indian market. So comparing these, the implantation procedure is quite similar for both of them. They are implanted from the femoral venous access. The sheath size is quite bulky, but vein can take that device size nicely. It's around 25 French plus sheath, and the procedure generally takes around 30 minutes to implant, and both the devices has around 1 decade or more of the battery life, and this is helix based fixation and this has tines based fixation. And in my Medtronic we have this mechanical AV synchrony system with Micra AV, which has been launched in last 1 year, and that has algorithm for sensing the atrial contraction, and that can trigger the ventricular pacing. So we can have VDD program here. In AVIR, they have launched the 2-device system, when the one is implanted in the ventricle and one is implanted in atrium. So one can have the conventional atrial sense, ventricular pacing, or atrial 2 pacemakers simultaneously. So which of these patients are benefited with the leadless pacemaker? Primarily we have the RV only pacing. With the AVIR we now have the RA pacing also. If there is a high risk of infection, because we can avoid the pocket hematoma or infection, venous access issue like the subclavian vein occlusion or the prior lead infection, patient who are elderly or the frail patient or cachexia or thin skin where these devices get erodes through the skin, chronic kidney disease or dialysis patient, history of device infection or the lead endocarditis, and if there is a need of removal of the infected device and simultaneous pacing, so this can be implanted even in the presence of infection also. So these are the advantages, that it is brief percutaneous procedures without any cuts. There is invisible to the patients, there is no pocket, no system connections, there is reduced procedure times and the fewer complications. There can be short-term complication, but in the experience hand the incidence is quite low, and after the 30 days the long-term complications are the rare thing. This is the device being implanted from the transfemoral route. This is a bulky sheath, but the femoral vein doesn't have any complication rate as such, and being implanted in the RV apex. So to conclude, leadless pacing is a feasible and relatively safe and effective option in the short and long term. Newer generation devices show promise and for dual chamber and expanded pacing capabilities. Long-term safety and efficacy data are getting generated, and they still need to establish the clinical benefit fully. Potential to benefit the majority of the pacemaker recipients, particularly those at high risk of lead-related complications. And I would like to add one more line, that the patient who are like patient with sick sinus syndrome who infrequently needs pacing, or the patient of AF who gets intermittent bradycardic episode also. So those are one of the best suited patient for these transfemoral leadless pacemakers. Otherwise, the one who don't have complication of venous occlusion or the infections, then they becomes a candidate for these leadless pacemaker. Thank you.
Next question. Thank you for the nice presentation. Questions will be taken later off. So
next question.
We invite the next speaker. Thank you, sir.
So we have the next speaker, Amitabh Yaduvanshi. He is the Chief of Cardiology, Holy Family Hospital, New Delhi. He is a highly regarded cardiologist based in New Delhi. He has extensive experience in providing top-notch heart care services and has been serving the community as a cardiologist in Holy Family Hospital, Okla. Patients trust his expertise and recommend him to others in need of heart care. I think Dr. Yaduvanshi will be talking on how we can make the clot removal simple, about the procedure thrombosuction in DVT and pulmonary embolism. Over to Dr. Yaduvanshi, please.
Thank you, sir. Thank you for your kind introduction, and thank you, Dr. Naresh, for allowing me to present my cases. So, as Dr. Naresh told, DVT is something that is often considered benign, and but you can see that this is like a thrombus album. So much large thrombosis that are there in the DVT and pulmonary arteries, which can cause havoc in a patient, and this is something that can be extracted. So venous thromboembolism is a common condition. It is estimated to double by 2015. As more imaging is available to us, more disease we are able to pick up, and 6 lakh cases of significant pulmonary embolism and 2 lakh deaths can be attributed to venous thromboembolism. Management, we all know, is anticoagulations, which could be for prophylaxis as well as for treatment. Most cases of pulmonary embolism are preventable because 40% of DVTs actually develop pulmonary embolism either in minor or major form. So we all know DVT is a thrombus or clot in the deep venous system. It can occur anywhere, but usually occurs in the lower extremities. Symptoms include swelling, tenderness, discoloration, and what is more important is almost 50% of them develop what is called as post-thrombotic syndrome. So I'll be mentioning it slightly later. We all know the risk factors. 50 to 70% of DVTs are provoked DVTs because they have some specific risk factors. However, remaining 25 to 50% are non-provoked DVTs, and they are becoming more and more common in recent years. We all know the virtuous triad, which causes DVTs, circulatory stenosis, endothelial injury, and hypercoagulable state. The mechanical prophylaxis could be by elastic compression stockings or intermittent pneumatic compressions. It targets the stasis part of the virtuous triad. Pharmacological prophylaxis target the hypercoagulability part. So it could be by aspirin, but aspirin alone is not sufficient. Data is limited, so it should always be considered along with mechanical prophylaxis. Warfarin can be used, but it is not practical for perioperative prophylaxis. So again, not really used very frequently. So the most frequent pharmacological prophylaxis by heparin, which could be either by unfractionated heparin or lower molecular weight heparin. But once you develop DVT, there are certain symptoms. It could be asymptomatic. So many patients, they just don't have any symptoms and only know about DVT once there is a pulmonary embolism episode. But there are certain symptoms and signs which are there. Clinical assessment depends on severity of the DVT. So there can be phlegmyncia alba dolens and phlegmyncia cellulis dolens, which is the blue limb or the white limb. I'm sure all the physicians here know about these things, which we learn in our undergraduate days. Ultrasound is the diagnostic test of choice because it is easily available. Findings include intraluminal hyperechoicity, increased venous diameter. So I'll just then venography, CT venography, MR venography, or PET can also be done, but these are not really used very frequently. So this is how you diagnose a DVT on ultrasound. There is when you do compression, the vein does not compress. So if it is non-compressible, it means it is full with thrombus. This is how the vein should ideally compress. So this is the vein. Once you do compression, it usually compresses into a chink. If it is not compressing, that means there is a thrombus. Sometimes there may be a partial thrombus, so the flow can also be restricted. So why do we need to treat DVT? So one important is you have to decrease the risk of pulmonary embolism, but most often forgotten aspect is to prevent post-thrombotic syndrome. So this, what is there because of venous hypertension, patient develops cramps, heaviness, varicose veins, edema and skin changes. And iliofemoral DVT is the biggest predictor of PTS, and 40% may even have venous claudications. Symptoms worsen with recurrence of DVT, and so how do you treat these DVTs? If it is just a calf DVT, then probably just anticoagulation is sufficient. If femoropopliteal DVT, then anticoagulation is also sufficient in most of the cases. However, in iliofemoral DVT, apart from anticoagulation, we should strongly consider interventional therapies to decrease the chance of post-thrombotic syndrome. IVC filters, we all know, I will not go into details. Then what is post-thrombotic syndrome? This is when, because of the increased venous pressure, because once you have thrombus, the valves of the veins, they become incompetent and there is leaky valves. And because when we are standing, because humans are erect animals, when we stand, the pressure increases, hydrostatic pressure increases, and this causes pump failure and obstruction and valvular dysfunction. All three contribute. So you can have symptoms like pain, cramping, swelling. You can have varicose veins. You can have even severe forms of venous ulcers. All these patients, they just have venous obstruction and venous insufficiency. They do not have any arterial insufficiency. So when to intervene in DVT? If there is an acute iliofemoral DVT, then there is a high thrombus burden. We should intervene. Options are thrombolysis, aspiration, stenting, and surgical. Lytic therapy has a 70 to 90% success rate in acute DVT. However, bleeding risk is high, 5 to 11%, and treatment time is usually 24 to 72 hours. It requires ICU and prolonged embolization, and most of the time it is given through catheter directed thrombolysis. So a catheter is placed inside the vein and you go thrombolysis through that. Aspiration thrombectomy is the new thing that has come up in our country, and it involves passing a large catheter through the thrombus. It can be assisted using balloon maceration or certain devices that are inbuilt into the aspiration system that can macerate the thrombus, allowing it to be aspirated more efficiently. The disadvantage till now was it led to a significant blood loss. Most of the time it was technically successful. However, few patients would require additional thrombolysis. So there are certain new devices that have come up. The most significant is the Inari float retriever. So this is an elegant device with just a manual suction syringe, and you can remove large chunk of clots through this method. Then another device is the Penumbra CAT series. So again, there are various sizes of the catheter. So you can go into even smaller vessels. So it can be used both in arterial as well as venous. In fact, it can even be used in coronary arteries. We have used it in coronary arteries also. So this is how a Penumbra device looks. So it can be easily tracked up to the distal limb, and you can have good flow once the thrombus is sucked out. Another device which is not yet available in our country but is also very efficient in removing the clots from the DVT is a Inari clot retriever device. So it is like a mesh basket, and you can just pull out the thrombus inside the basket. So coming on to few cases that we had done. This was a 36-year-old obese female. She was admitted with right flank pain. Ultrasound showed right hydronembosis with ureteric calculi, underwent a cystoscopy and pyelogram with DJ stenting under spinal anesthesia. The next day, while going to the toilet in the ward, she collapsed. Code blue was announced. She was found in cardiac arrest. There was pulseless electrical activity. CPR was initiated. There was return of circulation after prolonged 50 minutes of CPR. Transthoracic echo showed right atrium and right ventricle dilated. She had an history of OCP prescriptions. Patient was initiated in heparin infusion. However, there was a large bilateral saddle thrombus in the main pulmonary artery. So it was decided to, because this patient was not a candidate for thrombolysis because of the recent surgery and recent spinal anesthesia. So it was decided to go for a mechanical thrombectomy. So this is how it's done. So just so this is the large device. This is the Penumbra device that we have used in this case. So it is a large bore device. It has the newer form has a robotic computer programmed suction. So when it is in the free blood flow, it doesn't initiate the suction. It is only when it is engaged in the clot, it takes the suction, and you can see the clot coming out in this case. So this was done on both the sides in this patient, and finally a large chunk of clots were removed from the artery and only 250 ml of blood was lost. In another case which we did recently, 72-year-old female, male, severe dyspnea for 24 hours, had prolonged immobility. He had gone for some pilgrimage and was in the bus for a very long time. Came to us with tachycardia. Echo showed all features of pulmonary embolism, and you can see there is a lot of thrombus in the pulmonary artery. So all this white thing that you see is the thrombus. So again, in this patient we use the Inari system. So in the Inari system, the benefit of Inari system, it is a manual aspiration. So you are not dependent on the. So this is how it is done. So it is a manual large bore syringe that you use, and you apply the negative suction, and you can see the clot coming out. So just bear with us for a few minutes. It will come. So this is how it is coming in, and then once it is there, you remove, and you can. The beauty of this is the blood that is there you can recirculate. So this is a filter that is there which is called as cell saver, and you can push the blood in, take it out, and the clot will remain in this filter, and you can see the amount of clot that is removed. This is the clot. So in just a single pass you can see such large amount of clot that is removed with the Inari system, and the blood can then be reperfused back. So there is very minimal loss of blood in this system. So you can do multiple passes and you can transfuse the blood back, and a lot of thrombus. So this was from the other side. Again the same thing was done, and finally there was a significant resolution of the clot. So in such cases the idea is not to remove all the clot. The idea is to decrease the pulmonary venous pressure, and you can see in this case from 60 it came down to 40, and there was a significant improvement in the hemodynamics of the patient. A lot of clots were removed from both sides. So to conclude, DVT and PE is preventable and treatable. Awareness is important. Isolated DVT without PE is not always a benign condition and is associated with a lot of post-thrombotic syndrome. PTS can occur in 20 to 50% of DVT patients, and large iliofemoral DVTs have a higher risk of PTS, and catheter-based systems can be used to fragment and aspirate these clots, whether they are in the deep veins or in the pulmonary artery, and this can reduce the incidence of PTS. And in patients with submassive pulmonary embolism who are not candidate to thrombolysis, catheter-based system can be life-saving. Thank you.
Question answer session. Thank you, Dr. Yadurvanshi. Question
I
answer.
request Dr. Amitabh to stay, and Dr. Devendra also.
For the question answer session, yes, please. You please carry on for the question answer.
This is the thing, that new thing what we are going to what we wanted to discuss, and to all this August audience, that DVT is not so benign. We used to treat with the suppose in an injection enoxaparin, and as well with its oral Novax nowadays. But this is that probably, I think, what's the complication rate if you remove the DVT on this patient?
Complication rate of the procedure?
Yeah, procedure.
Procedure is usually very benign. Again, these catheters are all very soft catheters. They are atraumatic catheters. The only complication is basically there can be some vessel injury if you are not very careful, and secondly, blood loss is there. But with the new system where you can actually retransfuse the blood inside, that also is taken care of. So
what were the patients like in whom you would recommend to offer up to popliteal or iliac vessels? Till what time of the thrombus is there, then we can recommend?
I think iliofemoral, anything above the femoral in the iliac or the IVC, then definitely we should, because again two things. One, very high chance of pulmonary embolism, and secondly very high chance of post-thrombotic, because the collaterals are totally gone. There is no collateral circulation, because if you go into the iliacs, everything will go through the iliacs. So there is no, till femoral, till popliteal, till calf, you can still get away with without removing the clot. But if it is from femoral to iliac, I think.
And what about the indication of putting a filter nowadays, IVC filter in these patients? Because we have heard about lot that to put an IVC filter in between, so that there should not be any embolization of pulmonary embolization.
Yeah. So in patients who are not candidates or who are not tolerant to anticoagulants, or who are having showers despite anticoagulants, we can put filters. Now, most of the filters are now retrievable filters also, but most of them are actually placed in patients who have a continuous risk factor for DVT. So,
no, what I mean to ask you, during procedure you need, because when you are sucking it out, some thrombus might go to the pulmonary and lead to pulmonary embolism.
So, no, in these patients, because there are two ways of going it. If you are going through the popliteal upwards, then you are chewing it from down, so it usually doesn't happen. If you are going from up, then there are maybe some chances. So, if you are going from up antigradely, then sometimes we put a filter, do the procedure, and then we may even remove the filter if we are sure that everything is removed, or we may leave it there also and then subsequently remove it.
Thank you. Any questions from the chairperson?
Anticoagulants after the procedure, how much time they have to be
Sir,
given?
usually if it is if it is a provoked DVT, so after the provocation is complete, we should give for at least 3 months anticoagulation. If it is an unprovoked DVT, again 3 months at least we have to give, but sometimes these unprovoked means there is something in the patient which is causing their DVT. It is not some external factor that caused it. So those patients have in fact higher chances of recurrence of DVT. So in these patients, if there is another recurrence, then probably you have to give lifelong, and then you have to check for this factor 5 laden, protein C, protein S deficiency, antiphospholipid syndrome. All these things should be checked in these unprovoked DVT patients.
And secondly, Dr. Amitabh has told that if you remove the clot, it's not the all clot is removed.
Yeah.
You need to follow with a catheter-directed thrombolysis. Presently, we are not giving thrombolysis because there is a high dose and risk of brain hemorrhage. But what they do is they put a multi-hole catheter at a clot section and give very low dose of actylase or medicines, so that dissolve the clots. And then long term we need anticoagulations.
So these catheters are actually quite costly, so some patients are not able to tolerate them. In fact, there was one patient who were not able to afford. In that patient we did catheter-directed thrombolysis of the pulmonary vessels, and very good result. But then again, it requires resources. You have to keep the catheter inside for 24 to 72 hours, and then all other complications can
One question to Dr. Devendra Agrawal regarding the cost of the leadless pacemaker and affordability part, and also the life of the leadless pacemaker.
So the life of battery depends on how much the patient is requiring, and if the patient is 100% dependent, with the new algorithm where the voltage output is set to the lower side, we can expect a battery life of around 10 years around. With the dual pacemaker setting, it goes down, but the single chamber pacing, it is around 8 to 10 years at least. And the cost, it's in the range of 10 to 12 lakhs.
So these are the Medtronic that the one company is providing the pacemakers which are not retrievable, and the battery life is 8 to 10 years, and they have studies up to 4 these kind of pacemaker can be put in the right ventricle. Where now the recent version of that company has come up, in which the battery life is supposed to intermittent pacing, then it's to 10 to 15 years. And after 10 to 15 years, when the battery life is completed, you can retrieve and put another one.
Right.
So any kind of patients you want to say that where we should not go for this leadless pacemaker?
Dr. Devendra, but I just want to ask that all the indications which you gave for leadless pacemaker was in patients who have local problems like vasculitis, infection or thrombosis, hemodialysis. It means it is not the first line to be given.
No, that's
what only reserved.
That's what I was asking. It can be used as a first line. Yes, presently what we have is a single chamber pacemaker, only ventricle chamber, and a lot of patients and elderly patients, they are going as a first line therapy also. Okay. For these leadless pacemaker, but it's a costly affair in comparison to like a routine pacemaker is costing nearly 5 lakh rupees, where this costs around 12 to 15 lakh rupees. But yes, there is a significant advantage of these pacemakers. But any kind of an absolute contraindication where you should not go for leadless pacemaker.
And they are MR safe also?
Yeah, they are
MR safe.
So AV synchrony, because we have mostly is like the VVI pacing here. We have that mechanical AV synchrony in Micra, but if we are using the single pacemaker in the ventricle itself, then we lose the AV synchrony, and the patient, they have heart failure symptoms or they have PEF symptoms where you think that AV synchrony needs to be maintained, then we should go for the conventional. Otherwise, we will not get the AV synchrony in these leadless pacemakers.
So largely what I mean to say is, if the person has a normal LV function, then you can comfortably go for the leadless pacemaker, particularly elderly guys. But if you have an LV dysfunction where you need a tachytherapy also, in those patients you need an anti-tachytherapy like an AICD, which also has an inherent pacemaker. It's better to go for the conventional.
So few patients where it is actually very helpful. One, frail old people where you have chances of infection. Second, in patients who are on dialysis or who may require dialysis, because many patients you have fistula here, you put a pacemaker there, the fistula will not work, or subsequently they require fistula, then that becomes a challenge. So that is CRF patients who may require dialysis or who are on dialysis, I think they are a very good candidate for this.
And secondly, the patients who are on compulsion of blood thinners also. Because then you have more chances of pocket hematoma and infection. Suppose mechanical valve replace, the patient has to be on the warfarin, because you need to change to the heparin, then to stabilize, and again you have to restart that warfarin, so that there are more high chances of getting this hematoma of the pocket and infection, these things. So there I think also we should prefer to have leads.
They are working by a percutaneous method, but there is no leads are not there.
There's no, that
So
battery lead, everything within this small minuscule.
Any special precaution, like for example, a lot of electronic gadgets are there, we go and nothing like that.
Presently I don't think, and Dr. Jha is there to come on the stage.
Now.
So let us stop this thing.
So thank you, Chairperson and the Speaker, and I request the Chairperson and Speaker to come to the felicitation dais. And there's a lucky draw, Dr. Amitabh. Sir, lucky draw निकाल दो आप. बहुत बोला आपने तो थोड़ा सा.
Dr. Amitabh and me were colleagues at GP Pant Hospital. Now he is heading the department at Holy Family. He is the only consultant who has a good experience of renal denervation. Presently,
Anurag Ranjan. Is he present? Dr. Anurag Ranjan. Manjula Suri. Good, good. So we'll have inauguration. Just wait for the family. Thank you.
वाला टेबल क्लीन करवाना है? पहले भी जो लगा हुआ था।
तू हटाना ना वहाँ से नहीं।
जी।
प्रिया जगह बनने दो ना। हो गया रेडी? बैठ जाओ आप लोग, बैठ जाओ बैठ।
Good afternoon, friends. Please be seated. We are going to have an inauguration ceremony.
Jyoti, not required. Not required. सर ये ठीक है। सीढ़ी भी कवर हो गया यार, सीढ़ी भी कवर हो गया, सीढ़ी भी कवर हो गया। बहुत नीचे ही ठीक रहेगा, सीढ़ी कवर हो गया। हाँ बोलो। अभी कहाँ किसे बोल दिया? नहीं नहीं खाना नहीं खिलाना। नहीं भी नहीं नहीं नहीं।
हाँ स्टार्ट करें। नमस्कार। On behalf of North Delhi Vision Forum and Fortis Healthcare, I welcome you all for the inaugural ceremony of Cardicon 2025. Sorry. Anyway, North Delhi Vision Forum के हम लोग हैं ही। I am a Delhi North Zone and Fortis Healthcare. without wasting any time, for last about 3 years, we are having Cardicon 1, 2, 3. This is third one, and has been amply supported by Fortis Healthcare, plus Dr. Naresh Goel has been very particular, and his personally is involved in this, and all the scientific session is managed by Dr. Naresh Goel. So give a big hand to Dr. Naresh Goel, please. First of all, I invite Dr. Girish Tyagi, our chief guest, and request Dr. Priya Panchali to accompany him, escort him to the dais. Dr. Girish Tyagi, please. Dr. Girish Tyagi needs no introduction. He is the president of Delhi Medical Association. He has been the secretary of Delhi Medical Council for the last 20 years. So, Dr. Girish Tyagi, sir, please. Now, I request Mr. Mahipal Vanot. He is the business head Fortis Healthcare, and I request Dr. Parul to escort him to the dais. Please. Now I request Dr. Praveen Bhatia, he is our president of IMA Delhi North Zone, to come to the dais. Then Dr. Naresh Kumar Goel, he is the chairman of this conference and the brain behind this all conference. Dr. Naresh Goel, sir. And our dynamic Dr. R.M. Chawda, he is the chairman of scientific committee of this conference. He is the founder president of North Delhi Fashion Forum. Then I invite Dr. Naveen Kumar, he is the general secretary, IMA Delhi North Zone, to come to the dais. Dr. Sonia Bakshi, she is the finance secretary, Delhi North Zone, to come to the dais. And Dr. Satish Tyagi, he is the president-elect for the next year, to come to the dais. So without wasting any time, I request Dr. Praveen Bhatia to honor our chief guest, Dr. Girish Tyagi. And now I request Dr. Naresh Goel to honor our guest of honor, Mr. Mahipal Vanot. बाहर से आ जाओ सर बाहर से आ जाओ बाहर से हाँ Next, Dr. Ambika Modi to honor Dr. R.M. Chawda. And Dr. Alka to honor Dr. Naresh Goel. Please, madam. Dr. Bhatia to honor Naveen, Dr. Naveen. And Dr. Sudha Handa to honor Dr. Satish Tyagi. And Dr. Jasoda, please honor our Finance Secretary, Dr. Sonia Bakshi. कौन करेगा? And now I request one of the senior person, Dr. Naresh Chawla, to honor our President, Dr. Praveen Bhatia. Please, sir. आइए सर. सर ताली बजा दीजिए डॉक्टर चावला के लिए. He is a former Vice President of Delhi Medical Council and a very renowned medical activist. ये फोटो बढ़िया से लो. May I request Dr. Praveen Bhatia, our President, Delhi North Zone, to say a few words. Yes, sir. Please. Yes.
Respected Dr. Girish Tyagi and Mr. Mahipal Singh Bhainot, our chief guests and guest of honor, Dr. Naresh Kumar Goel, Dr. R.M. Chopra, Dr. Nishinath Jha, Dr. Naveen Kumar, Dr. Sonia Bakshi, and Dr. Satish Tyagi. I welcome you all on the stage, and all the dignitaries on the dais and off the dais, and our esteemed faculty, colleagues, and all the friends. It is my proud privilege as President of our Medical Association to stand before you today at the inauguration of this prestigious conference. And this gathering is not merely an academic event but a celebration of our shared commitment to the noble profession of medicine. So medicine today stands a fascinating crossroad. On one hand, we are facing a lot of stress, medical legal problems, and on the other hand, emerging diseases, lifestyle diseases, and we have to cope up with all these things. And newer techniques like robotics and artificial intelligence and next generation diagnostics are also coming, and we have all to update about these things. The responsibility before us is to embrace all these new techniques and to adopt to these techniques. The conference has been thoughtfully designed to bring together some of the finest minds in the medical science, and especially cardiology. We already had some sessions, and over these sessions we had a very nice, excellent information, and next few minutes we will have more of sessions and something about the medical legal problems too. I would also like to place on record my deep appreciation for the organizing committee who have worked tirelessly to make this academic feast possible, and my special thanks also goes to the Fortis Hospital and to our partners and sponsors for their valuable support. With these words, I wish all the best to everyone. Let us finish with the conference, this particular inauguration session. I would like to give the mic to Dr. Anand Jha, please.
Now I request Dr. Mukhi. Dr. Mukhi, please say Dr. Anand Jha.
अच्छा.
ये स्पेशल होगा.
Dr. Anand Jha to be honored by Dr. Mukhi.
हम इसको नहीं भूलते, ये भूल जाता है.
Now I request all the dignitaries on the dais, please come for the lamp lighting, please. षष्ठी बनना लगा दो.
आरोग्यं धनसम्पदः शुभं कुरुध्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम्
Thank you, sir. Please come on the dais again, sir. Guests, please. Now I request Mr. Mahipal to say a few words. Please come.
Good afternoon. Thank you, Dr. Jha and Dr. Goel, dignitaries on the dais and distinguished clinicians. Very, very good afternoon and warm welcome on behalf of Fortis Healthcare. It's an absolute privilege and honor for me to be standing in front of all of you and sharing this time and space with all of you. This is a wonderful occasion to exchange the new developments in the field of cardiac sciences. And I'm sure the new methodology, the new advances that have been discussed will go a long way in improving clinical care and clinical outcomes. At Fortis Healthcare, we run 28 hospitals across length and breadth of the country. Our hospital in Shalimar Bagh is one of the finest institutes that we have in our network. With 3 cath labs, there is a lot of advanced work that gets done in the entire cardiac spectrum, not only in cardiology but cardiac surgery. This is backed by the advanced technology when we talk about either ECMO or IVUS, Rota, OCT and Impella. So I think it's the hard work of our clinician which has actually placed this institute as the most preferred institute in this part of the Delhi, and amongst our entire network this institute gets the maximum number of primaries. I think this is credit to all our clinicians, the trust that the community has placed in this particular institute. And at a group level, one of the program, the clinical outcome that what we monitor is STEMI, where we look at door to balloon time less than 90 minutes is what we track. And at a group level and at Shalimar Bagh, our door to balloon time is less than 90 minutes in more than 98% of the cases, which is a commendable work. I think this is where when you have the finest of the clinician, the latest technology, the clinical outcomes are bound to improve, and the morbidity and the mortality reduces significantly, the outcomes are absolutely superior. So congratulations to Dr. Naresh Goel and his entire team in leading this vertical. And he's a very, very passionate cardiologist, and specific, his main driver is on the heart transplant program. So he also runs heart failure program. At Shalimar Bagh, besides organ transplants and kidney transplant and liver transplant, we actually have the license for heart transplant as well. And I'm sure with the advancements that is happening, with the exchange of ideas that's going to take place today, the academic and the technical front, I'm sure this institute will continue to do well, continue to set new milestones and continue to do better in clinical care and patient services. So thank you to all of you for sparing this time. Thank you for inviting me here, and compliments and congratulations to all the organizers. Thank you very much.
Thank you, Mr. Mahipal, for the nice words and vision for the Fortis Healthcare. Now I request our chief guest, Dr. Girish Tyagi, कुछ आशीर्वचन हम लोग को दें. Dr. Girish Tyagi, please.
Thank you, Dr. Jha. Dr. Praveen Bhatia, President IMADNZ. Dr. Naveen, Secretary IMADNZ. Dr. Satish Tyagi, President-elect. Dr. Sonia Bakshi, Finance Secretary.
Dr. Mahipal ji, guest of honor for today's program, Dr. R.M. Chavda, Dr. N.N. Jha, Dr. Naresh Goyal, who are principally involved in the organization of this conference. First of all, congratulations to Dr. Praveen Bhatia and his team of members who are organizing this conference, because these conferences are required to upgrade our knowledge so that we can perform better in delivering the patient care in a better way. At the Delhi Medical Association, there are certain issues, of course, which pertains to doctors at large, be it a single clinic or a nursing home or other issues. Mahipal ji is here, who is representing the AHPI also. With the AHPI, Delhi Medical Association and AHPI are taking up the issues which are pertaining to the nursing homes, small as well as the big nursing homes. Recently, with the HPI and Delhi Medical Association, we have tackled the issue of insurance with one of the company, which were blackmailing, or you can say that doctors and the nursing home in delivering the issues. And Dr. Sunil Khetpal is also there, who is the secretary of HPI. So I thank Mahipal ji, Sunil Khetpal, and other members of the HPI who are working in association with the DMA. As far as the other issues are concerned, like recently there was an issue of DPCC, Delhi Pollution Control Committee, in which they, for the last so many years, we are asking that single clinics should not be charged for that DPCC, because they are not generating much waste, and a clinic run by the MD medicine people or a psychiatrist people who are just, or a cardiologist, they are not generating any waste, but they are forced to register with the DPCC company, and of course there are only two vendors. The monopoly is there. So with the Manjinder Singh Sesa, who is the environment minister, TMA and he has agreed to our proposal, and today also in the newspaper it was mentioned about that these things should be tackled. So DMA is looking after the issues for that matter. There are certain issues like registration of the nursing home, which are long pending, and with the fire NOC and other harassment by different agencies, whether it is nursing home cell or fire people or corporation people or and whoever is there, they just want to harass that. So we have to be united. We have to face our united front to that public, and simultaneously we have to image our professions, medical professionals, in the eyes of the public, because at the moment every section of the society, whether it is public, whether it is police, whether it is media, whether it is politician, whether it is judiciary, they are hostile against the medical professional. इमेज यही है कि डॉक्टर लूट रहा है, कि कितनी मेहनत कर रहा है, कितना अपना काम कर रहा है, कितने प्रेशर में काम कर रहा है, कितना whether it is being exploited by the government sector or the private sector or wherever he is working, there is exploitation of the doctor. But they are thinking that डॉक्टर लूट रहा है. अगर कोई डेथ हुई तो डॉक्टर ने मार दिया, डॉक्टर ने लूट लिया, डॉक्टर कातिल है, and these kind of things are going for a long time. So we have to improve the image of medical professional, and that will be possible if we are united. सबसे ज़्यादा दिक्कत हमारी ये है कि हम यूनाइटेड नहीं होते किसी चीज़ पे भी, और हमारे पास जो वेपन हमारे पास होता है, एक आज की डेट में भी कभी मेडिकल एसोसिएशन ने अपील करती है किसी इश्यूज़ के ऊपर कि हम टोकन स्ट्राइक पे जाएंगे. टोकन स्ट्राइक पे ही जाते हैं, उससे ज़्यादा हम सोच भी नहीं पाते. ना मेडिकल एसोसिएशन को पता है कि हमारी औकात क्या है, कि हमारे को कितना सपोर्ट मिलेगा. टोकन स्ट्राइक पे भी एक हॉस्पिटल खुल रहा है, बराबर वाला उसका देख रहा है, नर्सिंग होम है, उसने इनिशियली बंद करा, देखा पड़ोस का क्लिनिक बंद है, नर्सिंग होम में उसने अपना खोल दिया 11 बजे के बाद कि वो सारा ख़त्म है. तो और वो भी हम कम कर रहे हैं. कर रहे हैं कुछ प्रोटेस्ट करना है तो संडे को मॉर्निंग में कर रहे हैं कि संडे को मॉर्निंग में ज़्यादातर क्लिनिक बंद है, नर्सिंग होम बंद है. तो वी कैन नॉट थिंक कि हम उसको एक पूरे दिन के लिए भी हम अपील कर पाएँ. पूरे दिन के लिए अपील भी करते हैं, तो 11 बजे तक थोड़े खुल जाते हैं, लंच तक ऑफ कोर्स बंद होता है, इवनिंग में सबकी ओपीडी और नर्सिंग होम की क्लिनिक वो सारे चालू हो जाते हैं. सो अगर इस तरह का, और हमारे पास एक वेपन हमारे पास जो हमने आज तक कभी यूज नहीं करा, वी हैव नेवर यूज्ड द इमरजेंसी मेडिसिन. इफ वी कैन just told the government that we will force our medical professionals to not to entertain emergency. सिर्फ प्राइवेट में, गवर्नमेंट को भूल जाओ. अगर गवर्नमेंट आ जाएगी साथ तो सरकार अपने आप ही जो हाईएस्ट लेवल पे, चाहे पीएम है चाहे एचएम है, कोई भी लेवल पे आपके पास बात करने के लिए आएगा. बट एटलीस्ट इफ वी कैन टोल्ड देम दैट वी एट द प्राइवेट सेक्टर विल नॉट डू द इमरजेंसी फॉर सच एंड सच. आप 1 घंटे के लिए तो अपील करिए. But we have not done so. We have not. Why? Since we have not faith on ourselves, our colleagues, etc. So, my appeal is unite रहें. And once again, congratulations to IMDZ for doing such kind of work. और बाकी जो इन सीएमए के साथ साथ हमारा जो सोशल, हमारा को हम सोशल कैसे अपना इमेज इंप्रूव कर सकें, उसके बारे में भी थोड़ा सा ध्यान करिए. और वेयर आई गो मेडिकल लीगल पे, आई वाज एसिड विद दिल्ली मेडिकल काउंसिल फॉर सो मैनी ईयर्स. सो एवरी आज की डेट में पेशेंट के पास क्या ऑप्शन है? ही कैन फाइल कंज्यूमर कंप्लेंट, पुलिस कंप्लेंट, सिविल कंप्लेंट. ही कैन गो टू द NHRC. एक NHRC में उसने सिर्फ एक कंप्लेंट करनी है, और NHRC की मशीनरी इतनी स्ट्रॉन्ग होती है, वी नो एट दैट NHRC जस्ट सम नोटिस द सेक्रेटरी हेल्थ कि वाई इट इज सो. और सेक्रेटरी हेल्थ अगर ने एक बार सेक्रेटरी हेल्थ DHS को लिखेगा, DHS या दिल्ली मेडिकल काउंसिल को लिखेगी, तो ऑटोमेटिकली दे हरेसमेंट दैट आपके पास नोटिस तो आएगा कि रिप्लाई टू दैट नोटिस इज इटसेल्फ इज अ हरेसमेंट. सो वी शुड wherever go, 4 things are there. First, try to communicate with the patient, because 90% of the patients are complaints against the doctors because of poor communication, and we are not. And then worst thing is that it is documentation, because we are doing most of the things but we are not documenting, and if it is not documented, it is presumed that it has not been done. So communication, documentation, documentation of communication, and communication documentation, if you follow at 20% of these in our clinical practice, most of the complaints against us will be low. So thank you Dr. Praveen Bhatia, Dr. Naveen Kumar, Dr. Sonia for giving me a chance to address this, and I wish you wonderful year. Thank you very much.
Thank you, Dr. Tyagi. We are proceeding further. We welcome our guests from the other branch, Dr. Mukesh Gupta and Dr. S.K. Podar. I request Dr. Abhishek. Dr. Abhishek, please honor our guest. Jaldi, jaldi. Dr. Podar को बुला लो. Dr. Podar, please. Do I request Dr. Praveen Bhatia, I am a president, to honor our guest, Dr. Girish Tyagi, with a memento. Memento, please. अब बाहर आ जाओ, बाहर आ जाओ. नहीं, इनको बोलते बाहर आ जाओ. प्रेसिडेंट को. तो हमारा डॉक्टर गिरीश त्यागी. And Dr. President, to honor our guest of honor, Mr. Mahipal, please. आप इस दे दो सर अंदर से. and Dr. Bhatia to honor Conference Chairman Dr. Naresh Goyal for putting such a great effort. So now we all request all of you to please stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे।
बहुत बहुत धन्यवाद. सो दिस इज द एंड ऑफ सेशन और लंच इज नाउ ओपन. एक अनाउंसमेंट है, इसके बाद इमीडिएटली एक लीगल पर्सपेक्टिव पे डॉक्टर नरेश चावला फॉर्मर प्रेसिडेंट वाइस प्रेसिडेंट दिल्ली मेडिकल काउंसिल का लेक्चर है. तो हमारी लेक्चर दोबारा स्टार्ट हो जाएगी 3:15 में. आधे घंटे का लंच टाइम है. सो धन्यवाद. सो वी एंड द सेशन नाउ. थैंक यू. जय हिंद.
हाँ हाँ आधे घंटे में बना है तो डीलर कर दिया कि चावल का देखते रहे
कितने बजे चलना है?
कितने बजे का टाइम है
इसका 5 बजे का है.
Good afternoon. In another 5 minutes, we are starting the next session. Just after 5 minutes, we are starting the scientific session again.
Good afternoon, everyone. I know it's a post-lunch session. We are already running late for our session, so we will be starting now. The session now is a very important session which is required on our regular practices, and it is legal aspects of medical practice current perspective. So Dr. Chawla will be giving this lecture. He is okay. So this session will be a little late. Currently we will have the cardiology session now, and for this session I'll request on stage the chairpersons for this session, Dr. Sunil Verma. Sunil Verma, sir, kindly come up on stage to chair the session. Dr. V.C. Jain, General Practitioner, Dr. Ashok Agarwal, Senior General Practitioner, and Dr. Rakesh Sood, who is the General Practitioner and Consultant at Fortis Shalimar Bagh. Sood sir, are you there? And the topic for this session is lipid conclave, and we are most of the times confused. Doctor. Dr. Priya Pancholi, a practicing gynecologist. Dr. Priya Pancholi. So, over to you, sir, to start the session now on lipid conclave.
Just before the chairpersons do start, friends, this is a lipid conclave because nowadays, if you can understand, with the coronary artery disease largely based on atherosclerotic, and it's not limited atherosclerotic heart disease, coronary disease, they are also involved in the cerebrovascular disease as well as the peripheral artery disease. We have tried hard from a long time to control the lipids, the bad lipids as well as to increase the good lipids. There are lot many things beyond LDL and HDL like lipoprotein little a, and we have now newer medications because we have seen the statins and its complications. So for that we have kept this particular scenario where we are going to discuss the lipid, particularly what is the new in the lipid and how we can control. And is it necessary to take the medication for a longer duration, or can we reduce the number of medication to control the lipid, to take care of the lipid in the atherosclerotic heart disease? So over to the chairpersons.
Can you hear me now? Okay. In this postprandial session, I am sure we have these three doctors with us in this session, and they are excellent speakers, and they will give you no occasion to sleep. They will give you a lot of learning notes. So kindly listen carefully. We have with us the first speaker, Dr. Kuldeep Arora. He is an MBBS graduate from Jabalpur. He has done his MD medicine from Bhopal, and he has done his DM cardiology from Bangalore. He is presently the unit head and chief cath lab. It will panel this. Okay. Okay. So this talk has been converted into a panel session. We have Dr. Kuldeep Arora with us. Please, Dr. Kuldeep Arora. Dr. S.K. Agarwal. He is a senior intervention cardiologist, Kailash Hospital, Noida. And Dr. Anil Dhal. He is a very old colleague of mine, and he is going to chair the session. He is an excellent soul. So over to Anil Dhal.
Good afternoon, everybody. I'm sure that
everybody enjoys a Sunday afternoon lunch. And people ask me, why are you not partaking of lunch? I say, because a Sunday afternoon lunch is to be followed by a Sunday afternoon siesta. So if you are not going to have the siesta, because we are going to have a talk, or we are going to have a discussion, then it's better not to have the lunch. So it's a great privilege to be here amongst friends and luminaries, and I have with me two very senior and eminent colleagues who I've known for a long time. Santosh has come all the way from Noida, and Kuldeep has come all the way from Gurgaon. Anything? It's not connected? Right. All right. Is it connected now? All right. So we are actually, I was told to set the preamble. I was told to set the stage because as we are having this session here in Madrid, the 2025 European Society of Cardiology Congress is taking place, and in that there has just been a focused update on dyslipidemias which has been presented. We all know that India is the world capital of diabetes and heart disease, and we also know that cholesterol is one of the most important chemicals which is involved in atherosclerotic cardiovascular diseases. In 1918, the Surgeon General of the Russian Army, Nikolai Nichkov, first decided to experiment with the lipid hypothesis. And we worked a long way into developing that whether these lipids that we ingest go into our cholesterol, into our arteries. But it came as a little bit of a surprise as this evolved, and our concepts changed, that only 15 to 20% of the lipids of your LDL cholesterol actually comes from the food that you ingest. So don't mind whatever Naresh has fed you just now. So it is all right, you know, because only 15 to 20% of your cholesterol comes from there. The rest the body synthesizes. And we all looked all along at first at creating drugs which would block the absorption. Then we looked at drugs called statins which acted on the rate limiting step of cholesterol biosynthesis, what we call the HMG coenzyme A reductase inhibitors. And then we are still looking at best solutions. But in 1984, Goldstein and Brown were awarded the Nobel Prize for elucidating the structure of the LDL receptor. And in that receptor, today all our focus is for that receptor, because that receptor traps the LDL, takes it inside the liver cell, converts it into bile acid. Now this receptor can upregulate and downregulate. So if you decrease your intake, you don't have lunch, then your receptors may downregulate. So likewise, we need these receptors to be upregulated. Now these receptors break down by themselves by an enzyme called PCSK9. And if we inhibit this, well, then we can possibly make sure that the receptors are more. If there are more the receptors, more LDL will be cleared by the liver cells. And utilizing the small interfering RNA, we actually have great drugs, and as you probably know, the small interfering RNA acts by what is called the GalNAc pathway, and it has long effect. So I am just going to say that we are going to ask a few questions. We have with us Dr. Santosh Agarwal from Noida, from Kailash Hospital, a very old friend and a very senior reputed interventional cardiologist, and Dr. Kuldeep, who is from my erstwhile hospital, Artemis in Gurgaon. So I would like to start by asking a question to to Santosh. How low would you go in respect to the target LDL reduction? So why don't you come and take on, or I can read the slides out if you want to see. You can come here.
Yeah, yes.
So good afternoon, dear friends. We are here to discuss about the LDL cholesterol management. And obviously, as Dr. Dhal have enumerated that LDL cholesterol is the most important risk factor for development and progression of atherosclerosis. Enough data is available that if you lower the LDL cholesterol, you reduce the cardiac events significantly. So current strategy, what we have is that you start LDL cholesterol lowering therapies early, go with the higher doses, bring it down as low as possible, especially in patients who have established ASCVD, and continue therapy for prolonged period of time, because it's not only the absolute level of LDL cholesterol which is important for development of atherosclerosis, but also exposure of the vessels over the period of time. So when it comes like how much LDL cholesterol to be reduced in patients who have ASCVD, means they are known patients with cardiac or cerebrovascular disease or peripheral arterial disease. So obviously, lipid management looks little bit complex, and it is made complex especially by availability of so many guidelines. But as of now, if you see, we have got two important guidelines from our country, that is from Lipid Association of India and Cardiological Society of India. And another very important guideline we follow is the European Society of Cardiology guidelines. So as Dr. Dhal was just saying that right now also European Society Cardiology conference is going on, and they have only few days back they have come up the update in 2025. There is very little difference between the three guidelines, but mostly we follow either the LAI or CSI guidelines. So any patient who has ASCVD, he falls, we classify these patients into low risk, moderate risk, high risk, very high risk, extreme high risk from LAI classification. So any patient who has ASCVD, he falls into the very high risk category or extreme high risk category. Low, moderate and high is like before development of ASCVD. So any patient who develops ASCVD, if you have more than 50% stenosis, either clinical event he had or on imaging basis, so he has ASCVD, and then the patient's targets are to be lowered. European Society and CSI guidelines say that the LDL cholesterol should be brought down below 55 mg/%. LAI is little more stricter, and it says that in patients with ASCVD, the LDL cholesterol should be brought down below 50 mg/% to reduce the future events. But this is like in patients who are just simply falling into the very high risk category. But then there are extreme high risk category also, which is again like LAI classified into extreme category A, B and C depending on certain features. And there they recommend even to bring down the LDL cholesterol not below 50 but even below 30 and even below 15 mg/%. So this is what different guidelines actually say that what should be the. So here is a summary of 2023 ESC guidelines. So if you see from the first part, any patient who presents with ACS, and suppose he is not on the statin therapy or he is taking low dose statin therapy, then they should be initiated on high dose statin therapy so that you bring down the LDL cholesterol below 55. If patient is suppose already having high dose statin therapy, he comes to you with a high dose statin therapy means rosuvastatin 40 mg or atorvastatin 80 mg to understand. So if he is having a high dose statin therapy and still he presents to you with an acute coronary syndrome, then what next to be done? If the LDL cholesterol is below 55, no problem, you continue with that. But if LDL cholesterol is more than 55, then the next step comes into the picture is they recommend to add the ezetimibe 10 mg along with the high dose of statin. After 4 to 8 weeks, 4 to 6 weeks, you reassess his LDL cholesterol profile. If LDL cholesterol comes down below 55, it's fine. If it doesn't comes down below 55, then a third drug has to be added, which could be like Indian guidelines say bempedoic acid. European guidelines still do not favor too much of bempedoic acid. Of course, in 2025 update, they have mentioned about bempedoic acid. Then you have to go for the PCSK9 inhibitors. So we have two subsets of PCSK9 inhibitor, monoclonal antibodies, and of course, small inhibitory RNA transfer, SIRNA, what we call. So that is inclisiran. So these are the two classes of drugs. So that is how we go on to. This is a CSI strategy, how to reduce the LDL cholesterol in patients with ACS. So as I mentioned, initiate, do a lipid profile very early on the very first day. Non-fasting lipid profile has to be carried out. It's not essential to have a fasting lipid profile. Initiate, CSI guidelines say that you initiate a combination therapy. So European Society and CSI guidelines from India, they differ into this mentioning that European guidelines say that you start with the high dose statins after 4 to 6 weeks. If the cholesterols are not up to the mark, add stemide, and again 4 to 6 weeks. If not under control, add bempedoic acid, or maybe go to the PCSK9 inhibitor. But Indian guidelines recommend that you start with the combination therapy right from the day 1 in ACS patients. Why? We have enough data that probably single use of monotherapy, high dose use of statins do not reduce the LDL cholesterol sufficiently, especially in Southeast Asian population. In fact, in ESC Congress also one paper has been published yesterday only from day 1, like from India, which showed that use of high dose statin is associated with LDL cholesterol reduction below 50 in only 42% of the patients. So Indian guidelines recommend that you use high dose statin along with estimide. After 4 weeks, you check the cholesterol, LDL cholesterol. If it is at label below 55, fine. Otherwise, you add the bempedoic acid. Another 4 weeks down the line, you recheck the lipid profile and LDL cholesterol. If it is below 55, good enough. If not, then you have to use the PCSK9 inhibitors.
So, I think he's already covered most of the issues. So I just want to ask you, Santosh, in a post-ACS patient, given a scenario a few years ago, we were not testing the lipids and we used to wait, and then we would start, and then came the idea of using high-intensity statins, and then even then we used to wait for 4 weeks. So you are clear now that we should start intensive regime right from the beginning. You agree? So so because there is a risk of recurrent events in ACS patients, so strike early, strike strong, and these are patients at high risk of future events, and all guidelines recognize that early intervention is critical to improve outcome. And how do we do that? Well, we can do that by either using, there are various mechanisms. So in a hospital, what do you do in your practice if you have a patient who has got very high, or where he's got an ACS? What is your practice? Do you start high intensity statins, ezetimibe? Do you add bempedoic acid, because there is some data also by mathematical modeling we can get benefit, or do you go for an injectable? Come answer here, because I think
So in all ACS patients, there is no doubt that right from the day 1, we start with the high dose statin therapy. That means either rosuvastatin 40 milligram or atorvastatin 80 milligram, along with estimide, especially if a patient has other high risk features. So although CSI guidelines have recommended to use the combination therapy, and it should be, I think, but many times...
So guidelines are also evolving. You'll understand that this time the hypertension guidelines from the US which have come, the biggest achievement is that they've got a fixed dose combination. India is a land of fixed dose combination. We've had fixed dose combinations for many, many decades. But for the first time, the 2025 hypertension guidelines, there was a lot of excitement in the US because the Vicadilip, which is a combination of an ARB, a calcium channel blocker, and a diuretic, has been approved. So we are actually good with intensifying our treatment. Our Bhishma Pitama of cardiology is Professor Eugene Grunwald. He is 96, 97 years of age. He is still functional. The textbook of cardiology that we studied was written under his name. And he wrote an editorial about 2 years or 3 years ago in European Heart Journal, and he wrote an editorial which was very interesting. Because it is not only the amount of LDL cholesterol, but the duration of LDL cholesterol is also important. So he conceptualized, just like 30 years ago we used to talk about cigarette pack years. How many packets of cigarette do you smoke for how many years, and that adds to risk of lung cancer. So he actually identified something called LDLC gram years. So, and he said, if you want to live to be 100, keep your LDL as low as possible for as long as possible, and use whatever means to get this down as low for as long as possible. And to discuss this, I'd like to invite Kuldeep to say a few things. How do novel therapies like inclisiran fit in this space?
Yeah. Thank you, sir. So we all know LDL is the most common modifiable risk factor for heart disease. Still, we are not controlling it. We are aware of the target, but unfortunately, less than 10% of the patient achieve LDL of below 55, which is desirable in high-risk coronary artery disease patients. So, how does we can achieve that? The journey starts from PCSK inhibitor, which started way back in 2003, when the initially PCSK work was started. And after that, after some years of work, in 2020, Novartis took over the inclisiran. After that, there are rapid Orion programs were there, and now a lot of approvals for inclisiran is available. When we say how inclisiran works, so if we see this, these are our LDL particles, and on the surface of liver, these are the LDL receptors which take care of the LDL. So if somehow we can increase the LDL receptors, we can reduce the LDL. And LDL receptors are downgraded or degraded by a PCSK protein. And we have to take care of this PCSK protein. If we just reduce the PCSK protein, we can increase our LDL receptors, and in turn will reduce your LDL. So initially, monoclonal antibodies were introduced, but the problem with the monoclonal antibodies were it has to be given twice a month. So it is quite cumbersome. For initially, even in my practice, initially people were quite motivated, but after some time they got exhausted, because taking injection every 2 weeks is a bit cumbersome. So we were looking for something which can be given in say once or twice in a year, that will take care of your cholesterol permanently. That is the thing which was desired, and answer was inclisiran. So we have ample data, LDL cholesterol reduction of more than 50% with the inclisiran, and there is no such thing like how low we can go. In fact, as low as LDL achieving below 30 or below 10 also is found to be safe. There were initially trials of like with statin, some concerns of dementia were there. But in the trials it has been found if we reduce the LDL to up to below 30 also, there is no such concerns of dementia or sugar impairment. Victoria Initiate trial said we have to start as early as possible and intensify the therapy. Now coming to this interesting concept of Braunwald, how to live 100 years before developing coronary artery disease. So they have identified, just like smoking pack years, we have cholesterol years. So there is no such thing, a person comes to you at the age of 30 years with say cholesterol of 140, 150, you say you are too young to start the cholesterol therapy. Wait for 30 years when all the cholesterol is deposited, and now this guy has become 60 years of age, and then you say now it is the time to start the therapy. So in this intervening 30 years, a lot of cholesterol deposit has developed. So nowadays the concept is no such thing like at the age of 30 years you should not start, same value, everything remaining same, at the age of 60 years you start. So this is not the way. So they say you start the cholesterol therapy as early as possible and reduce your overall cholesterol burden. So they have found this 7 gram% is the absolute limit. Once this 7 gram% of LDL cholesterol limit is achieved, in this example, so you develop coronary artery disease. We all see in our practice those guys who are having LDL of around 160, 170, they come to us here in their 40s with coronary artery disease. And we commonly see somebody who is having LDL cholesterol of 190, they develop coronary artery disease in their late 30s or early 40s. So 190, 200 cholesterol is coming to coronary artery disease here because his threshold is achieved here. So why not to delay this 7 gram % by introducing once in a year inclisiran therapy for all asymptomatic population, and once they reach their LDL goal 7 gram % at the age of 100 years. So you can prolong the life. This is just an interesting concept. This is LDL alone, we all know. If somebody is smoking, somebody is having diabetes, somebody is having uncontrolled hypertension, they play the role. But this is the concept. If you can somehow delay your cholesterol years, you can prevent coronary artery disease. This was oversimplistic things. Cholesterol, smoking, other risk factors plays the role, but this is very important. Of course, who are the patients? At this stage, we should be starting inclisiran in asymptomatic population. There are trials like Victorian Prevent trial is going on. We can check by coronary calcium score. Coronary calcium score is a very easy way, not much radiation, just like a mammography. Only coronary calcium score gives idea. If coronary calcium score is raised, that means somebody is having somebody is having non-obstructive coronary artery disease. So those are the patients. Or if lipoprotein A is significantly elevated, I will be coming to that. But those are the patients we should be at least starting therapy early. And if we say we are starting this injection, what is the safety data? So right now we have more than 7 years of safety data. Apart from injection site complication, no major complications. So this therapy definitely holds promise. We should be starting later on. Right now we are focusing more on coronary artery disease patient, but even for preventive where this therapy should be started, especially for Indian population which are very prone for heart disease. Apart from LDL reduction, commonly in our practice we see some lipoprotein A also plays a very important role, and PCSK right now is the only remedy available which reduces the lipoprotein A. Close to 20-25% reduction in lipoprotein A is achieved by PCSK inhibitor. We don't have, statin don't have any effect on lipoprotein A. Other therapies are not effective, and we have seen our practice, somebody who is having LDL close to borderline or mildly elevated with very high lipoprotein A, developing recurrent coronary artery disease. So PCSK right now is the only ornament in our thing which can take care of your lipoprotein A also. In hepatic and renal impairment also not much of the issues. Most of the drug is cleared once we give the injection. 4 to 6 hours after that it is cleared from the blood, and even in mild moderate renal failure or hepatic failure it can be safely given. So these are the trials which I said, they are looking for even in asymptomatic population, or even somebody is having non-obstructive coronary artery disease on CT coronary angiography, the inclisiran injection helps. So I'll invite Sarah to continue the discussion further.
So Kuldeep introduced a very important thing called lipoprotein small a. Lipoprotein little a is atherogenic as well as thrombogenic. It has 6 times more ApoB than LDL, and is definitely an amplifier of, just like I'm speaking to a loudspeaker, it's an amplifier of the LDL. So because we don't have any great drugs right now, our focus was to reduce the LDL. But now we do have lot of companies are working, and incidentally, if you in your practice have any patient who has a lipoprotein little a of more than 180, please contact us or contact your Novartis representative. We'll be able to get free pelacarsen. We'll be able to import that drug for your patient. So this is, I think, a very important thing which he has brought out, that lipoprotein little a is an amplifier. Then looking at coronary artery calcium score. Now the plaque which is there in any vessel can be of 2 types. It can be calcified, it can be non-calcified. I always give an analogy that imagine a tube with a single fried egg inside. When it heals, when you make it double fried, it heals, then there is a speck of calcium. That is picked up by the CT, and that is a CT calcium score. Now it is a surrogate marker. It is not a replacement for a CT coronary angiogram, but we know that there is a correlation. The higher the calcium score, more coronary artery disease is likely. Now 2 things I want you to remember. There used to be a value of 0. there was a value a few years ago, we used to think that if the calcium score is 0, this patient will not get disease for the next 5 to 8 years. We no longer think like that because soft plaques will be missed on calcium. The second thing which I want you to know is that this calcium is otherwise a little protective, because the calcium itself is not your enemy. The enemy is once this calcium protrudes, it is an enemy of the interventional cardiologist, because we have to break this calcium to place a stent. But otherwise, calcium, if you give a patient statins, calcium will actually increase. So if we consider all this, we still start, in a large majority of our patients, we still start with statins. We add ezetimibe because it is innocuous, it doesn't even have muscle symptoms. If somebody has muscle symptoms, we can add or substitute it with bempedoic acid. But in a large number of patients, in both, especially those who are at very high risk, which means that they have evidence of either a very strong amplifier circuit, which is a lipoprotein little a. Kerberg, I told you, described it in 1963, but we have realized the value only now. 25% of the people have very high lipoprotein little a. If we actually look at that, or we look at evidence of atherosclerosis in other organs, a very simple thing is to do a carotid Doppler and look for carotid intimal medial thickness, and we should find this out. Now, and the other thing is to do a calcium score or to do a CT coronary angiogram. In patients who have coronary artery disease, and especially those who are frequent flyers, who keep coming in and going out, the use of these agents which alter the LDL receptor go a very long way in controlling their LDL, so that we can get good results. Beyond so everybody is very conscious of the fact that we look at numbers, but actually we look at the risk of an individual, we collaborate it from others. Numbers are important, but more important than that is the risk of an individual. When we were born, we had 25 milligram of LDL cholesterol in our blood. It was enough for our brain to synthesize for all our neural development. So you should not be getting cognitive dysfunction. And in the trial called Fourier trial, which was using evolocumab, which is a monoclonal antibody similar, there was an Ebbinghaus sub-study where they reduced the LDL to below 20, and there was no cognitive dysfunction. Now, in these high-risk ASCVD patients, LDL reduction by more than 50% is desirable, and the convenience of 2 doses a year. Let me tell you something which is not in course or not this thing. The NICE, which is the National Institute of Clinical Excellence in the UK, has made a deal with Novartis, and they now have 2 injections a year given to a large number of patients in the clinics, because they have worked out the cost effectiveness, and they have shown to the government that if you pay for this drug, your admissions for ACS will come down, your admission for stroke will come down, and this has a very good safety profile for up to 6.8 years. So also, let me also tell you that because of a relentless pressure by us on this company, now they have actually decreased the cost, because it used to be 96,000, now we can have buy one get one free. So that is also a big thing. So just contact your neighborhood Novartis rep and you will get it. Thank you very much. If there are any questions, we'll take them.
Thank you, sir. And it was a wonderful session about this new molecule which has come up for that lipid lowering. So how long it has to be taken once it has occurred, or MI, or at what level you would like to, once the patient has an ACS and handed LDL above 70, 80 or 100, once the LDL is being controlled, to at what level you would like to stop the medication or try to titrate or detitrate or de-escalate the injections, because the public do have a kind of an impression that because we see lot of patients कि rosuvastatin 40 है उसको कम कर लें, atorvastatin 80 है उसको कम कर लें. So particularly when it's a matter of injection, so when you would like to de-escalate these injections?
See, as we have already discussed, lower is better. So in a patient who is known case of ASCVD, lower is better. But yes, of course, we do know that statins are associated with some symptoms, especially the muscle symptoms. So if a patient is not able to tolerate the medicine properly, he develops some side effects because of the medicines, then sometimes we have to de-escalate the therapy. When you de-escalate the therapy, it is important to monitor the LDL cholesterol again and again, at least every 4 to 6 weeks, until unless your targets are not reached, that is below 50 or 55. If diabetic and ASCVD below 30 maybe. So keep the levels below a certain level, below 50 or 30 depending upon the risk category. If patient develops symptoms, you can de-escalate, but then you have to monitor the therapy, and if in case you need to re-add, then maybe a second drug like estamib or bempedoic acid can be added. Continue it as the line A and line B 7 milligram year concept is there, so that has to be followed up. So indefinite therapy, long-term therapy, and to keep it below a threshold is important.
So I think he's summed it up very well, that keep the LDL as low as possible for as long as possible. But I think what Naresh's question was, how long do you continue inclisiran? Remember, this is a preventive therapy with a long-term goal. And we are all going to lead longer and longer lives. As with collective utilization, we hope that the price will come down as time goes on. And therefore, right now, we don't say that after some time you stop it. Remember, maximum risk of recurrence, the most activity of the plaque is initially after an acute event. So at that time, you certainly have to do it. Today, yesterday, there was a paper even for preservation of vein grafts. You know, although it is counterintuitive because vein grafts probably have a different mechanism by which it happens, but even for preservation of vein grafts, even for preservation of native coronary post bypass, there is going to be a role of these therapies. So I think we should continue for as long as possible and keep the LDL as low as possible.
So do you recommend any patient presenting with an acute coronary syndrome? We used to give an antiplatelet and statins. So we should give an plan for an injection.
So there is a trial called the Pacman AMI. There was no time to discuss all that. And Huygens study and Pacman AMI, and we have a lot of data. So in my practice, if the patient can afford it, they get a shot of an injectable when they come in with ACS. Now, affording is because we kind of democratize medicine, and we know that these are at present expensive modalities. So we have to respect that. But if a patient is a frequent flyer, if a patient has had, and if I do intracoronary imaging and I find that there's a lot of vulnerable plaques, I am a little more aggressive.
Thank you, sir. Any question from the audience?
Yes, ma'am. So there are many ways of, thank you very much for this question. There are many ways of handling statin-associated muscle symptoms. So in statins, we follow a rule of 6. So even a smallest dose of statins is going to help you. Now statins also, we understand that there are two kinds of statins. One are the lipophilic and hydrophilic statins. They all have different interactions. So suppose you take atorvastatin and you take grapefruit juice, its effect gets amplified. In fact, so much so that in many parts of this country we have lal pohe, which is red yeast rice. Now red yeast rice is also a statin. So if there is some value in decreasing the amount of statins and also in decreasing the frequency of statins, even the lowest dose works, and we call a rule of 6, which means if you double your dose, you will only have an additional 6 milligram reduction in LDL cholesterol. But there are many confounders to this, because confounders being that the patient has many other things which the patient does. So yes, this is one of those things, but all those challenges and those techniques have virtually gone with the availability of drugs like inclisiran. Now today, if I have a statin-associated muscle symptom, I try bempedoic acid. If it doesn't work, I am very happy to put this patient on inclisiran. You understand? Because I become safe, and I become sure. The greatest advantage of inclisiran is, usually because it's an expensive molecule, if he takes the drug, he will take it. The adherence is the biggest bugbear with statin therapy. Because once you tell somebody to take something orally and he does not realize the value, I normally start all my discussions on preventive cardiology by one slide, which is that no patient has ever come to me in my 43 years of clinical practice and said that, sir, thank you for prescribing a statin or an antiplatelet, because of which I never got an MI. Everybody, those who got an MI and I treated them, come and tell me that thank you for treating me in the middle of the night. So please keep that in mind. There are choices available.
Sir, how often HSCRP do you advise?
Okay, now HSCRP is a little controversial subject, because I understand that most of the labs don't actually give us HSCRP, because it requires nephrolometry and it requires to be done very correctly. Because HSCRP is a sign of inflammation, and this started with the Jupiter trial when we were trying to work out the appropriate dose, the utilization of statins, and if there is an extra inflammatory component, you need to be more aggressive. Just like I said, lipoprotein little a, if there is an elevated HSCRP. Now the data in Indians is a little confusing because we have a lot of cross infections in the lay public. So I don't use it very aggressively in my practice. However, I do something else, and that is the patient teaches you what is to be done. So if a patient has had a CT coronary angio, and which many of these patients who are now looking at this particular aspect would have had, then I ask them to get the CT evaluated for what is called perivascular fat index. And if that is showing an elevated perivascular fat index, this is after the Scott Hart trial, there is something called Carry Heart, there is a software, and if that is showing that there is a large amount of inflammation, I become more aggressive and I even look at this space of HSCRP. It will become very relevant in just a few years. There is a drug called zilbeticmab, which is undergoing trials. We are also part of some of those trials, which is actually an anti-inflammatory, because colchicine as an anti-inflammatory in these patients has been a little disappointing, at least in my practice. I hope I have answered.
Thank you, sir.
Thank you so much, sir.
Let's, in interest of time, we'll conclude the session later on.
We conclude the session.
Minimal calcification stabilize the athermatous plaque in the coronaries. Minimal amount of calcium scoring inside the coronary stabilize the athermatous plaque.
No, it's not that calcium is stabilizing the athermatous.
No. So you haven't got it right. When a plaque, we all have plaques. When a plaque heals, it will invite calcium. And that calcium will be a marker कि यहाँ कभी plaque था. So the more of that, the more likely is that there is more coronary artery plaque burden in that patient. So it is not, I was giving you a very philosophical view on calcium. It is a very broad subject, and this time is a little too short for us to discuss.
The calcium is there, that means there was a disease, and that really creates a problem during the intervention also. So we can't take it lightly, but yes, the softer plaques are more prone to repair. Thank you, sir. Thank you, Dr. Das. Thank you, Dr. Kuldeep. And thank you, Dr. Santosh.
We'll conclude this session now. I request all the speakers to go to the photo booth to have collect their mementos.
Please, sir, lucky draw निकाली से जरा ये.
And we'll have one lucky draw now.
ठीक है, lucky draw, sir.
The hall is sweating.
संतोष आप एक ही करते हैं, सर. एक ही करते हैं, सर. No. Dr. Sunita Gupta.
I request the chairpersons to be seated, please, for the next sessions. Sir, please be seated. We will have 2 more sessions. Then we will switch to the next sessions. 2 more sessions, sir.
Well, now I call upon Dr. Samir Mehrotra. He was. अभी नहीं, अभी समीर मेहरोत्रा. He was a little late for his talk, and his topic is stent-free angioplasty, the role of drug-coated balloons. Dr. Samir, please.
We requested the organizers to keep that topic for 30 minutes, 45 minutes, 30 minutes for lipid conflict, and 15 minutes for Mehrotra, and then we will request Dr. Chawla to have it.
Yes, Dr. Samir.
So, good evening, everybody. After an intense talk on the lipids as the mechanism of coronary artery disease, I am going to talk about something which intervenes these lipid plaques, and we are going to talk about stent-free angioplasty, drug-coated balloons. It looks very lucrative, we are moving from the era of human intelligence to AI, but it seems in interventions we are moving backwards. We all started with plain simple balloon angioplasty that was done way back in 1977. Then came bare metal stents, then came drug-eluting stents, then came absorbable stents which failed miserably. And then after that, we are gradually moving back to the drug-coated balloons, so that if we can provide something which doesn't leave its mark in the vessel, that will be really good, especially in the young patients which you get, where you have to leave a stent and a metal for life. So what are the limitations? Before we start this, we should know what are the limitations. Whenever you put a metal stent in the vessel wall, the stent is a foreign body, it is a nitinol or a cobalt chromium stent. There is some vascular inflammation which happens in the vascular wall. There can be hypersensitivity to the metal and the polymer that can lead to acute stent thrombosis. That was more so with the initial first generation stents. It can also cause unequal drug distribution. There can be late occurrence of neoatherosclerosis. Because what happens when you have deployed a stent, there is intimal hyperplasia because you can get restenosis at a later stage, might be 1 to 2 years later. It also hampers future bypass options, because if you have a metal jacket in your vessel from proximal to the distal vessel, and I'll show you one such case, then it's very difficult for the surgeon to open up the vessel and put a graft in that vessel. That is one of the biggest disadvantages when you give a metal jacket to your patient. Then there's a long-term requirement of dual antiplatelets. Well, that is a bit controversial, because with simple angioplasty, nowadays you can even reduce the duration of dual antiplatelets with the newer third generation stents, might be to 4 weeks, even 4 weeks, that is the minimum. It has been seen even after 4 weeks you can shift the patient to a single antiplatelet if required. So that is why came the concept of drug-coated balloons. Mechanical causes why it should be used to avoid the stent related issues, you avoid inflammation. When you put a stent, it's a stiff structure, so it also prevents the vasomotion of the vessel wall. So that is why it allows for uneventful positive remodeling, and you don't want to have stent fractures. We see stent fractures many times when you are inflating the stent, as we were discussing about the calcific nodule. When there's a calcific nodule and you try to expand the stent, sometimes the stent can fracture. And obviously in stent restenosis treatment burden. Clinical, you improved outcome through the long run, interrupting drug-eluting absorber, lifelong 2 to 3% major adverse cardiac events. And you also find it difficult to reduce the antiplatelets if you are using a stent. So once we know that with angioplasty you can use simple balloons, now the question comes, what is the concept of these drug-coated balloons? OCT studies have shown that 40 to 50% lesions treated with drug-coated balloons had a late luminal enlargement at 6 to 8 months of follow-up. Now this is something very important. When you deploy a stent, you get neo-intimal hyperplasia and the stent causes restenosis. When you are giving a drug-coated balloon, there is a positive remodeling and the vessel lumen expands slightly. That is what makes all the difference. What is a drug-coated balloon? It's a balloon catheter, a highly lipophilic drug and a coacting matrix that regulates local drug delivery to the vessel wall. Requirements of successful non-stent based approach for local drug delivery, rapid drug uptake by the tissue, and drug persists into the vessel wall to compensate for the short time. So what happens? It's a balloon which has a matrix, there's a drug attached to it, you inflate the balloon for 60 to 90 seconds, and then the drug is stuck to the vessel wall. It goes gradually, gets gradually absorbed in the vessel wall, prevents the blockage as well as it causes positive remodeling at a later stage. This is a drug-coated balloon. This is the shaft of the catheter. This is the balloon. Balloon has, you can see all these yellow and green dots. One is the matrix coating excipient, that is iopromide, which corrodes the paclitaxel or the other drug whichever is used over the film of the balloon. And this balloon is inflated. Once you inflate it, this drug gets absorbed into the neointima or the arterial vessel wall. Once the drug gets absorbed, it stays there for some time, and that is how you prevent restenosis. So now the question comes, what are the clinical settings where you can use? One thing, you don't want to leave anything behind, preserves future therapy options, maintains long-term patency. In stent restenosis, it decreased. In small vessels, where you find that the chances of restenosis are high, where you don't want to give a stent, then definitely you can try drug-coated balloons. In bifurcation lesions, osteal lesions, or challenging stenting areas, that is also one of the areas where you can use a drug-coated balloon. Indications, the approved indications are in stent restenosis and small vessel disease. Prospective and tortuous indications are multiple indications, bifurcation, large vessel lesions, diffuse long, acute coronary syndrome, high bleeding risk. Now, one important indication is the ostium of a branch vessel, where you don't want to give a complicated bifurcation stenting. In such cases, it is advisable that you can treat the main vessel with a stent and the side vessel with a drug-coated balloon. These are the various commercially available stent-coated balloons, drug-coated balloons. I am not going to discuss the detail. More important is, one is the additive which carries the drug, another is the drug. Drug can be sirolimus or paclitaxel. As of now, paclitaxel is a more established drug. So now with this I am just going to show few cases. This was a 71-year-old hypertensive male CAD, came with acute inferoposterior ST elevation MI, EF 45%. This is the left vein, this is one of the vessels. Here you can see one of the vessels is gone. There is an acute cutoff here. This vessel cannot be seen. Now what we did was, when we saw that this vessel is cut off here, you had two options. Either we put a stent, so if you look at it, we could have the option of putting a stent from here to here, then exposing the stent struts. At this point, we couldn't have taken a stent from this branch to this left main because there was a mismatch in the size of the vessel. And had we placed a stent here, there might have been a possibility we could have compromised the lumen of the main vessel. So what we did, we knew it was a plaque that has ruptured, that has caused an acute heart attack. We just did a drug-coated balloon, and this is what the result we got. See, the artery is opened, everything is fine. It has been, I think it has been 9 to 10 months the patient is doing fine, and as such we didn't get any complaints. The stress echo which has been done 6 months later is totally negative. This was the drug-coated balloon done. Now we come to the second case. 58-year-old male, diabetic, hypertensive, CAD, post-PCI. I think we should stop for the national anthem. I think we should stop for that. Yeah. Continue. Take it. So 58-year-old diabetic, hypertensive, CAD, post-PCI to Ramus intermediate, that was in 23. Acute MI, 25, ejection fraction 40%. This was the vessel, see, this is the left main, and this vessel is fine, the RCA is fine. Now what should be done in such a case? We saw that there was a stent had a restenosis. We inflated the stent with a balloon, normal balloon, and after that, once we have inflated the stent with a balloon, this is what we did. This was a drug-coated balloon we used inside the stent, and this is the result we got. So, no further metal inside the metal. The vessel was opened, the patient has been fine, and he is doing fine. And it also gives us the assurance that since the vessel elongates by positive remodeling, the chances of restenosis are less. This was a 67-year-old diabetic, anterior wall MI, post-primary PCI to LAD. So now this case, this patient had a RCA lesion which we stented later, but first time this patient came with an anterior wall MI, and this was the LAD. It was totally occluded from here. The distal vessel, he was a diabetic, distal vessel seemed to be a diffuse disease. What should be done? We stented the main vessel. This was the stent. Once we stented it, we realized that the distal to the main vessel, we were seeing some disease. At that point, we didn't use a drug-coated balloon. We just did a simple balloon angioplasty, plain old balloon angioplasty, and left it like this. We didn't want to stent this area because the vessel was small in caliber. He was a diabetic patient with diffuse disease. Now what happens? This patient, when we took the patient after 4 weeks for the angioplasty to the left side, right vessel, he comes to us with this tight blockage. I'll show you. See, the stent is fine, but there's a blockage here. Now what to do? This time there was somebody said that you should go for a stent. Now that he has come with a re-stenosis with balloon angioplasty, we decided against that. We just took a simple balloon, drug-coated balloon, and this is the result that we got. See, a drug-coated balloon, the result is this, and the patient has been doing fine. We didn't need to put a stent. We would have put a long stent here, and there it would have increased the chances of re-stenosis in such a case, especially with the vessel size is off. Now this is a very good case. 68-year-old diabetic hypothyroid. He had a triple vessel disease, went to the US 1.5, 2 years back. He had a acute cardiac event, had a surgery, the vessels were bad, calcific. So a Lima to diagonal was done in USA, and they did a hybrid procedure. They did a PCI to left main to LAD and circ, a very good bifurcation result. It was perfect result, left main to LAD and circ bifurcation result. He had a severe mitral regurgitation. They gave him a mitra clip also. That was way back in January 29. Now this time he presented to us with this. The left main, right was this, not very big. It's non-dominant. And graft, there was only one graft you can see. That was to the diagonal. Now the question comes, what should be done? Medical management, CABG, bifurcation, stenting, DEB. Question here was, bypass is out. He had all the comorbidities. Medical management not possible with left main in-stent restenosis. This is not an approved indication. What we did was, since the patient had a single surviving vessel with a ejection fraction that was 35%, we used a LVSS device. This is Impella. We gave him Impella, LVSS device. This is the LVSS device that made the procedure quite uneventful. And after that, we did a drug-coated bifurcation ballooning.
Dr. Samir, can I request you to cut short, please?
Last case, 2 slides. This was important because this is this is not one of the indications which is clear-cut, but in this case, doing a drug-coated balloon with kissing to the left main to LAD and circ, it saved his life. This was the final result. See, no more metal, nothing done to the stents, just did a drug-coated balloon, and the patient has been doing fine with that. So with this, I will not go into the technical details of the drug-coated balloons, how do you do the procedure. But with this, I would like to tell that drug-coated balloon should be considered as an option in patients who have in-stent restenosis, small vessels, or where you find that these patients will do better with a drug-coated balloon rather than giving them metal jacket, especially in the younger population that you are getting. Thank you.
Thank you so much, Dr. Samir, for a beautiful lecture. I am sorry, there are no time for any questions to be asked. Any questions you can ask him in tea time. Thank you.
60,000 स्टेंट के बराबर है सर. The costing is not that different.
Right. Now, I am honored to invite Dr. Naresh Chawla sir. He is graduate and postgraduated from Maulana Azad Medical College, Delhi, DNB in Family Medicine in Maulana Azad Delhi, Medical College, Delhi. He is doing evidence-based medical practice for last 40 years. He is medical leader, former national joint secretary of IMA headquarters, former vice president of Delhi Medical Council, and post president of DMA in Delhi North Zone. His topic is legal aspect in medical practice in current perspective.
Thank you, Dr. Priya. So I'm changing the whole thing, although we are in the midst of a scientific whole day Cardicon, but what I'm going to tell you in next few minutes is going to be very, very important. So dear colleagues, good afternoon. My customary gratitude to the organizers of today's Cardicon, IMA DNZ and Fortis Hospital, for giving me an opportunity to speak on the legal issues in medical practice. Why is legal knowledge important, if at all? Gone are the days when doctors are considered demigods. In the days of Consumer Protection Act, the social media, which is super active, and extremely important, the right conscious people. Kuch galat ho na ho, it becomes viral straight down. In next few minutes, time is short because we have another speaker also, I'll try to make you and your medical practice a little more comfortable, convenient, and without any legal tangles. After all, we all became doctors not for this. We came for a safe, good, helping, noble practice only. So it's my proud privilege to present to you this small presentation for critical evaluation. Why is working knowledge important for a medical practitioner? As already said, in this socially connected and right conscious consumer-centric world, every doctor needs to be aware of legal knowledge apart from the medical expertise, making it the best safeguard against litigation. Every word, please, we are not conscious about these things. I am not speaking legal language, pure simple English. Circumspect about patient intentions, apart from the usual nitty-gritties of body language and patients and attendants. The moment the patient enters your clinic, your nursing home or hospital, you know what he or she may be for. I'm not trying to say that every patient, as you said, is a potential litigant. It is not. I still believe in India, we are ready to say we have a huge population which is still a very loyal and good population. But legal knowledge is very, very important. So I'll have few things to say. Some of you who have had close encounters with any such instance will know it very nicely that every person, every patient who is aggrieved, he has lot many choices. First is Delhi Medical Council in Delhi. So I shall be telling, लोग बहुत डरते हैं डॉक्टर साहब, ये हवा बन के रह गया है, अगले 10 मिनट में मैं इस हवे का डर खत्म कर दूंगा. I'm repeatedly asking, kindly listen to every word. Delhi Medical Council has an excellent complaint redressal mechanism. Every complaint has to go through 3 steps: an executive committee, disciplinary committee, general council, and then the order is passed after careful deliberations, keeping in mind the inherent complexities in medical practice. As we all know, DMC, Delhi Medical Council, was in news for some wrong reasons, but I'm sure its honor will be restored soon. As Dr. Tyagi was saying, apart from Delhi Medical Council, the complainant, the aggrieved patient, has many choices. He can go to National Medical Commission, Consumer Forum, Civil and Criminal Courts, National Human Commission, very powerful, police. So, as we know it, medical practice involves diagnosing, as we do it every day. Legal implications arise when the patient care deviates from accepted medical standards. Doctors are legally bound to provide care adhering to the principles of duty of care and medical ethics. Years back, decades back, you must know that DMC has come into the play only for last 17 years only. And it was brought into the scene by the Delhi government to weed out the quacks. But what has happened? Quacks stay where they are, and we are in the soup. So, what do? We do our medical practice ethically, then we have nothing to worry. So, importance of understanding legal responsibilities of doctors, awareness of legal applications helps prevent legal liabilities and maintain ethical standards, protects both doctors and patients by promoting safe, transparent and fair medical practices, equips doctors to make informed decisions in complex clinical scenarios, encourages documentation and communication as essential safeguards. Recent trends, you must have seen, let me inform the audience here, we are receiving not less than 70 to 80 cases of complaints from the population of Delhi in last couple of years. Say, decade back, it was hardly 10, 15. So people are becoming more aware. Consumer Protection Act, doctors are increasingly facing cases under CPA provisions. Growing role of social media has practically killed us. Something may go wrong or not, we are already in the soup always. Complaints and grievances often escalate quickly online, influencing public perception. You must have seen assaults, attacks, decision given even before any fault is found with the doctor. So we all have to be aware of that. So the use of medical expert testimonies, ये मत सोचो कि कोई वहाँ हुआ बैठा है, उसमें आप ही के दोस्त बैठे हैं, वही डिसाइड करते हैं. And let me inform you, Delhi Medical Council, before it was dissolved, it was one of the best councils, and the conviction rate is not even 1%. So आपको ऐसा डरने की जरूरत नहीं है. So few things like emphasis on informed consent, lack of proper consent. Believe me, 2 words. If I'm asked to comment, I am conclude on my session. 1, informed consent. 2, communication. गलती भी हो गई, बता दो यार, Mr. Patient ये हो गया है. And 3rd is documentation. If you have these 3, you have nothing to worry ever. So I'll just quickly go through my slides. Few words which you must know. In the legal framework, the law of torts is a branch of civil law which deals with situations where a person's action cause harm or loss to another, leading to legal liability. In this context, the context of healthcare, tort law governs cases where healthcare professionals' actions or omissions cause harm to a patient. So we have the Indian Medical Council Act, we have our own Delhi Medical Council Act, we have the Consumer Protection Act, we have the IPC, or now the Bharatiya Nyaya Samhita, we have MTP Act, we have the CR Illegal Exploitation Act, we have the Transplantation of Human Organ Act, we have PC, PNDT, we all know. Who decides? The Jewish perspective. Understanding the standard of care and negligence. The standard of care refers to the level of competence that a reasonably skilled doctor in a similar field would provide. Deviation from the standard of care can result in finding of negligence. So you do not have to be a super performer. You do not have to be a topper. You do not have to be Amitabh Bachchan. You have to be an average skilled person. That's all. So factors considered while determining negligence: the breach of duty, whether the doctor deviated from the accepted medical standards. The jury will look at 2 parameters to decide whether duty to care was performed as per expectations. That is, the reasonable degree of skill and knowledge, reasonable degree of care. Extremely important. One thing is sure, decades back, I used to go to a doctor, you used to go to a doctor, डॉक्टर जो करता था पूछने वाला कोई नहीं था. आज के बाद ये नहीं होगा. You must be aware of one thing, that someone is watching you. That is where we sometimes do flaws. So I already used the word reasonable degree of skill and knowledge. Do not flaunt or display the qualification not recognized by NMC. I see lots of MD medicines calling themselves cardiologists or diabetologists. I think it is not done. A plain MBBS calling herself a gynecologist or obstetrician, it is not done. Although you may do the practice, but you cannot call. We have examples of this type in Delhi where they have been convicted. Do not claim a specialization or super specialization which you cannot back by your organized degree. Never go beyond your knowledge and skill in handling the patient. Balancing these days, I already said that rights. This modern world is suffering with so-called over-rights. So ensure that the patient rights to safety, informed consent, and fair treatment are upheld. At the same time, decisions often acknowledge the complexities and uncertainties of medical practice. May consider whether the doctor acted in good faith and exercised reasoned judgment. So I'll take only 5 minutes more, quickly. So 3 things I already said. Use your judgment. Never think that कोई देखने वाला नहीं है, कोई ना कोई आपको देख रहा है. 2 words which are used: communication and documentation. Expect doctors to maintain accurate and thorough medical records. We see lots of consultants going to a number of places, done a good job, but they don't document. Something goes wrong, they're under sue. Proper documentation serves as evidence of informed consent, clinical decision-making, and follow-up care. Effective communication with patients and families reduces misunderstandings and potential legal disputes. Few cases quickly. Important case, Jacob Matthew versus State of Punjab. In this patient, the patient died due to alleged medical negligence. Defines what constitutes criminal negligence under the section 304A. Gross negligence is severe lack of care or competence that goes beyond ordinary negligence. It involves conduct that disregards the safety of patients, demonstrating a blatant breach of duty. Recklessness, acting with conscious regard. मुझे पता है ये नुकसान हो सकता है, but still I am doing, thinking that कोई नहीं देख रहा. No, the patient has a right to demand, why did I go wrong? Two words I'll use quickly. BLAM. What is BLAM? BLAM is a legal standard used to determine medical negligence. According to this test, a doctor is not negligent if their actions are consistent with a practice accepted as proper by the responsible body of medical professionals skilled in that particular field. I'll not go to the details, but BLAM means कि उस टाइम ये लोग कहते थे आपको मानना पड़ेगा. This is a case which was BLAM versus some hospital in 1957. A patient, while undergoing the ECT, was not given a muscle relaxant. This cannot happen now, but that time it was considered is normal. So the doctor was found non-negligent. Coming back, another word, bolitho. What is this? Bolitho was a 2-year-old boy who suffered from respiratory difficulties. He was admitted in a hospital under the care of a hospital, and despite signs of worsening breathing difficulties, no senior doctor attended to him. He absolutely died. So the negligence was, why did not he get the right service? Another important case, Kunal Saha versus MRI Hospital. In this particular case, the Kunal Saha's wife died and Supreme Court awarded the highest ever compensation. It was 13 crores. So the key takeaway is the case established the importance of accountability, especially in corporate healthcare system. Another case, Subira Kohli versus Prabhavan Chanda. The patient underwent a hysterectomy without proper informed consent. This takeaway is the consent must be voluntary, informed, and obtained from the patient or legal guardian. So quickly, consent, I already used, I explained all this. The exceptions to consent, medical emergencies, unconscious or incapacitated patients, or we may need legal authorization. So what is contributing negligence? If the patient does not comply with suggestions or advice given by the doctor, not taking prescribed treatment, not keeping or following up non-compliance or investigations. So it is advisable to write full instructions on a prescription paper discharge card. Only today in state of Punjab, the High Court said that illegible prescription is one of the flaws. It should be a legible prescription. So where does the burden of proof lie? The onus of proof, आपको गलत प्रूव करने के लिए किसकी जिम्मेदारी है? The patient या attendants की. This burden shifts to defendants, that is doctor, or where there is no free access. Only 2 minutes more. No free access to the patient as an OT or ICU. Another case which highlights the importance of vicarious liability. This case highlights the principle that the hospitals may bear responsibility for the actions of their consultants, especially where financial arrangements indicate a direct service provision, particularly in big or corporate hospitals. So coming to the last thing, doctor's perspective. Where does the doctor go wrong? Doctor faces many challenges. Fear of legal action affecting to defensive medical practices. This has happened already in the developed West, and our own India is becoming a victim of it. Increases instances of patient disrespect and aggressive legal actions, media trials, public perception, difficulty in maintaining comprehensive medical records amidst high record. Concerned कहता है भाई उसे इतना काम है मैं कहाँ दिखूंगा, ये थोड़ा सा गलत है. So already used the word documentation and communication. Important question, don't be lazy, don't be casual. Sometimes हमने कर तो दिया है, patient को शिकायत करेगा. Don't be lazy, do not be casual. Not documented means not done. Sloppy documentation means sloppy care. Communication and transparency, already has said a lot about this. पेशेंट से प्रॉपर कम्युनिकेट करो. कैनॉट से वो तो गांव की जुबान बोल रहा था, मुझे समझ नहीं आया. ट्राई टू टॉक टू पेशेंट इन पेशेंट्स लैंग्वेज, एंगेज द पेशेंट इन डायलॉग. एट द एंड ऑफ कंसल्टेशन आस्क द पेशेंट इफ पेशेंट हैज एनी क्वेश्चंस. वेरी इंपॉर्टेंट. क्या होता है, समटाइम्स व्हाट हैपेंस, वी आर बिजी, मेनी डॉक्टर्स आर बिजी. पेशेंट बाद में बोल रहा था, आप लिखना पहले शुरू कर देते हो. डोंट डू दैट. इंटरप्ट, don't interrupt the patient. Let him or her say the story. Appear to be in a hurry. Even if you are in a hurry, at least let not the patient know. Tomorrow he'll allege, doctor साहब ने ध्यान से देखा ही नहीं था. Start examination and then route out a prescription before patient has finished. Indemnity schemes, we must all have it. Continuous learning, we must all have it. So coming to literally last half a minute. General precautions. Ask for colleagues or seniors advice in difficult cases. शर्माने की जरूरत नहीं है. We cannot be omni-powerful. We cannot be omnipotent. We always need help. Refer early. Keep knowledge updated as we do all. Give guarded preference. Sometimes मेरी कमी दूसरे के पड़ोसी के डॉक्टर से कमी से ज़्यादा सफाई होनी चाहिए. We tend to overdo, overpromise, do not do. Be defensive. Tell the patient the right thing. Maintain records, already said that. Obtain clear informed consent. Stick to your area of expertise. Do not, if अगर गलती से आपके केस फाइल हो भी गया, do not panic. Attend all cases personally. Take due cognizance and reply in time. Inform insurance company. Consult medical experts. There are many. Do not give unnecessary details. All these small things. Final thoughts. While the legal challenges in medical practice are inevitable, understanding legal principles and practicing defensively without compromising patient care can significantly mitigate risks. Upholding medical ethics extremely important. Exercising empathy and maintaining professional diligence are the cornerstones of both good medical practice and legal protection. Ultimately, a well-informed doctor is empowered to provide better care while navigating the complexities of legal system. So, it is not only what we do, but also what we do not, for which you are accountable. Inaction can have as much consequence as a wrong action, as doctors understanding legal responsibility is as vital as medical expertise. Thank you, dear friends. Thank you very much.
Thank you, Dr. Chawla. It is a very extensive topic. You try to cover it up. My request to all doctors sitting here is, please do not criticize your colleague. That is the most important thing. All the legal aspects take place. Issues are there because we tell them, the patient, कि ये चीज गलत हुई है. Please do not do that. You could be there tomorrow. Thank you.
Thank you. Thank you, dear friends.
Good evening, all the dear friends. So now I request all the chairpersons to honor our speakers of the session, of the last session. And we are moving to the session 7. And the session is ECMO and organ transplant. So I invite the chairpersons for the session, Dr. Abhishek Garg, who is a general physician, Dr. Parul Dikshit, who is radiologist at Sachdeva Diagnostic Center, Dr. Veenu Parashar, general practitioner at Ashok Vihar, Dr. Madhu Verma ma'am, she is a senior gynecologist practicing at Vinayak Hospital and Kayakalp. I will request Dr. Madhu Verma to kindly introduce our first speaker, Dr. Sharanya Kumar.
वही कर रहे हैं.
I am honored to call upon Dr. Sharanya Kumar. He is a senior consultant and head and thoracic transplant, anesthesia and critical care at Clean Angels Health City, Chennai.
Thank you everyone. Good afternoon, and thank you Naresh sir for this opportunity. I am just going to talk briefly about the heart and lung transplant as just an essential knowledge, mainly focusing on the evaluation as well as listing and finally the outcomes of these transplants. So heart transplant has seen many of innovations starting with a canine model. Light? Laser pointer? The heart transplant started with a lot of innovation, starting with the canine transplant, followed canine heterotopic transplant, then later on moving into the canine intrathoracic transplant. Finally, first xenotransplant to the human from chimpanzee in 1964. In 1967, first human-to-human transplant happened in South Africa. Over the next several years, there were a lot of poor results. As a result, the transplant program did not grow well until the pioneering efforts of Dr. Shamwe and thank you. Under the Shamwe and their colleagues standardized the management of this cardiac transplantation. And an introduction of endomyocardial biopsy as well as newer immunosuppressive agents such as cyclosporine really brought about that modern era of the transplantation medicine that we see today. The advanced heart failure as defined as a significant cardiac dysfunction with marked symptoms, dyspnea and fatigue with end organ hypoperfusion at rest or at minimal exertion as well as AHA stage D as well as refractory symptoms requiring specialized intervention to manage the symptoms or prolong life. The Intermax profile, the classical interagency profile for mechanical circulatory support, divides into 7 stages. Phase 1 is crash, where the patient is having hypotension and rapidly escalating inotrope. Profile 2 is progressive decline in spite of intravenous inotropic support, whereas profile 3 is stable but continuously inotrope dependent. Profile 4 is where there is resting symptoms. However, patient can be stabilized to normal value, but they experience daily congestion at rest. Whereas profile 5 is minimal exertion also, they will not be able to tolerate. Profile 6 is exertion limited. They don't have any evidence of the fluid overload and comfortable at rest. However, the minimal activities beyond their, outside their home results in fatigue. Profile 7 is advanced NHA where they do not have a current as well as recent episodes of unstable engine. So when do we think of this cardiac transplantation? So patient first of all should receive maximal medical therapy before being considered. Second thing is they should have been considered for other alternative therapy. For example, if there is a chances of coronary bypass grafting or valve repair or replacement, that should be tried or considered first. And then CPET test showing peak oxygen consumption is one of the reproducible way to evaluate the potential for transplant. Anything 12 or ml per kg or less is considered as an indication for heart transplantation. So this is the diagnosis of the cohort of the patients who come for the heart transplant. Most commonly the dilated cardiomyopathy followed by ischemic cardiomyopathy, and this has remained almost unchanged over the various eras of transplantation. A simplified acronym to gauge when the patient requires the referral to a heart transplant center is, one is when the patient is on or previous requirement of inotropes, when there is persistently high NHA class level or high BNB, when there is worsening renal or liver dysfunction, or E where there is very low ejection fraction, recurrent defibrillatory shocks, or at least one hospitalization in past 12 months, or there is a signs of persistent fluid overload or increase in diuretic requirements, consistently low pressure less than 90, or prognostic inability to titrate the GMDT therapies. So I need help will give you a hint of idea that this patient will require referral to an advanced heart failure center. So whenever a patient comes for the evaluation following this I need help kind of symptoms, you do a clinical assessment, imaging as well as right heart study. Once all of these are considered, we will classify the patients into no low cardiac output and low cardiac output states. In the no low cardiac output state, whether there is a congestion and end organ dysfunction. If it is yes, then we will have to aggressively manage and consider listing at a lower status. Whereas there is no severe congestion, but there is an exceptional disease such as hypertrophic cardiomyopathy or amyloidosis or VT strom, then we still consider for transplantation or LVAD implantation. However, even that is not no, then we go only for medical therapy. If the patient with all this evaluation shows to have a low output syndrome, then we try to find out whether there is any contraindication for transplant or LVAD implantation. If there is no, then if the patient is eligible for transplant and LVAD, we list the patient for transplant, but we may initiate LVAD if the patient deteriorates. That means they go up on Intermax scale to class 2 or 1. However, if the patient is eligible for transplant but not for LVAD, there is only one possibility, that is list for transplant. Whereas if the patient is eligible for LVAD but not for transplant, such as severe pulmonary artery pressure, so we implant the LVAD, we may reconsider the transplant later if provided the previous contraindication has been removed. If the patient is eligible for LVAD only, then we go ahead with the implantation of LVAD. This is called as destination therapy. So basically, the principle of the heart transplant evaluation goes through 3 questions. One, is the heart sick enough and there is nothing that we can do to optimize it beyond the transplantation? Next, is the rest of the body doing well? All the other organ systems are at least in the appropriate levels, and whether the patient can adjust to the post-transplant lifestyle, be it medical adherence, abstinence and caregiver support. This is the same general approach to evaluation. The CPET study, CPET values that I was told on patient on beta blocker, usually less than 13 ml per kg is an indication of beta blocker, usually 12 ml per kg of VO2. However, if the patient is not able to reach the RE, respiratory ratio of less than 1.05, then we may even consider peak of ventilation by carbon dioxide slope of more than 35 or peak VO2 less than 50% predicted as cutoff points for registration or listing for transplantation. Simply put, the contraindication mainly severe pulmonary artery hypertension such as PVR of more than 5 or transpulmonary gradient of 16 to 20, PA systolic pressure of more than half of systemic pressure, advanced age, systemic infections, active malignancy, poorly controlled diabetes and end organ dysfunction. Marked obesity is a relative contraindication, severe peripheral vascular disease that is not amenable for revascularization, systemic process with a high risk of recurrence such as amyloidosis and sarcoidosis. Donation, there is a talk for donations, so I will just skip this part. Whenever we get a donor call and all, the matching is pretty important because ischemia time, an ideal ischemia time for a heart transplant is ideally less than 4 hours. So not just about a HLA type of matching, but we also need the appropriate ABO matching, any elevated levels of PRA, donor to recipient ratio should be between 75 to 125, geographic location relative to the donor and length of time at the current status. However, if the patient has a little higher PRA, then patient may require plasmapheresis, immunoglobulins or immunosuppressive agents prior to the release of cross clamp. Standard bicaval approach is what we use, where superior vena cava and inferior vena cava are separately anastomosed instead of the biatrial approach which was done previously. This is the Kaplan-Meier curve for 12 years, for the 12 months of post-transplant. And this is the long-term follow-up of the heart transplant patient with the outcome showing 1 year survival of 80% and a median survival post-heart transplant of 12 years. Typically, the cause of death in the first year is due to the acute rejection. After first year, the primary cause is vasculopathy, CAV. However, in the later stages, arrhythmias can also be a sign of rejection. So, there is a similar survival between men and women. The lowest survival among this cohort is very young and extremes of age. Next topic is the lung transplant. So, placing a patient on a list should be exposed to the risk of transplant surgery when only the viable treatments have been exhausted. The most common indication in the West is idiopathic pulmonary, is the COPD followed by idiopathic pulmonary fibrosis, whereas we do get pulmonary fibrotic cases as the maximum. So, general consensus is if patient has a risk of death more than 50% within 2 years if not transplanted, and there is a high likelihood of 5-year survival provided there is adequate graft function. Simply put, the contraindication include lack of willingness, malignancy, other organ failure, active infections, psychiatric diseases, and poor post-rehabilitation potential. These are the various risk factors which carry the worst prognosis following the lung transplant. When to refer? In cases of ILD, individual disease wise, if FVC falls less than 80 or DLCO less than 40, or there is functional limitation or worsening oxygen requirement. In COPD, progressive disease, despite maximal therapy, board index of 5 to 6 or increased by 1, elevated PaO2 and PaCO2, FeV1 less than 25%, whereas in pulmonary hypertension with class 3, class 4 symptoms with escalating therapy, as well as use of any parenteral targeted pH therapy or suspicion of pulmonary veno-occlusive disease or pulmonary capillary disease. Last one. So this is the transplant window where you can see the time course of the pulmonary disease as well as the advancing of disease, gradual worsening of the symptoms as well as beginning of oxygen therapy probably is the transplant window. However, once the patient goes to respirator or ECMO, it probably might be late for the majority of the patients. Due to the time concern, I will stop the talk. Thank you very much.
Now I am honored to call Dr. Vishal Garg, Principal Consultant, Cardiac Anesthesia. He has more than 15 years of experience in cardiac anesthesia. Vishal Garg has trained and worked at one of the most premier hospital in UK, gained knowledge in ECMO, heart-lung transplant, anesthesia and pediatric cardiac anesthesia, along with cardiac intensive care. He is also an AHA certified BLS and ACLS instructor.
Oh, sorry, I will take just a minute. I request Dr. Bhatia, our president, to honor Dr. and Mrs. Lal Chandani, Dr. Prakash Lal Chandani and Dr. Deepmala Lal Chandani. Please come to that. No, start, sir.
Okay. Thank you, sir. I would request the clock to be reset, please. Good evening, everyone. Thank you for inviting me here at Cardicon 2025. I thank IMA DNZ and Dr. Naresh from Fortis Hospital, Shalimar Bagh. Artificial intelligence, does that sound a buzz? Well, this is not my topic, but in today's world, wherever you go, this is the buzzword, artificial intelligence. Similarly, when we talk about critical care or critically ill patients, artificial life support is the buzzword. And how do we achieve it? ECMO is the answer for providing artificial life support. So this is what I'm going to discuss in the next 10 minutes or so, the role of ECMO in managing critically ill patients. So what does exactly ECMO do? It's a life-saving technology for severe heart and lung failure. Basically, you are providing prolonged cardiac or respiratory or both supports to the patient who are critically ill. ECMO stands for extracorporeal membrane oxygenation. It's an advanced life support technique. It would provide us time for organ recovery, decision making and preparation for organ transplant if the patient is fit enough. Just think of an ECMO as an artificial heart-lung machine which is kept outside the body. So the pertinent question after knowing what ECMO does is when to consider it. Now there are a lot of scales, lot of formulas where you can put in and decide whether your patient would benefit from it or not. But I don't want to bombard you with all those. There is already enough to remember in life. So only two things I would like you to remember. Either the heart or the lung or both of them are failing, or they are expected to fail despite all our conventional treatment. That is where you would want to consider ECMO. So I'm just going to illustrate this by quoting certain cases. All of these cases which I will be discussing are the ones we have done at Fortis. The presentation is gone. They're trying to open it. Okay, thanks. So I would just discuss few cases which we have done. So this is a 45-year-old male who came with a 3-day history of breathlessness with fever. He needed mechanical ventilation as soon as he arrived at the hospital. CT chest was done, which showed bilateral diffuse ground glass opacities. A working diagnosis of acute viral pneumonia was made. And subsequently, he had increasing ventilatory requirements. Prone ventilation was established. Despite all this, he was hypoxic, and quite obviously he was in ARDS with severe pneumonia. So what do we do next? Do we wait for his lungs to recover, or just let the natural progression take its course? This is another case, a 15-year-old girl, a known asthmatic. She was on regular treatment, but now she is presented with acute exacerbation of asthma. Saturation is less than 80%, even on high flow nasal oxygen. Mechanical ventilation is initiated. Despite all medical measures, magnesium, steroids, propofol, everything, she continues to be hypoxic. Patient continues to be deteriorated. She is in status asthmaticus. What should we do next? There's another patient. He's a 35-year-old man, a known case of interstitial lung disease, on home oxygen therapy. He's on a lung transplant waiting list. Now he's admitted with acute dyspnea. His ABG shows severe respiratory acidosis. HFNC and other supportive therapies have been initiated, but he continues to worsen, and we know that mechanical ventilation is not going to be of much help here. So what are our options now? In all these three cases, the diagnosis is that the lungs are failing, the failing lungs, and the answer is ECMO support. So the modality which we can offer to these patients is veno-venous ECMO, which will provide only the respiratory support. So we take out the blood from inferior vena cava, deoxygenate, put in the oxygen, take out the carbon dioxide, and put it back in the patient, providing him more time, provide time to the organs to recover, give us more time for decision, and keep him fit for an organ transplant if he is eligible. Similarly, now there was a 30-year-old lady. She was admitted with acute dyspnea. Echo was done, showed dilated heart chambers, diagnosis of dilated cardiomyopathy was made. She was hypertensive, so started on inotropes and vasopressors, but still she was not able to maintain her hemodynamics, going into multi-organ dysfunction. Family is ready for any treatment. So can we help her? We cannot keep on escalating the inotropes. It's not going to be of any use. Another patient, a 50-year-old man, came with acute STEMI. Angiography was done, 100% occlusion of LAD. PTCO was done. He was still in cardiogenic shock. Inotropes, IABP, everything was done, but continued to be in low cardiac output even after 6 hours. And now is gradually going into multi-organ dysfunction. So what are our options now? Another patient brought to ER, 50-year-old, reasonably young, in gasping state, needed mechanical ventilation, had a history of taking large doses of antidepressive and psychiatric pills. So probably a suicide attempt. Inotropes and vasopressors were needed for hypertension. Echo was done, showed severe LV dysfunction, and patient is now going into MODS. And we know that this is drug-induced problem which is temporary. But can the patient sustain that? Do we have time for that? What should we do next? Another patient, previously healthy, admitted to ER with non-recordable BP. Few days of history of fever, fluid resuscitation, inotropes, vasopressors, mechanical ventilation, everything has been done, but continues to have worsening acidosis. Ejection fraction is only 15-20%. A working diagnosis of severe septic shock with multi-organ dysfunction syndrome is made, and now we need to strategize what should we do next. Another patient, 70-year-old, is known case of coronary artery disease. He's got some LV dysfunction. He's a CKD patient as well. Admitted now with prostatic abscess, which was drained, and as a result of which he has gone into florid sepsis with shock. So all conventional therapies, inotropes, vasopressors have been started. He's not maintaining blood pressure. Family was counseled, but they want all treatment options to be exercised. So can we help him? Now, in all these cases, the diagnosis is failing heart. So heart is not able to cope up. We need to give more time to the heart to recover. We need to give time to the patient. We need to give time to the antibiotics to work. So the answer is, again, ECMO support. And the modality here which would work is a veno-arterial ECMO, which provides complete cardiorespiratory support. So basically we would take out the deoxygenated blood from the venous system, oxygenate it and put it back into the arterial system, and the pump will also help maintain the blood pressure. So the key to the success of ECMO is in the time of initiation. We cannot wait till the end organ damage has occurred. There is irreversible damage. We should time our initiation much before that so that we can give time for the organs to recover. Worldwide, the outcomes of ECMO are very good. Neonatal ECMO survival is best, which is around 70%, because they are mainly respiratory cases. Adults with ARDS have a survival of 50 to 60. Cardiac ECMO has survival of about 30-40%. And after COVID-19, the use of ECMO has dramatically increased. I would like to share our data at Fortis Shalimar Bagh. We have done almost 28 ECMOs in the last 4 or 5 years, out of which 21 have been the VA ECMOs and 7 have been VV ECMOs. So I'm very proud to say that we have been able to successfully help 19 of these patients, 15 of which were successfully weaned from the ECMO, and 4 were a bridge to transplant or an LVAD. Future of ECMO, it lies in minimizing the hardwares so that portable ECMO is possible. More and more AI, artificial intelligence, is coming in monitoring and prediction of survival, and the use of ECMO is now started in the eCPR as well. When you're doing CPR and you're not able to resuscitate the patient, that is where you go in and put in the ECMO. Just last slide, few take-home points. So ECMO is a bridge to recovery, a transplant or decision. It's a high-resource, high-risk intervention. It requires specialized expertise and centers to do it, and it can be life-saving when all else fails. Thank you so much. This is our ECMO helpline number. If any of you encounter such a patient who you think is failing heart, lungs, or both, just call us and we would be able to help you. Hopefully, yes, and we would be able to help the patient as well. Thank you.
Thank you, Dr. Vishal Garg. That was really nice. You're treating the patient between life and death, I think.
Try to help, ma'am. Yes. Thank you.
Thank you.
Thank you, Dr. Vishal, and Dr. Sharanya has to leave. And the third session, we have requested the Noto persons, but the Noto was not able to come, so they have sent their representative. So they have also come for this organ donation awareness, and then we can have a question, or we can have a question before if anybody is interested on ECMO. ECMO and the heart transplant, basically this session was being kept for that awareness of the critically ill patients, what can we do and how can we do and take care of these patients. We have seen at Fortis Hospital Shalimar Bagh, as Dr. Vishal has shown the experience of ECMO in a very critically ill patient, and as he has shown our cases, almost you can say that if they would not have been on ECMO, their survival would not have been more than 24 hours. I think you can ask for the next speaker.
Third speaker.
So we request that उनके representative आए sir.
So we can call the representatives. They can come.
Just a 5-minute awareness about the organ donation awareness.
Yes,
because
please.
we are facing the heart transplant, as Dr. Sharanya has discussed about the heart and lung transplant, but we need the organs and they can't be manufactured. So we need to donate somebody that what we can do, and this is a very important social gathering for us for the organ donation to make them aware wherever any critical ill patients, they can motivate and donate this organ. So I request Sureshji or their team to have a few words over that organ donation if they can guide us.
Good evening, everyone. डॉक्टर्स के हाथ में हीलिंग पावर और सोसाइटी के हाथ में डोनेटिंग पावर. On behalf of Agam Sharif and Lions Club, it is my honor to speak on the topic organ donation, bridging gap between demand and supply. डॉक्टर्स आप सब जानते हैं कि हर दिन हजारों पेशेंट ऑर्गन ट्रांसप्लांट की वेटिंग लिस्ट पर होते हैं, बट द सैड ट्रूथ इज दैट डिमांड बहुत ज़्यादा है और सप्लाई बहुत कम. ये गैप सिर्फ एक नंबर हजारों का ही नहीं, ये एक जिंदगी का सवाल है. द रीजन फॉर इट्स आर सिंपल: अवेयरनेस की कमी, मिथ्स एंड मिसकंसेप्शन एंड वीक प्लस कल्चर. बट सॉल्यूशंस आर आल्सो सिंपल: अवेयरनेस, काउंसलिंग एंड कलेक्टिव एक्शंस. डॉक्टर्स, यू आर द मोस्ट ट्रस्टेड वॉइस. आपकी गाइडेंस एक परिवार का डिसीजन बदल सकती है. आपके सपोर्ट से ये मिशन एक मूवमेंट बन सकता है. इमेजिन कीजिए अगर हर पेशेंट को टाइमली ऑर्गन मिल जाए, एक माँ के आंसू रुक जाएंगे, एक बच्चा दोबारा से खेल सकेगा, एक स्टूडेंट दोबारा से देख सकेगा. सो लेट अस प्लस टुडे. आई रिक्वेस्ट ऑल ऑफ यू, प्लीज स्टैंड अप, रेज योर राइट हैंड straight and speak with me. Please stand up. We hereby declare our intention to donate our eyes, skin and organs after death for the purpose of transplantation and saving life. Thank you. Please be seated. With your support, our mission, Anga Dan, Jivan Dan, the truth gifts of life, will surely become a reality. Thank you. Dhanyavad. Jai Jinendra. ठीक है जी, ठीक है. हाँ, ठीक है, ठीक है. हाँ, ओके. अब बिल्कुल सर, नहीं नहीं, देखो ये मिनिस्ट्री ऑफ हेल्थ ने, हाँ हाँ बताओ.
Sir, nowadays pledging is basically awareness. It's not that you have pledged and if your relatives are refused, they have a right to refuse. And with your pledge only, nobody is going to take the organs. It's just for awareness. And nowadays the pledging is, the central government has made a registry or the notice of the hospital, and it's online. The previous we used to get the forms filled and they are not accepting those forms. That nowadays the pledge is registered with your Aadhaar number, mobile number, and then you get a certificate that you have pledged it, and that number is saved with the noto. And secondly, in Honorable PM has discussed this thing in Man Ki Baat also, and we have also requested to put it on driving license, so that if anybody pledges their organ, so that can be signed on the driving license whether you want to pledge it or not, so that everybody whenever they carry it, because that is the biggest epidemic in our side is the traffic accidents where you have the organs for these things. And secondly, I'll just take 2 minutes again to discuss about those organ donations. What we are discussing is not after death. What we need the organs as a heart and lung is after brain death, where the circulation death has not arrived or has not achieved. So it is the point where the brain death, these are 8 organs can be donated: 2 lungs, heart, 2 kidneys, intestine and pancreas. So these are the 8 organs that can donate. And secondly, after death you can donate the eyes, as well as the skin donation is very much in demand. You can call up the Sutherland Hospital, they send their team, and they also take a very brief piece of skin that required for the burn patients. So as an eminent member of the society, there any sick patients, they comes to you, take an opinion, what should we do? Should we keep them on ventilator or should we switch off the ventilator and take them home? I think this is our duty to motivate them at that time for the organ donation. That's how we are going to supplement, because if you remember any person whose life on the kidney transplant patient awaiting list on going for alternate day for the dialysis, they don't have a very good quality of the life. If you imagine every other day they have to go for dialysis, one person has to accompany them, every quarter they need hospitalization, they don't have an organ to receive an organ. But if anybody cadaveric before death, if they donate their organ, so 2% will get this kidneys and that heart and lung transplantation also. Thank you, sir. thank you Agamshri Foundation for giving us the time to discuss about these things. They have a organization and they have a stall outside. You can have a further discussion.
So now I will request chairpersons to honor all our speakers towards the right side of the stage. With this, we end this session.
Thank you so much.
And we will have one lucky draw. I will request Dr. Atam to take out the lucky draw. Oh, एक मिनट, एक सेकंड. एक सेकंड. I will request Dr. Gangwal to please honor our speakers along with the chairpersons of the session. Next.
So we will proceed to our next session, which is modern imaging in coronary artery disease from echo to angio. And to chair this session, I'll request upon stage Dr. Atam. He is a senior surgeon at Atam Nursing Home and Joint Secretary at IMA Headquarters. Dr. Chawla sir, please proceed to the stage. I think we do not need to introduce him again. Dr. Karan Malhotra is Medical Officer at Ministry of Education, Government of India, and Assistant Secretary at IMA DNZ. Dr. Abhishek. Dr. Abhishek, are you there? Is the past President IMA DNZ and a practicing physician. So request the chairpersons to start the session, please.
I'll take a minute to just briefly introduce the session. See, a lot of time the persons do ask me, Dr. Sahab, kaun sa angiography कराएं? Can we avoid the invasive angiography or the conventional? आजकल CT scan से भी हो जाती है. And everybody is scared about coronary artery disease. It is a rising epidemic. So we have 2-3 modalities like an echocardiography, for which we have an eminent speaker, Dr. Rakesh Gupta. We have a CT coronary angiography. We have a conventional angiography. We as an interventional cardiologist, our bread and butter is to do the conventional angiographies. But probably after this discussion, we will be in a better position to say what exactly is required for that particular patients. So friends, this is a very important topic where we are going to discuss and to be concluding that in which patients, what modality would be the better opinion. Over the chairpersons, please.
Good evening, friends. So now I invite the next speaker, very eminent speaker, Dr. Rakesh Gupta, please. Dr. Rakesh Gupta is a Director and Chief Cardiologist of Echo and Color Doppler at Jharkhand Institute of Echocardiography at Ashok, and a very dear friend.
Thank you, chairpersons. Thank you, dear friends, Dr. Naresh Goyal, friends and delegates sitting over here, the fag end of a day. Well, coronary artery disease is unbelievably rising by leaps and bounds every day, and the question which is pertinent to us is what should we do in next 10 minutes time. I'll try to prove my message, what is required as on today in the circumstances. I'm here in Europe. We are doing a lot of echocardiography, more than 600 to 800 echoes every month. And we have a state-of-art equipments, the best in the world, and the best diagnostic facilities we have in echocardiography. We are not only doing echocardiography, we are doing teaching in echocardiography for the last 25 years. We just celebrated our Jashn-e-Jarab of echo teaching in 17th August. If you look at the ischemic cascade, what exactly when the patient present is either EC changes, angina or myocardial necrosis. If you understand the chest pain, what kind of a chest pain patient present? Look, many of us sharp, fleeting, shifting, pleuritic, positional, they are not the real kind of a chest pain. If you look at the history, chest भारी हो जाती है, central pressure develop हो जाता है, जब मैं चलता हूँ तो थक जाता हूँ, and that is the most important take-home message, the characteristic of a chest pain which is very important to diagnose coronary disease. That is symptomatology. If a patient presents with an ECG, that's what the ECG is. You look at the ST elevation in these ECG with reciprocal changes. This is a ECG just at the onset. This is few hours down the line. And if you make this diagnosis, it means the patient has already suffered with infarctions. What are the specific signs for arresting ECG? We look at their hypokinesis. Hypo means less contracting endocardium. Akinesis, almost nil contracting endocardium. And dyskinetic means outbulging endocardium. These are the cases who have established coronary artery disease, and the same patients, they develop LV dilatation over a period of time. It means they have already established a significant disease. This is one picture of a patient where the patient does not have a wall motion abnormalities but has got a significant mitral regurgitation. Why? Because the tenting effect of papillary muscle due to ischemia is completely gone. And next is, we have a complications of myocardial infarctions, ventricular septal rupture and a free wall rupture. These are dire emergency where we have to rush like anything for echocardiography in management issues. How does echo help? We look at an ECG, we make a particular territory, which particular territory is infarcted. Is it a right coronary artery, left coronary artery or circumflex? And then we look for severity and progression along with a few complications which we have seen. This is what when the patient has suffered. Now the question is, how do we see a patient who talks of a chest pain and one not really sure what to do with the subject? And that's what is seen by this slide, which is almost 50 years old down the line. If you have a stenosis which is more than 90%, you have a resting wall motion abnormalities. If you have a stenosis between 50 to 70, that's most of the patient present with, and that's where we chip in with stress echocardiography. And if you look at this paper, it says that catheter-based angiography is a gold standard for diagnosis of obstructive lesion, but it is invasive, costly is technique, but the most important thing is non-acceptable everybody. So what do we next? The next answer is we have a stress echocardiography. That is what functional imaging is. Then we have a nuclear imaging, then we have positron imaging technique, and finally the CT coronary angiogram versus invasive coronary angiogram. In today's circumstances, either you talk of a stress, you talk of a CT coronary angiogram or a conventional angiogram. This is a paper published from October 21 in European Heart Journal saying that this stress echo has evolved into one of the leading diagnostic tools for assessing coronary artery disease. Why? Everywhere available, portable, low cost risk, avoidance of ionizing radiations. And most important thing, it tells you a territory which is involved in this particular subject. And it can be performed during exercise, gives you wall motion abnormalities, gives you STT changes, tell you about LV dilatation, and on top of that, it really tells you that this is one modality which is confirmed as a class 1A indications in this European Heart Journal in 2021. So what we need to do is, where we do, anybody whom we suspect a coronary artery disease, and this suspect goes on the kind of a pain this patient has got it. Many of the patients says, चुभन होती है, मीठा मीठा दर्द होता है. These are negligible signs, not looking for a stress echocardiography at all. And then whom should we subject? Anybody who talks of these kind of symptomatology. And this not only tells you about ischemic burden, it tells you many other factors in the echocardiography. It tells you about the cause of dyspnea. It tells you about elevated pulmonary artery pressures. It talks about LV, EDP, and we assess aortic and valvular lesions for their symptomatology based on this. We do this for prognostication of hypertrophic cardiomyopathy. One person was saying calcium scoring. Have you ever looked for our aorta? We find number of times calcified aorta. Is not that abnormality? Calcified aorta means significant inflammation leading to deposition of calcium. And this is one paper talks about if you have a calcification of aorta, there are more than 50% chances of having a coronary artery disease. Negative point is avoid dissection of aorta, avoid pulmonary embolism. That history can tell you. Next question comes, who should do it? That's the most important thing is at least level 2 trained echocardiographer or level 3 with expertise in echocardiography. And post recording should be done in less than 1 minute. That's the most important echo messages. And on top of that, the equipment with which we should do it, it's a quadruple screen display for analysis of stress echocardiography and we use 16 segment model for this particular phenomena. Either we can do by exercise or we do a dobutam in echo. Look at the setup. Here is a treadmill. here is a couch. This hardly takes about 8 to 10 seconds to shift the patient to a particular couch. Now, this is a format of our own lab. It talks of various parameters apart from wall motion abnormalities and give you a final report in this particular formats. Then, positive response, no ECG changes, no wall motion abnormality. Sorry, negative response. Positive means you develop a wall motion abnormality, fall of ejection fraction, develop an MR, increase LV volumes, thinning, and fall of TAP set, tricuspid annular systolic excursion, to talk about RV. Now the question comes, what is the strength of echocardiography? Ubiquitous, always available everywhere, but only two important things is you have to have a good machine, man behind the machine, and the analysis software also. Indian Academy of Echo Delhi branch is coming out with accreditation lab of Indian Academy of Echo, where they'll talk of level 1, level 2, level 3 accredited centers for doing echocardiography. Problem with this particular modality is only one, it has got a low sensitivity. Look at this sensitivity, almost 50%. And specificity, if it's positive, it is positive. If it is negative, it means we are still missing a lot of people who are having a coronary artery disease. This is what is the next topic, CT versus coronary angiogram. I would like to spend this particular word. The assessment of wall motion in stress echo is a gold standard with high specificity, low sensitivity. And that's where CT tries to make a difference. Look, we can give you a luminal stenosis which echo cannot give it. And that's what the question of low sensitivity. I can tell you, we can obliterate this complete low sensitivity in this paper published in 2025, just a few months back. Look at the carotid plaque associated with 10 years major cardiovascular event in low intermediate risk people referred for general cardiology clinic. And these people, when they looked at, this is no plaque versus more than 2 score plaque. And when these people were looked, significant difference in major adverse cardiac events. Another paper, evolution of stress echocardiogram in the era of stress angiogram, and they looked at the carotid plaque at the same time for 10 years major adverse event. And here is a graph, positive stress echo and score more than 2 of a Rotterdam score, talking of we can give an excellent sensitivity and specificity. And where it will be available? Inconclusive stress echocardiography. Negative, forget about it. Positive, forget about it. And here we are going to chip in for carotid plaques. And my submission is, if we incorporate the stress echo with plaque score based on Rotterdam plaque study, we can really increase the sensitivity of this stress echocardiography, especially in inconclusive study patients. And there we are talking about all this. In conclusion, less than 1 minute time, ubiquitous nature of mobility, cost effective, non-radiation modality, and the most important thing you can tell a patient, look, this is a result. Trained manpower, equipment is the most important thing. Low sensitivity, that's a negative thing. However, can be offset to a large extent by carotid plaque evolution. Significant relation with coronary artery disease. Two important issues learned in last 39 years of my career. If patient has got a symptomatology, if ECG is normal and echo shows a wall motion abnormality, take my home that this person is suffering from a significant coronary artery disease. Thank you very much for your patience hearing. This is what the friends are.
Thank you, Dr. Rakesh. We know you practically as if in Delhi you are an institution, not only yourself, but practically training lots of new echocardiographers. You do it too well. If there are any questions from him, we should be able to answer. Thank you, Dr. Rakesh.
Thank you very much. I'm open to questions, and I like to leave because our training program are getting recognized by IP University for these training programs.
I know you were doing this role ever since I was president of DNZ in 1997. So you're doing it for more than 2 or more decades, I believe. Thank you very much.
Thanks a lot.
So next speaker is Dr. Ankesh Kumar Agarwal. A big round of applause for Dr. Rakesh Gupta. Now, next speaker is Dr. Ankesh Kumar Agarwal, who is a senior consultant cardiology at Fortis Shalimar Bagh. For more than 12 years experience, he has done his MD in general medicine from Sri Naidu Medical College, Agra, Uttar Pradesh, and his DM cardiology from UMC Surgical Hospital, New Delhi. Over to Dr. Ankesh Kumar Agarwal to speak on looking inside of the arteries, CT versus conventional angiography for CAD. Dr. Ankesh.
Good evening all. Thank you, Dr. Naresh sir, and I am a DNZ for giving this opportunity to speak on this dais in Cardicon 2025. So I am talking on looking inside the arteries, CT versus conventional angiography for the coronary artery disease. In this rising era of coronary epidemics, first question comes when patient present with the chest pain, डॉक्टर साहब किस टाइप की एंजियोग्राफी मुझे करानी चाहिए, CT और conventional? We are having, it depends on the patient perspectives, whether kind of symptoms patient present, whether ECG changes, echo findings. As Dr. Rakesh already discussed about the symptoms of patient, ECG and role of echo in the coronary artery disease diagnosis. So come to the CT. So first question, non-invasive. Patient generally prefers, Dr. Saab, why I should go under invasive coronary angiography, whether we should have other modality of non-invasive. So we are having invasive coronary angiography, angioplasty, this is the bypass. And so nowadays we are commonly having CT coronary angiography. So myths regarding the angiography, heart disease, what is the myth and facts? Angiography we are generally doing with the radial mostly cases in femoral invasive, and the CT coronary angiography which is the non-invasive modes of coronary angiography. So most of people come with the Google ज्ञान कि कोरोनरी एंजियोग्राफी के खतरे और साइड इफ़ेक्ट्स क्या हैं, इस टेस्ट की कॉस्ट क्या है और कोरोनरी एंजियोग्राफी से और क्या और कैसे की जाती है. So is the CT with the dye. This is the common saying, sometimes we think it doesn't happen the way you want, but the thing happen in a good way for you. So which one is to choose or which one is the good for the coronary artery disease evaluation is the matter of discussion today. So let's decide which test is better for which subset of the patients. So CT coronary angiography is an accurate non-invasive mode of coronary angiogram compared to the invasive coronary angiography. CT coronary angiography advised to the patient with a stable chest pain, stable symptoms with the low or intermediate probability of obstructive coronary artery disease patients. However, the comparative efficacy of CT versus invasive coronary angiography in the management of coronary artery disease to reduce the frequency of major adverse cardiovascular events is uncertain. So invasive coronary angiography is the reference standard in the diagnosis of obstructive coronary artery disease that give the definitive obstructive coronary artery disease and help to enable the coronary revascularization in the same setting. However, the elective invasive coronary angiography is associated with the rare but sometimes major procedure related complications. So comparing the CT coronary angiogram versus invasive coronary angiogram, CT coronary angiography associated with the more radiation exposure compared with the invasive coronary angiogram, more time required for the CT coronary angiography, more contrast volume required, almost 100 ml of contrast required, which can lead to sometime renal deterioration. Strict rate control required for interpretation of CT coronary angiography, and sometime imaging modality difficult to interpret in morbid obese patients, inaccurate to assess the severity in heavily calcified vessels. There is inaccurate estimation of obstruction in heavily calcified vessels, less sensitive in patient with the prior stent due to blooming effect of the metallic scaffolds. These are the drawback of the CT coronary angiography compared to the invasive angiography. These are the studies, Scott Hart studies and Promise studies, which shows patient compared with the usual care like ECG, echocardiography versus the CT coronary angiography. Scott Hart trial shows stress echo testing compared with the CT coronary angiography. The strategic study approach is always better. With the Promise study shows as compared with the initial strategy of functional testing like stress echocardiography, nuclear imaging and stress echo, an initial CT strategy in patient with the stable symptoms with the low to intermediate risk profile patient is associated with a similar cardiovascular outcome at 25 months, where the Scott Hart study shows use of CT was associated with a significantly lower incidence of major adverse cardiovascular events, which were defined as a death from the coronary artery disease or non-fatal MI at almost 5 years. So now how to evaluate and which test we should advise? Depend on the patient symptoms. These are the typical cardiac symptoms or atypical chest pain, risk factors associated with the patient with the cardiac already comorbs associated with the patient, those who are high comorbidities, physical examination, ECG changes. So low risk profile patients, those have less than 1% probability of MACE and within the 30 days. The shared decision making, those patients can be discharged from the outpatient OPD, and those with the intermediate or high risk profile, those have ECG changes, biomarker positive, and high probability of obstructive coronary artery disease and heart failure symptom. Those needs to be evaluated further with the either CT coronary or invasive coronary angiography. So, role of the CT coronary angiography in the chronic CRE patients, those are stable, patient with the stable symptoms. This is the first line test for the evaluating patient with the, those without coronary artery disease but stable typical or atypical symptoms or chest pain or angina equivalent present to you. Those patients can be undergo CT coronary angiography. Also, CT coronary angiography is the first line of diagnostic test in evaluating coronary anomaly post-bypass patients to define the graft patency and localization of the graft. It's a reasonable test for evaluating patient with the non-coronary artery disease with the stable symptoms. Those are not for this, CT is the not preferred test for the acute coronary syndrome patient, those with the non-STMI or STMI patients. It's the reasonable test for non-occlusive functional test. If functional tests like stress echocardiography or stress echo or stress TMT test are inconclusive, in those subset patient can undergo CT coronary angiography. Is also reasonable test for patient with the coronary stent. Those are prior stent of larger stents, a smaller stent at the non-bifurcation sites, and the prior cardiac surgery in younger patients with a low intermediate probability of coronary artery disease, excluding coronary anomalies. So these are the different test probability of obstructive coronary artery disease in symptomatic patient according to the age, sex, and symptoms. The patient with the chest pain or dyspnea, man and woman, as the age increases from 3rd decade to 7th decade, probability of coronary artery disease increase in both man and woman. In the chest pain, patients are more probable to have obstructive coronary artery disease compared to the dyspnea. This slide shows the probability of ischemia according to chest pain symptoms, where the typical pain symptoms have high probability of coronary artery disease, where the atypical kind of symptoms, sharp fleeting chest pain, pleuritic chest pain, the low probability of chest pain. So what guideline says? Guideline says to assess the symptoms and perform clinical investigation. If patient supposed to be present with the unstable symptoms, unstable angina, considered for the and quality of life, whether to revascularization consideration or not, whether to continue on medical therapy or patient need, repeat ECG, biomarker, X-ray, echo, stress testing. If patient has low EF and high probability of obstructive coronary artery disease, patient can undergo CT coronary angiography or invasive coronary angiography. These show selective sensitivity specificity of the different tests. Stress echo, stress MPI has good and CT coronary angiography have high sensitivity or negative predictability of to rule out the coronary artery disease, where the moderate specificity to diagnose the coronary artery disease, 78% of specificity with the CT angiography, where the MPI has 70 or stress echo has very good specificity to diagnose coronary artery disease, 82%. So coming to the patient with a stable chest pain without the coronary artery disease, in this subset of the patient, CT coronary angiography is the first line of diagnostic test, and then where the non-conclusive functional tests like TMT, stress echo are inclusive. In those subset of the patient, also CT coronary angiography can be the preferred test. Asymptomatic high-risk individuals, those with the low-risk symptomatic patients, non-coronary artery disease patients, those with the present with the stable symptoms or typical atypical chest pain can undergo CT coronary angiography. Functional imaging test with CT with the functional imaging like FFR, CT FFR, CT myocardial perfusion imaging are the preferred test in those with the borderline lesion like 30 to 70% of the stenosis. This gives the functional significance whether to need to be treated or leave on the medical management. Stable coronary artery disease patient with the post-revascularization with the different stent and post-CABG patients. The stable coronary artery disease patient, asymptomatic high-risk patient may be appropriate in the selective asymptomatic patient, specifically those with the higher likelihood of having the non-atherosclerotic calcified plaque. Other indications of CT angio like non-coronary cardiac surgery. Before undergoing non-cardiac surgery, those with suspected with the symptoms of those can be ruled out with the CT coronary angiography, and also ruling out the non-ischemic cardiomyopathy subset of the patient can be ruled out with the CT coronary. The coronary anomaly in the limited delay imaging in the CT like 60 to 90 second delay, we can image the LA or LA appendage thrombus also on the CT coronary. Myocardial viability assessment sometime, but MRI is better in viability assessment. This is the algorithm which shows which patients should undergo CT or which patients should undergo invasive coronary angiography. Those without coronary artery disease patients with the prior testing, whether there are prior testings are negative, patient can be discharged on medical management. With the prior inconclusive testing, those patients can go CT angiography. With those with the high probability of obstructive coronary artery disease or symptomatic can undergo directly invasive angiograms. Those with the CT angiogram, if CT shows less than 50% obstruction, those can be discharged on medical management. Those with the borderline lesion more than 50%, those can be undergo functional imaging. If functional testing shows significant result, then undergo intervention or invasive coronary angiography. Otherwise, they can be discharged on medical management. Same patient, those with the without any prior image testing, those can be undergo ECG echo stress testing. If they suggest any high risk features, those patient can be referred to invasive angiogram. Otherwise, patient can undergo CT angiogram. Similarly, those with the coronary angiogram prior CAD patients with the those shows non-obstructive coronary artery disease, those can undergo CT coronary angiography. If it's normal, then discharge on the medical management. If shows borderline lesion or high risk feature, those patients can undergo invasive coronary angiography. So coming to the implementation of results in the clinical practice, the evaluation of the coronary artery disease to identify patients who need appropriate revascularization to improve the prognosis or symptoms to respond to medical therapy. Stenosis severity remain the primary arbitral to therapy decision, but more and more data now suggest that the anatomy coupled with the physiological correlation is the better rather than to the direct anatomical. So role of CT guided therapy in the non-invasive evaluation. So CT facilitates the decision making by dividing the patient into multiple informative categories. Negative CT angiography or demonstration non-obstructive coronary artery would generally exclude the flow limiting coronary artery disease and unnecessary invasive coronary angiography. CT seems to be allowed the more appropriate for use of antiplatelet therapy better than the non-invasive like echo or stress echo test. CT with the FFRCT gives the better idea about the functional significance. So my take home is pre-test probability of coronary artery disease in the low or intermediate risk patient or high likelihood in the high risk patient with the invasive coronary angiography. Presentation of the patient is very important. If acute coronary, better to go for invasive. If patient with a chronic angina or chronic stable, patient can be preferred for CT coronary. Coronary CT angiography should be considered as the test of choice in most symptomatic patients without non-coronary artery disease patients. Excellent sensitivity with the high negative predictability rule out the flow limiting coronary artery disease. Prior history of revascularization and PCI has the negative effect, blooming effect of the stent. Body habitus, morbid obese patients, poorly controlled heart rate, inability to hold the breath. These are the drawbacks of the CT. In those subset of patients, invasive coronary angiography would be preferred. So superior doctor prevent the disease, where the mediocre doctor treat the disease before evident, where the inferior doctor treat the full-blown disease. This was saying for the Chinese. Thank you.
Thank you, Dr. Ankesh, for a wonderful talk. Any questions from audience?
Dr. Ankesh, although you have partly answered the question, can CT angiography be used as a screening modality, especially seeing lot many young cardiac deaths we are seeing? So can it be used as a, because we know you already answered the question that for who do not have any history of CAD, we can do it, but can it be used as a screening modality for all across, all executives about 35 years, all executives about 40 years?
In the guideline, there is no such advice. We are jumping to the CT coronary. It's depend on a lot of factors, whether patient symptoms, prior ECG, any markers, any echo. If something suggests to us a coronary, then we can go for CT coronary. Either we can go for calcium scoring, but drawback of the calcium scoring, some soft placa miss, and then interpretation of CT coronary are also important. If suggest patient, then we can go, but not as a routine for screening.
Thank you.
See, CT coronary angio has a very good value for this.
If there is a young patient, say young boy, he wants to get a CT angio to rule out obstruction.
That's what I wanted to
Because
say.
people are afraid.
We are strong family history.
Having very low pretest probability, and he was a scaring. Now somebody has happened कि यार कल मेरे दोस्त को heart attack आ गया, मेरे पड़ोसी में आ गया, बिल्कुल ठीक ठाक था, ना diabetic, hypertensive. So in these subset of patient, probably the CT or structural imaging would really help. And secondly, as Dr. Ankesh has told, suppose a stress echo we do, and Dr. Rakesh Gupta is not here, but if it is negative, you can't decide whether the antiplatelet and statin to be given in these patients. Suppose they have multiple plaques, probably it would be better to do a CT modality for these things patients. And I think it would spare the interventional cardiologist also from the radiation, because if you do rule out the moreover non-requiring intervention patients to do a diagnostic test with the CT, probably you will avoid all these things and you can focus more for the intervention rather than doing a diagnostic test.
Both ways, yeah. Thanks.
Thank you. Yeah, it has a very good negative value. That's what I'm saying. And that's what Dr. Ankesh wanted to tell. If probably you have a CT coronary angio is a normal, that's almost very good proof that you have a normal. But for a positive, the interpretation is also very important. Yeah, the one point which I would like to highlight, the CT coronary angio has to be done with a controlled heart rate lastly, less than 70 per minute, and where the person who is able to hold the breath, and there should not be any arrhythmia. And secondly, the interpretation is also very important. Whereas a conventional angio, you see the live video of that thing. Where in the CT coronary angio, we do come across around, I'll say 25% of the patient who has a significant, or in CT coronary angio finding is altogether different when we do a conventional angio. So the interpretation of a CT coronary angio is very important in comparison, in addition to the clinical context of the patient, in comparison to the conventional angiography, where you see the live video of those conventional angios.
मतलब ये है कि नेगेटिव आ गया तो ओके, पॉजिटिव आ गया तो गो हेड फॉर
पॉजिटिव आगे फिर भी आपको जरूरत पड़ती है, बिकॉज यू कांट डिसाइड द प्लान ओवर द सीटी एंजियो, कि आगे स्टेंट डालना है, दवाइयों से काम चल जाएगा, कि बाईपास होना है, दैट कांट बी डिसाइडेड ऑन सीटी एंजियो.
But at least you are prepared with the stent. You are prepared with the stent. If you are
prepared with the mentality, suppose if shows a single vessel disease with a 80% lesion, you go and the person is also, interventionals are always prepared for putting a stent.
So Dr.
If the patient is also prepared कि हाँ 80% lesion है, so that I will get a stent.
So Dr. Rakesh is not there, but the question was, so many times we see that echo is normal, stress echo is normal, again the patient has changes in the CT.
Yes, sometimes happens.
So it's quite common. So the stress echo.
So I think it is a sequence of investigations rather than saying.
A stress echo has to be done by a very competent person like Dr. Rakesh Gupta. Most of the time what we are doing, there is a mushrooming of echo lab. They are not able to do the proper stress echocardiography, and ideally they are not scoring the images. If you see, they just do within the 5 minutes, they score the images in their mind and compare with their mind only. Ideally they should be stored pre, post and then recovery and then to interpret. Secondly, if you have a balanced ischemia, it might not be detected. Thirdly, the posterior ischemia like left circumflex artery ischemia might not be detected in stress angiography. So in those patients, structural imaging is required. And in structural imaging, Dr. Ankesh has told that where we should do a conventional angio and where we will do a
very rightly, sir. Very rightly, sir.
Thank you.
Thank you, sir.
Thank you. Thank you, chairpersons and the speaker. Please come to the felicitation dais thing. And there will be 3 lucky draws. And there is an announcement after the last session. There will be 2 mega draws. I mean,
mega draw में डालना है.
Last time mega draw, 3 prizes are there. One from the Systolic company, they will also have 3 prizes. So after the last lecture, and this is, next is going to the last lecture. 3 lucky draws we are taking out. Sir, nikalo.
I will draw because I am not a claimant at all. मैंने card डाला ही नहीं.
गर्दन कर देंगे.
Dr. Anil Kumar Gupta.
लो जी आगे आगे.
अरे
मिला के देखो. कैसा है यार? He is a past president यार. Thank you.
डॉक्टर्स फिर चले गए. अनुराग रंजन पहले भी नहीं थे, अभी भी नहीं.
वो अनाउंस कर रहे हैं ना सर. So we are going to start our next session.
सहगल, डॉक्टर वीना सहगल. हाँ, yes.
Our first chairperson for the next session is Dr. Rajiv Bajaj. He is general physician at Shastri Nagar. Next is Dr. Suryakant Singh. He is a GDMO in Delhi Government Hospital.
डॉक्टर नरेश खन्ना.
Dr. J. Aditya Jam. He is orthopedic surgeon.
डॉक्टर हेलियाना.
Max Hospital Shalimar Bagh and Jam Hospital Shalimar Bagh. Next is Dr. Anil Gupta. Sir is a pathologist and blood transfusion consultant.
पीयूष मिश्रा. नहीं, चला गया. चलो.
सर मेरा भी कर दो.
डॉक्टर अशोक तनेजा. नहीं है.
आप बाद में मैं दे दूंगी आपको. आप अंदर बैठो.
नहीं सर. सौरभ भगत चला गया. चलो ठीक है सर. आप चुंझुनू को निकालते हो तो चला गया.
I request the chairperson to be seated, please.
वंदना गुप्ता. डॉक्टर वंदना है भाई. डॉक्टर मधु वर्मा चली गई. डॉक्टर अमित मित्तल.
चले गए.
डॉक्टर ब्रिज बजाज, वो भी चले गए. हाँ है. अरे यार.
Very good, very good, very good.
इसको फेंक दो.
चलिए. I request the chairpersons to kindly introduce and call our speakers.
3 mega draws after this session.
Good evening. There are two speakers now. One is Dr. Piyush Gupta and Dr. Deekchand Chitkara. Now I call Dr. Piyush Gupta. Dr. Piyush Gupta is MBBS from the MAMC Medical College. He is MD Medicine and he has done DM gastroenterology from the Vellore. He has rich experience in various hospitals including Rajiv Gandhi, C.K. Birla Hospital, Jaipur Golden, MGS Sehgal and RML Hospital, G.B. Pant Hospital. And he has awarded so many awards from the IMA as well as travel ground from the APDW. And his areas of interest are the endocrinology, endoscopic procedure, ultrasound guided FNAC and so on. He has large numbers of the publication in both international and national papers. Please, Dr. Ayush Gupta, please go on. Dr. P.S. Gupta, sorry.
Thank you for the warm invite. Thank you, Dr. Nadesh. And thank you, IMA DNC. So my topic for today is MASLD, which is a silent epidemic. By MASLD, we mean metabolic dysfunction associated steatotic liver disease. So we'll shift a little from cardio to liver side. I'll just discuss one simple case. He is a routine patient, a 35-year-old gentleman, Mr. Bobby. He comes to my OPD. He is asymptomatic. He has a height which is 170 centimeters and 93 kgs in weight. He has a BMI of 32. Occasional alcohol intake is there, but it's quite rare. On routine workup, he comes with the cholesterol of 222, triglycerides of 250, A1C of 6%, SGOT and PTR 50 and 103 respectively. On ultrasound, he says he has grade 3 fatty liver and fibroscan is showing moderate fibrosis and severe steatosis. Now what do I do with the patient? This is another case, 60-year-old lady who is a known case of coronary artery disease and post-PTCA status. She is a known diabetic and a hypertensive, presents with hematemesis, managed in casualty initially, and an upper GI endoscopy which shows that she has grade 4 varices, esophageal varices. We did a banding and she is doing well. She has cirrhotic liver on ultrasound. Now what do we do for her? Liver is a very silent organ. It does almost all of its work in the background. It is like a mother in a home. Okay, she does everything and she doesn't get that recognition what she actually deserves. Now on one side we have a very ripe, juicy liver which is with a normal hepatocyte, and on the right side we have a fatty liver with some hepatocytes who have lot of fat in them. Now what happens is, when we take lot of sugars, it is converted and stored as adipose tissue, and it is stored in liver cells. So this when liver cells contain a lot of adipose tissue, they become stressed out. So this hepatocyte is a stressed hepatocyte. Then we keep on taking more sugars, it is unable to take any more sugars. It says, I need insulin, otherwise I won't accept you. So a lot of insulin is required for the sugars to go into the cells. So what happens is, patients continues to have chronic carbohydrate consumption, blood glucose goes up, pancreas has to secrete more and more insulin, for which the cells of the patient become insulin resistant, and they struggle to produce enough energy. Hence, and again more insulin is produced, and patient finally ends up having diabetes. So fatty liver is behind this all. What happens is, it is the reason for insulin resistance. It is the reason for diabetes. When fat spills into the circulation, it causes dyslipidemia, hence resulting in hypertension and coronary artery disease. So this is just MASLD is just a term, new terminology for a non-alcoholic fatty liver disease which we used to use earlier. This is just a fancy description of the symptomatology which we already discussed. Now what was the problem with the term NAFLD? See, the non-alcoholic fatty liver disease, it is actually described by what it is not than what it actually is. It is actually metabolic dysfunction which is not described in the term at all. That is why we needed the change in the term from non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease. Fatty itself is a stigma, and even alcohol limitations were not described in the earlier term. So now, like there is an old saying, a bottle of wine contains more philosophy than all the books in the world. लोगों के लिए जाम में सब कुछ होता है, जितनी गहरी बातें होती है वो उसी से होती हैं, चाहे कितनी किताबें लिख डालो या पढ़ डालो. So this is actually an evolution. Earlier we used to just call it obesity. It changed to fatty liver disease. It changed to NAFLD, hepatic steatosis. In during a few years earlier, it came to MAFLD, metabolic syndrome associated fatty liver disease. Now it is metabolic dysfunction associated steatotic liver disease, MASLD. So in our prescription, you will find MASLD, which is actually NAFLD, which we used to use earlier. So NAFLD was just no or insignificant amount of alcohol intake with fatty liver, and you have excluded other causes like drugs and viral and autoimmune causes. So with metabolic MASLD, we use cardiometabolic risk factors like overweight or obesity, which is BMI of more than 23 in Asian people in our country, more than waist circumference more than 90 centimeters and more than 80 centimeters in women. Dysglycemia or dyslipidemia or type 2 diabetes, that is a pre-diabetic patient or a type 2 diabetes full-blown, or a patient on treatment for type 2 diabetes. Patients having triglycerides more than 150, HDL less than 39 in men and 50 in women, and blood pressure of more than 130 over 85. So if any of the risk factors is there along with the fatty liver, we call it MASLD, as we can see in the flow chart. Suppose sometimes there is liver inflammation associated with MASLD, we call it MASH. That is metabolic dysfunction associated steatohepatitis. Later on it moves on to fibrosis and thereafter cirrhosis. Few people are unlucky and they end up having hepatocellular carcinoma, for which the most common cause as of today is MASLD. So people have come up to their senses and they have termed that there is some fat in the liver. It is called steatotic liver disease. If it is associated with obesity, diabetes, all the cardiometabolic risk factors, we call it MASLD. If it is associated with alcohol, we call it alcoholic liver disease. If it is associated with both metabolic risk factors and alcohol, we call it MET-ALD. So they are just fancy terms which we are using, but we have some clarity now as compared to earlier. What is the prevalence? Right now it is almost 1/3 to 1/4 of the population is having MASLD. It is more prevalent in obese patients and diabetic patients, and especially who are dyslipidemic. By 2030, almost 1/3 of the global population will be having this problem. So it is not a very small issue. It is a big issue. In India, especially along South India, we have almost 50% of the patients having MASLD. There is little difference in urban and rural people. That is, in urban areas we have 53% and in rural we have 30%. But still these are high numbers. Pathophysiology wise we have already discussed, that is, initially it is steatosis per se. It changes to steatohepatitis thereafter, then cirrhosis and HCC rarely. Patient with diabetes, how do we diagnose it? Simple waist circumference to diagnose cardiometabolic profile. Simple lipid profile. This will give you an idea about the metabolic dysfunction. Simple FIB4 test, that is a simple LFT, will tell you whether patient is having, if the FIB4 is quite high, then we call the patient may be having fatty liver. Then thereafter, if you have to confirm it, you can get an ultrasound done or a liver stiffness measurement, that is called a fibroscan or fibrotouch assay. What are the risk factors for HCC, especially in MASLD? As I told you, it is the most common cause. Patients who are diabetic or obese or both, who have an older age, who take concurrent alcohol intake or do smoking, patients who have a FIB4 of more than 3.25 and a liver fibrosis of more than 10. So they are at high risk for developing hepatocellular carcinoma. How do we take care of it? Lifestyle management, that is diet and some exercise. Suppose we do diet alone and we reduce almost 10 kgs of weight. What happens is we tend to lose proteins also. We develop sarcopenia. So that is a big problem. If you tend to gain weight thereafter, you will gain only fat. You will not gain the muscles. So exercises are important, but exercise alone may not take care of the weight loss. So you have to do significant amount of dieting. Use Mediterranean diet, use intermittent fasting, whatever suits a person. But he has to reduce weight based on diet and exercise both. So 10% of the reduction in the weight is more than enough. If you are able to do it almost 150 minutes a week exercises, that is more than enough. So a low carbohydrate diet is the key, because in Indian setup we have a diet which is quite high in carbohydrates. What are the drugs which we have? So is there anything beyond lifestyle? Yes, there is. Recently, resmetirom has been proven to cause reduction in fibrosis, and GLP-1 analogs definitely have a role, like tirzepatide or semaglutide. These are drugs which help in weight reduction. So they definitely go a long way in taking care of MASLD and MASH. Semaglutide has shown significant results. They are still in phase 3 trials. Tirzepatide is also in phase 3 trials, and they have shown significant reduction in fat, reducing liver fat and visceral and subcutaneous adipose tissue volumes. Resmetirom has been approved recently, which has shown in phase 3 trials to improve the fibrosis by at least one stage. It is still not available in India, but it will be coming soon. So this is the new drug which is quite hyped. Nor-UDCA still not approved for MASH, but still has a role which is quite upcoming. Sarcopenia, this is the last point which I wanted to discuss. The main aim of treatment of MASLD is lifestyle modification. As I told you that exercises is the only way to gain muscles. There is no other way, there is no other alternative. So increase in physical activity and healthy diet will only take care of the sarcopenia. Protein intake is quite advised for such patients who are having sarcopenia, and protein supplementation alone without resistance exercises is not effective. So diet alone is not the solution. Exercises also is very important. Vitamin D supplementation definitely helps along with the proteins, so they can be added. So initially I discussed one case, 35-year-old gentleman, Mr. Bobby, presented with asymptomatic but little obese and having raised SGOT-PT. I think lifestyle changes and drugs which I will prescribe him to reduce weight, that will take care of his issues. Second patient will need a liver transplant because she has already ended up having a liver cirrhosis and she has decompensated in form of bleed. So liver transplant is the straightaway option for her. Do not overthink it, just give her that option. At least consider gastroenterologist or hepatologist for the same. I think that's more or less it. सिर्फ लास्ट बात, जिंदगी में बस 2 चीज हैं जिसे सुख मिलता है, निरोगी काया, गुड नाइट स्लीप, बाकी दुनिया रेस्ट ऑफ द वर्ल्ड वो हाफ ही है बस. So, ध्यान रखिए बस इस चीज को. थैंक यू वेरी मच. Yes, sir.
Thank you, Dr. Piyush Gupta.
Thank you, sir.
Jumping the we see in the prescriptions of gastro people, physicians, एक तो UDC है, सब जितना भी फैटी लिवर है सबको लिखा होता है, और सारोग्लिट्जार भी यूज किया जाता है. इन दोनों का क्या रेलेवेंस है और विटामिन ई के क्या इंपॉर्टेंस है?
सर विटामिन, आई विल स्टार्ट विद UDCA. बहुत ज़्यादा रोल नहीं है सर UDCA का, कोई रोल नहीं है सर. मेरी प्रिस्क्रिप्शन पे तो नहीं होता, ठीक है. कभी एक भी प्रिस्क्रिप्शन आज दुनिया में ऐसी नहीं होगी जिसमें लिखा होगा सर UDCA, कभी नहीं लिखा सर. दूसरी चीज़ आपने बताया सारोग्लिट्जार का. सर सारोग्लिट्जार का रोल है सर, फेज 2 ट्रायल्स पास हो चुके हैं सर, फेज 3 ट्रायल्स चल रहे हैं और 52 वीक का डेटा है कि इट रिड्यूसेस इन्फ्लेमेशन सर. सो फाइब्रोसिस का डेटा कंफर्म नहीं है बट इन्फ्लेमेशन का है. सम एक्सटेंट फाइब्रोसिस होती है सर, कम. सो सारोग्लिट्जार डेफिनेटली हैज अ रोल. Other than lifestyle and weight reduction, saroglitazar is one drug which I will prefer. Vitamin E का सर सिर्फ initial steatosis में थोड़ा बहुत रोल है. Some amount of inflammation but no fibrosis role सर. तो fibrosis reversal नहीं कर सकता vitamin E. Even if you give vitamin E, किसी को अगर already fibrosis नहीं है उसको दिया जा सकता है, but already हो चुका है तो देने का बहुत फायदा नहीं है. So वो भी हमारे prescription पे नहीं होता सर. सर फैटी लिवर डिजीज का सबसे प्रमुख कारण है वेट, ओवरवेट होना. अगर हम खाना पीना किसी तरह से लो कार्बोहाइड्रेट पे चले जाएं, चाहे वो ट्रिजेपेटाइड यूज करके चले जाएं, तो भी डेफिनेटली देयर इज रिवर्सल. तो ट्रिजेपेटाइड के फेज 3 ट्रायल्स कहते हैं कि देयर इज सम रिडक्शन इन फाइब्रोसिस बट डेटा इज नॉट आउट येट सर. अभी 2-3 साल का डेटा पेंडिंग है सर. बट डेफिनेटली वेट रिडक्शन जो ट्रिजेपेटाइड करती है उससे फैटी लिवर पे बहुत फर्क पड़ता है. इवन इन्फ्लेमेशन एंड फाइब्रोसिस विल रिवर्स सर. बट प्रॉब्लम विद ट्रिजेपेटाइड कि वो सार्कोपीनिया भी करती है सर. द वेट जब रिड्यूस होता है तो फिर वो प्रोटीन भी लूज होते हैं सर. तो अगर पेशेंट उसके बाद या तो एक्सरसाइज नहीं करता या वेट गेन करता है, दोनों ही प्रॉब्लमैटिक है सर, क्योंकि उसमें वो फैट गेन करेगा, प्रोटीन गेन नहीं करेगा. सो दैट इज द बिगेस्ट प्रॉब्लम विद ट्रिजेपेटाइड. अदरवाइज इट इज अ वंडरफुल ड्रग. आई हैव यूज्ड इन मेनी ऑफ माय पेशेंट्स, दे हैव डन वेल. अगर वो लोग वेट गेन करते तो दैट विल बी प्रॉब्लम फॉर देम. आई डू वार्न देम. नॉट दैट एक्सपेंसिव सर. आज के जमाने में बेरियाट्रिक सर्जरी एडवाइस करते हैं सर, वो तो लाखों रुपए की होती है. एक महीने का 17,000 तो खर्च कर ही सकते हैं.
थैंक यू सो मच डॉक्टर पीयूष गुप्ता.
सर फाइब्रोस्कैन पे एक बार अगर फाइब्रोसिस आ गया, इट्स ए गॉन केस?
नहीं सर, नहीं सर, डेफिनेटली रिवर्स हो जाती है सर. टू सम एक्सटेंट फाइब्रोसिस कैन बी इजीली रिवर्स अगर इनिशियली पकड़ में आ जाए. इफ इट हैज गॉन टू सिरोसिस इट इज इरिवर्सिबल सर, बट फाइब्रोसिस कैन बी रिवर्स सर टू सम एक्सटेंट. यस, मॉडरेट अमाउंट ऑफ फाइब्रोसिस इवन कैन बी रिवर्स. पेशेंट की विल पावर होनी चाहिए और डेडिकेशन होनी चाहिए सर, और कोई दिक्कत की बात नहीं है. अगर अल्कोहल छोड़ देगा तो डेफिनेटली रिवर्स हो जाएगी सर. पतला हो जाएगा तो डेफिनेटली रिवर्स हो जाएगी सर. बस ये करना मुश्किल होता है बट डेफिनेटली हो सकता है. आई हैव गुड नंबर ऑफ एग्जांपल सर. बहुत अच्छी तरह पेशेंट समझ जाते हैं और कर लेते हैं सर. वो दोबारा से रिवर्ट बैक कर जाते हैं. दैट इज द प्रॉब्लम. भारत में तो यही है सर. थैंक यू.
एनी अदर क्वेश्चन प्लीज?
या रोल ऑफ रिहेप्टिन नहीं, मैं यूज नहीं करता बिकॉज देयर इज एब्सोल्युटली नो रोल. मतलब देयर इज नो स्टडी विच सपोर्ट्स द यूज ऑफ इट. यूजली जीपीज के प्रिस्क्रिप्शन पे होता है. आई यूजली एंड अप स्टॉपिंग दिस. UDCA हो गया, रिहेप्टिन हो गया, सब बंद कर देता हूं मैं. मतलब आई डोंट लाइक प्रिस्क्राइबिंग दिस क्योंकि डेटा बैक करने को नहीं है. कोई डेटा होता तो मैं दे भी दूं, थोड़ा बहुत दिया तो भी दे दूं, बट इतना कोई डेटा है नहीं सर. आयुर्वेदिक प्रोडक्ट्स में ये है कि मेरे को तो पता ही नहीं कि क्या है उनके अंदर सर. एग्जैक्टली इतनी मेरी नॉलेज नहीं है सर. लोग कई बार क्या होता है कि क्या होता है, लोग ज्यादा बीमार होकर आ जाते हैं. पेशेंट्स हु आर सपोज सिंपल अल्कोहलिक होते हैं, सिंपल वायरल हेपेटाइटिस होते हैं, दे टेक सम आयुर्वेदिक प्रोडक्ट्स एंड दे come up with so many problems. They come up with bilirubins of 30, 40, 50. मतलब वो ड्रग इंड्यूस हो जाते हैं, मतलब जो एक्चुअल कॉस्ट था वो तो ठीक हो जानी चाहिए था, वो ड्रग इंड्यूस और हो जाते हैं. सो आई एंड अप लिव 52 से सर मैंने कोई नुकसान नहीं देखा आज तक, फायदा हो ना हो. प्लेसिबो इफेक्ट ये सर. विटामिन ई का सर थोड़ा सा फैट कंटेंट कम करती है सर, स्टेटोसिस में रोल है, थोड़ा बहुत इन्फ्लेमेशन में रोल है, बट फाइब्रोसिस में कोई रोल नहीं है सर. बी कॉम्प्लेक्स का तो मैम लिवर पे ज्यादा रोल नहीं है मैम. नो मैम.
थैंक यू डॉक्टर पीयूष गुप्ता, थैंक यू सो मच.
Thank you very much, Dr. Piyush.
Thank
you. Now over to Dr. Jam.
So I would like to invite Dr. Dikshant Chitkara he's a general physician at Skincare Clinic. He's the editor of IMA DNZ. So we would like to introduce the website for the IMA DNZ.
This is the last lecture, only for 5 minutes, I believe. Yes?
I won't take more long time,
only
sir.
for 5 minutes. Thank you. After there is a felicitation of all the organizers and then mega draw. Yes, that is the last one. ताकि कोई भाग न जाए.
So I would firstly like to thank you all for giving me an opportunity for the launch of our website, our official website, imadnz.com. Myself, Dr. Dikshant Chitkara, Editor, Assistant Finance Secretary at IMA DNZ. So again, our legacy dates back to 1982, but with the growing time, we need to take initiatives to come on a digital scale. So we are serving more than 2,600 medical professionals in North Delhi. So I'll be giving over a basic overview of the website. So the purpose of imadnz.com is to connect, inform and empower our medical community, enhance communication between association and members, streamline access to professional resources and updates, a digital transformation in medical practice support, and a professional networking and collaboration platform. So some key website features would be, coming to the homepage, we have made a very minimal design for an easy navigation going into the subpages. So on the homepage, you'll be able to see a basic banner presenting some recent pictures from our recent events and the latest office bearer teams, and a short message from our President, Dr. Praveen Bhatia, and our Secretary, Dr. Naveen Kumar. So next to About Us stage, it consists of brief of our rich history and objective of IMA DNZ. All the memorandums and bylaws are present on the About Us page, and all the past teams dating back to 1982. All the past presidents, secretaries and finance secretaries are available over the About Us page. So there is a special page for doctors directory. Over here you will have an access to an Excel sheet containing all the contact details and the members of more than 2,600 delegates. So next would be the bulletins and circulars. It contains the latest updates about the CME programs, coming conferences or any other medical event, and the bulletin. So we are publishing all the PDFs of the current bulletin, and even it also consists the bulletins of past year also. So according to me, this is going to be the most visited page over our website. It contains all the images from all our events and even the events in which IME DNZ took part for other associations as well. So gone will be the days of waiting on WhatsApp for getting your own images. So to make membership easier, we are also implementing a page for membership for all the new aspirants who want to join IMA. It will be containing all the benefits and application procedure, and a PDF for our application will be available over to print it out. So the benefits and impacts, so it will be an instant access to professional directories and resources, regular bulletin and policy updates, streamlined participation in CME and health campaigns, a direct communication with association leadership, a digital transformation supporting modern times. So moving forward together, what I would like you all to do is to visit imadnz.com, explore all the features, update your contact details in the member directory. If there is any case of omission or any mistake, please contact us office bearers to make those changes. Download the latest bulletins and circulars, register for upcoming CME programs, and most importantly, share feedback to us to improve the platform. Lastly, I would like to thank KLM Labs to sponsor this launch over Cardicon 2025. And I would like to take any questions if there are. or else I would like to call upon the stage all the executive body members, all the past presidents and current office bearers to felicitate the launch, please.
Thank you, Dr. Chitkara.
Please.
Now I request all the speakers and chairpersons to move towards the felicitation desk for the felicitation, and I request all the president and past presidents to be there to honor the organizer.
First of all, I invite all the past presidents. Check. Dr. Naresh Chawla, please. Or Dr. Alish Hatam, Dr. H.N. Gangwal, Dr. Anil Gupta. Sir, please come on the dais. इधर आइए. A CM member, Dr. Handa, Madam Handa, please.
सॉल भिजवा दे. अब बुके, सॉल और बुके. सॉल और बुके भिजवा दे.
सबका ये बात. Dr. Bhatia, where is Bhatia? Bhatia, please honor all the past presidents with the shawl. And Dr. Sunil Khetarpal, Dr. V.K. Arora. Yes, sir. Dr. Girish Tiwari, Dr. Dr. Bhatia कीजिए. Dr. Bhatia सबको. Past presidents को खाली. Past presidents को खाली. भाग. Dr. Anil Gupta, Dr. Handa, Dr. सबको खड़ो रखो. बोलते जा रहे हैं डॉक्टर हांडा, डॉक्टर अनिल गुप्ता, डॉक्टर हांडा को ऑनर करो सर. डॉक्टर मिसेस हांडा, सुधा हांडा, डॉक्टर सुधा हांडा. डॉक्टर अभिषेक, डॉक्टर अभिषेक, अभिषेक जी को डॉक्टर अनंत झा, डॉक्टर अनंत झा, ऑनर करो मुझे, ऑनर करो, आप मुझे ऑनर करो, फोटो तो ले लो मैडम, फोटो फोटो Now hand over the mic to Dr. Mika Modi for honoring all the executive members.
Organizers की मैं. Please, all the past presidents be on the stage to honor the executive members. Dr. Anand Jha. बनाई हुई है. Dr. Anand Jha. मैम आप सर आप लोग अभी 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 बाद में Now it is time to sir please. Thank you sir. Now it is time to felicitate our organizers and उसके बाद मेगा ड्रॉ होगा. तो
next is first is Dr. Anand Jha sir. Please be on the stage sir. Sir आओ. Dr. Bhatia sir, please come on the stage to felicitate the organizers. Dr. Anand Jha, first is Dr. Anand Jha. Then Dr. Anand Jha, आप डॉक्टर परवीन भाटिया सर को कर दीजिएगा. वो आपको देंगे, आप उनको दे दीजिए.
परवीन भाटिया सर को देते हैं.
फोटोग्राफर.
दो आदमी थे तुम लोग, क्या हो गया?
सर आप उनको दे दीजिए.